Chapter 25. Spine Injuries. Introduction. Spinal cord injury is one of the most devastating injuries encountered by paramedics. Unfortunately, treatment options for spinal cord injuries are currently limited, with therapy relying heavily on rehabilitation over acute intervention. Preventive measures directed toward reducing the incidence of primary and secondary spinal cord injuries are the healthcare provider's best option for decreasing the morbidity and mortality associated with spinal cord injury. In Canada, the incidence is approximately 35 new cases of spinal cord injury per 1 million people, or 1,050 people, each year. Approximately 36,000 Canadians live with spinal cord injury. The average age at the time of injury is 32 years, and 80% of patients are younger than 40 years. Spinal cord injuries are classified into 5 major categories: motor vehicle collisions, 35% to 40%, acts of violence, 24.5%, falls, especially in older adults, 21.8%, recreational or athletic activities, especially diving, 7.2%, and other causes, including diseases such as polio, spina bifida, and Friedreich ataxia. The overall in-hospital mortality rate is 7% for isolated spinal cord injury. In the first few months after injury, the mortality is as high as 20%, a rate that increases with age. The leading causes of death for spinal cord injury patients who are discharged from the hospital are pulmonary embolus and septicemia from pneumonia, urosepsis, or decubitus ulcers. Anatomy and physiology. An understanding of the form and function of spinal anatomy, coupled with a high level of suspicion for spinal cord injury, is required to decipher the often subtle findings associated with a possible spinal cord injury. The spine. The spine consists of 33 vertebrae articulating to form the vertebral column, which is the major structural component of the axial skeleton. These skeletal components are stabilized by both ligaments and muscle. Together, these components support and protect neural elements while allowing for fluid movement and erect stature. Vertebrae are identified according to their location as cervical, thoracic, lumbar, sacral, or coccyx. Each vertebra is unique in appearance and, with the exception of the atlas and axis, C1 and C2, shares basic structural characteristics. Components of the vertebra include the vertebral body, lamina, pedicles, and spinous processes. The vertebral body, the anterior weight-bearing structure, is made of bone that provides structure and stability. The pedicles are the stubs of bone emanating from the posterior lateral surface of the vertebral body to the laminae and spinous processes to form the vertebral arch posteriorly. Together they form the vertebral foramen, which houses the spinal canal and spinal cord. The inferior border of each pedicle contains a notch forming the intervertebral foramen. This space allows the exit of a peripheral nerve root and spinal vein as well as the entrance of a spinal artery on both sides at each vertebral junction. The transverse spinous processes comprise the junction of each pedicle and lamina on each side of a vertebra. They project laterally and posteriorly and form points of attachments for muscles and ligaments. The posterior spinous process is formed by the fusion of the posterior laminae and serves as an attachment site for muscles and ligaments. The cervical spine includes the first 7 bones of the vertebral column, and its supporting structures. In addition to protecting the vital cervical spinal cord, the cervical spine supports the weight of the head, and permits a high degree of mobility in multiple planes. The atlas, C1, and axis, C2, are uniquely suited to allow for rotational movement of the skull. The thoracic spine consists of 12 vertebrae in addition to the supporting muscles and ligaments found in the vertebral column. The thoracic spine is further stabilized by the rib attachments. The spinous processes are slightly larger, reflecting their role as attachment points for muscles that hold the upper body erect and assist with the movement of the thoracic cavity during respiration. The lumbar spine includes the 5 largest bones in the vertebral column, and is integral in carrying a large portion of the upper body weight. The lumbar spine is especially susceptible to injury because of this weight-bearing capacity. The sacrum is composed of 5 fused vertebrae that form the posterior plate of the pelvis. The coccyx is made up of 3 to 5 small fused vertebrae. Coccyx injuries, although often extremely painful, are typically clinically insignificant. Each vertebra is separated and cushioned by intervertebral discs that limit bone wear and act as shock absorbers. As the body ages, these discs lose water content and become thinner, causing the height loss associated with aging. Stress on the vertebral column may cause a disc to herniate into the spinal canal, resulting in a spinal cord or nerve root injury. The muscles, tendons, and ligaments that connect the vertebrae allow the spinal column a degree of flexion and extension, limited to an extent by the stabilization they must provide to the spinal column. The vertebral column can sustain normal flexion and extension without stressing the spinal cord. Flexion or extension beyond normal limits may damage structural ligaments and allow excess vertebral movement that could cause spinal cord injury. The brain and meninges. The central nervous system consists of the brain and the spinal cord, both of which are encased in and protected by bone. The brain, located in the cranial cavity, is the largest component of the central nervous system. Its three major components are the cerebrum, the cerebellum, and the brainstem. Together, these contain billions of neurons that serve a variety of vital functions. The brainstem, which consists of the medulla, pons, and midbrain, connects the spinal cord to the remainder of the brain. The brainstem is vital for numerous basic body functions. Damage to this critical structure can easily result in death. 10 of the 12 cranial nerves exit from the brainstem. The entire central nervous system is enclosed by a set of three membranes collectively known as the meninges. The outer membrane, called the dura mater, is tough and fibrous. The middle layer, called the arachnoid, contains blood vessels that have the appearance of a spider web. The innermost layer, resting directly on the brain or spinal cord, is the pia mater. The meninges are bathed in cerebrospinal fluid. The meninges and cerebrospinal fluid form a fluid-filled cushion that protects the brain and spinal cord. The spinal cord. The spinal cord transmits nerve impulses between the brain and the rest of the body. Beginning at the base of the brain, it represents the continuation of the central nervous system. This bundle of nerve fibers leaves the skull through a large opening at its base called the foramen magnum. The spinal cord extends from the base of the skull to L2. At that point, it separates into the cauda equina, a collection of individual nerve roots. A cross-section of the spinal cord reveals a butterfly-shaped central core of gray matter that is composed of neural cell bodies. This gray matter is divided into posterior, dorsal, horns, which carry sensory input, and anterior, ventral, horns, which innervate the motor nerve of that segment. Surrounding the gray matter on each side are three columns of peripheral white matter composed of myelinated ascending and descending fiber pathways. Messages are relayed to and from the brain through these spinal tracts. Specific groups of nerves are named based on their source of origin and point of termination. Ascending tracts carry information to the brain, and descending tracts carry information to the rest of the body. Spinal nerves. The 31 pairs of spinal nerves emerge from each side of the spinal cord, and are named for the vertebral region and level from which they arise. The 8 cervical roots perform different functions in the scalp, neck, shoulders, and arms. The 12 thoracic nerve roots have varying functions. The upper thoracic nerves supply muscles of the chest that help in breathing and coughing, while the lower thoracic nerves provide abdominal muscle control and contain nerves of the sympathetic nervous system. The 5 lumbar nerve roots supply hip flexors and leg muscles, as well as provide sensation to the anterior legs. The 5 sacral nerves provide for bowel and bladder control, sexual function, and sensation in the posterior legs and rectum. The coccyx has a single nerve root. Nerve roots occasionally converge in a cluster called a plexus that permits peripheral nerve roots to rejoin and function as a group. For example, the cervical plexus includes C1 through C5, the phrenic nerve, C3 through C5, arises from this plexus, and innervates the diaphragm. The brachial plexus, C5 through T1, joins nerves controlling the upper extremities. The main nerves arising from this plexus are the axillary, median, musculocutaneous, radial, and ulnar. The lumbar plexus, L1 through L4, supplies the skin and muscles of the abdominal wall, external genitalia, and part of the lower limbs. The sacral plexus, L4 through S4, gives rise to the pudendal and sciatic nerves and supplies the buttocks, perineum, and most of the lower limbs. The sympathetic nervous system. The sensory, afferent, and motor, efferent, nerves are responsible for the somatic functions of the spinal cord, and often overshadow the role of the spinal cord in the involuntary autonomic nervous system. The sympathetic nervous system is controlled by the brain's hypothalamus. Information from the brain is transmitted through the brainstem and the cervical spinal cord, and then exits at the thoracic and lumbar levels of the spine to reach target structures. The thoracolumbar system provides sympathetic stimulation to the periphery largely through alpha and beta receptors. Alpha receptor stimulation induces smooth muscle contraction in blood vessels and bronchioles. Beta receptors respond with relaxation of smooth muscles in blood vessels and bronchioles, as well as have chronotropic and inotropic effects on myocardial cells. The sympathetic nervous system is also responsible for sweating, pupil dilation, and temperature regulation, as well as the shunting of blood from the periphery to the core, the flight or fight responses. Spinal cord injury at or above the level of T6 may disrupt the flow of sympathetic communication. Loss of sympathetic stimulation can disrupt homeostasis, and leave the body poorly equipped to deal with changes in its environment. Stimulation of sympathetic nerves without parasympathetic input can cause sympathetic overdrive, resulting in autonomic dysreflexia. This complication of spinal cord injury is discussed later in this chapter. The parasympathetic nervous system. The parasympathetic nervous system includes fibers arising from the brainstem and upper spinal cord that carry signals to organs of the abdomen, heart, lungs, and the skin above the waist. The vagus nerve travels from its origins outside of the medulla to the heart via the carotid arteries, thus, vagal tone remains intact following a spine injury. When the sympathetic nerves are stimulated and produce autonomic dysreflexia, the parasympathetic nerves attempt to control the rapidly increasing blood pressure by slowing the heart rate. Parasympathetic nerves that supply the reproductive organs, pelvis, and leg begin at the sacral level, S2 through S4. Disruption of the lower parasympathetic nerves in the sacrum results in the loss of bowel and bladder tone and sexual function. Pathophysiology. Mechanism of injury. Acute injuries of the spine are classified according to the associated mechanism, location, and stability of the injury. Vertebral fractures can occur with or without associated spinal cord injury. The spine is divided into a posterior, middle, and anterior column. The posterior column includes all of the posterior bony and ligamentous elements, while the middle column includes the posterior longitudinal ligament, and all of the elements comprising the posterior one-third of the vertebral body, and intervertebral disc. The anterior column is comprised of the remaining portions of the vertebral body, and intervertebral disc, as well as the anterior longitudinal ligament. Injuries with incompetence of 2 or 3 columns are inferred to be unstable. The 3-column theory applies to the thoracolumbar spine only. Stable injuries usually only involve the anterior column, and occasionally the middle column. Unstable injuries usually involve the posterior column, and typically damage portions of the vertebrae and ligaments that directly protect the spinal cord and nerve roots. Unstable injuries carry a higher risk of complicating spinal cord injury and progression of injury without appropriate treatment. Flexion injuries. Flexion injuries at the cervical level result from forward movement of the head, typically as the result of rapid deceleration, for example, in a vehicle collision, or from a direct blow to the occiput. At the level of C1 to C2, these forces can produce an unstable dislocation with or without an associated fracture. Farther down the spinal column, flexion forces are transmitted anteriorly through the vertebral bodies, and can result in an anterior wedge fracture. Depending on their severity, anterior wedge fractures can be stable or unstable. Loss of more than 1/2 the original size of the vertebral body or multiple levels of injury suggest involvement of the posterior column, with increasing risk of spinal cord injury. Hyperflexion injuries of greater force can result in teardrop fractures, avulsion fractures of the anterior-inferior border of the vertebral body. The injuries to ligaments associated with teardrop fractures raise concern for possible spinal cord injury, and qualify as unstable fractures. Severe flexion can also result in a potentially unstable dislocation of vertebral joints. This situation does not involve fracture, but can severely injure the ligaments. Strong forces can result in the anterior displacement of facet joints. A bilateral facet dislocation is an extremely unstable injury. Rotation with flexion. Rotation-flexion injuries often result from high acceleration forces. The only area of the spine that allows for significant rotation is C1 to C2. Injuries to this area are considered unstable due to the high cervical location and scant bony and soft tissue support. Below C2, rotation with abrupt flexion can produce a stable dislocation in the cervical spine. This is a radiologic diagnosis requiring a neurosurgical consultation and cannot be determined in the field. In the thoracolumbar spine, rotation-flexion forces typically cause fracture rather than dislocation. Vertical compression. Vertical compression forces are transmitted through vertebral bodies and directed either inferiorly through the skull or superiorly through the pelvis or feet. They typically result from a direct blow to the crown, parietal region, of the skull or rapid deceleration from a fall through the feet, legs, and pelvis. Forces transmitted through the vertebral body cause fractures, producing a burst or compression fracture with or without associated spinal cord injury. Compression forces can cause the herniation of discs, subsequent compression on the spinal cord and nerve roots, and fragmentation into the canal. Although most fractures resulting from these injuries are stable, primary spinal cord injury can occur when the vertebral body is shattered and fragments of bone become embedded in the cord. Some compression injuries may be associated with significant retropharyngeal edema, and serious airway compromise is a possibility. Hyperextension. Hyperextension of the head and neck can result in fractures and ligamentous injury of variable stability. The hangman's fracture, C2, results from hyperextension and distraction due to rapid deceleration of the skull, atlas, and axis as a unit. The resulting bilateral pedicle fracture of C2 is an unstable fracture but is rarely associated with spinal cord injury. However, if associated with a dislocation at C2, this fracture is associated with a high rate of neurosurgical complications. A teardrop fracture of the anterior inferior edge of the vertebral body results from hyperextension, resulting in a rupture of the anterior longitudinal ligament. The injury is stable with the head and neck in flexion, but unstable in extension due to loss of structural support. Categories of spinal cord injuries. Primary spinal cord injury. Primary spinal cord injury is injury that occurs at the moment of impact. Penetrating trauma typically results in transection of non-regenerative neural elements and complete injuries. Blunt trauma may displace ligaments and bone fragments, resulting in compression of points of the spinal cord. In its mildest form, it causes a cord concussion with brief transient neurologic deficits. In its most severe form, it causes complete and permanent paralysis. Whereas the former represents local axonal depolarization and transient dysfunction, the latter represents a primary axonal and neuronal injury followed by a spreading of secondary tissue damage that expands from the injury's epicenter. Spinal cord concussion, which is characterized by a temporary dysfunction that lasts from 24 to 48 hours, accounts for 3% to 4% of all spinal cord injuries. Cord concussion is considered an incomplete injury, and may present in patients with simple compression fractures or in those without radiologic evidence of a fracture. Spinal cord contusions are caused by fracture, dislocation, or direct trauma. They are associated with edema, tissue damage, and vascular leakage. Hemorrhagic disruption may cause temporary to permanent loss of function despite normal radiographs. Cord laceration usually occurs when a projectile or bone enters the spinal canal. Such an injury is likely to result in hemorrhage into the cord tissue, swelling, and disruption of some portion of the cord, and its associated communication pathways. Secondary spinal cord injury. Secondary spinal cord injury occurs when multiple factors permit a progression of the primary spinal cord injury. The ensuing cascade of inflammatory responses may result in further deterioration. These effects can be exacerbated by exposing neural elements to further hypoxemia, hypoglycemia, and hypothermia. Although some secondary spinal cord injuries may be unavoidable, you should minimize further injury through stabilization, that is, through spinal motion restriction and neutral alignment. In addition, minimizing heat loss, and maintaining oxygenation and perfusion are key elements in the pre-hospital care of a patient with a possible spinal cord injury. Effects of spinal cord injuries. Depending on the degree of function below the level of injury, all spinal cord injuries are classified as complete or incomplete. Complete spinal cord injury results in permanent loss of all spinal cord-mediated functions below the level of injury. When the injury affects the patient high in the cervical spine, quadriplegia results. A similar injury in the high thoracic area would result in paraplegia. In an incomplete spinal cord injury, the patient retains some degree of cord-mediated function. The initial dysfunction may be temporary due to swelling and inflammation. The degree and timing of recovery is variable and is evaluated regularly, using the American Spinal Injury Association impairment scale. Anterior cord syndrome results from the displacement of bony fragments into the anterior portion of the spinal cord, often due to flexion injuries or fractures. The anterior spinal artery provides blood to the anterior two-thirds of the spinal cord. Disruption of this flow will present as an anterior cord syndrome. Physical findings include paralysis below the level of the insult with loss of sensation to pain, temperature, and touch. In central cord syndrome, hyperextension injuries to the cervical area present with hemorrhage or edema to the central cervical segments. Central cord syndrome is frequently seen in older patients, who may already have a significant degree of cervical spondylosis and stenosis due to arthritic changes. A brief episode of hyperextension can exert pressure on the spinal cord within the relatively diminished spinal canal. Up to 60% of patients with acute traumatic central cord syndrome have sustained fractures, dislocations, or disc herniations. Within the central cord, motor, efferent fibers are distributed in a unique fashion, with more cervical and thoracic motor and sensory tracts than in the periphery of the cord. The patient with central cord syndrome will present with greater loss of function in the upper extremities than in the lower extremities, with variable loss of sensation to pain and temperature. The patient may also have some bowel and bladder dysfunction. The prognosis for central cord syndrome is typically good. Many patients regain all motor function or have only some residual weakness in the hands. Posterior cord syndrome is associated with extension injuries. This relatively rare syndrome produces dysfunction of the dorsal columns, presenting as decreased sensation to light touch, proprioception, the ability to perceive the position and movement of one's body, and vibration, while most other motor and sensory functions remain intact. Recovery of function is less prevalent than with central cord syndrome, but the overall prognosis remains good with therapy and rehabilitation. Brown-Sequard syndrome occurs when penetrating trauma is accompanied by hemisection of the cord, and complete damage to all spinal tracts on the involved side. Injury to the corticospinal motor tracts causes motor loss on the same side as the injury, but below the lesion. Damage to the dorsal column causes loss of sensation to light touch, proprioception, and vibration on the same side as and below the injury. Disruption of the spinothalamic tracts causes loss of sensation to pain and temperature on the opposite side of injury, below the lesion. Spinal shock refers to the temporary local neurologic condition that occurs immediately after spinal trauma. Swelling and edema of the cord begin within 30 minutes of the initial insult, and can lead to a physiologic transaction in addition to any mechanical disruption of all nerve conduction distal to the injury. The patient may present with variable degrees of acute spinal injury, potentially with flaccid paralysis, flaccid sphincters, and absent reflexes. Sensory function below the level of injury will be impaired, as will thermoregulation and visceral sensation below the lesion, resulting in bowel distension from a loss of peristalsis. Spinal shock may subside in hours to weeks, depending on the severity of injury. Neurogenic shock results from the temporary loss of autonomic function, which controls cardiovascular function, at the level of injury. Marked hemodynamic and systemic effects are seen. Hypotension occurs due to absent or impaired peripheral vascular tone with the loss of alpha receptor stimulation. Blood pools in the enlarged vascular space, causing a relative hypovolemia. This results in decreased stroke volume and cardiac output. Bradycardia results as well. The adrenal gland loses its sympathetic stimulation, and does not produce epinephrine or norepinephrine. Hypothermia and absence of sweating are also seen because of the loss of sympathetic stimulation. The classic case of neurogenic shock is a hypotensive, bradycardic patient whose skin is warm, flushed, and dry below the level of the spinal lesion. Patient assessment. Limiting the progression of secondary spinal cord injury is a major goal of pre-hospital management of spinal cord injury. You should be familiar with the circumstances that commonly produce spinal cord injury, and try to determine, through history taking and examination of the scene, whether any of these circumstances exist. When to suspect a spinal cord injury. The history of present illness typically provides most of the information necessary to reach a diagnosis. Maintain a high index of suspicion in any case for which the mechanism of injury suggests the possibility of spinal cord injury. Associated injuries, especially those that reflect involvement of massive forces, may also provide clues of the presence of spinal cord injury. Treat all patients who experience multiple trauma or those who are found unresponsive after trauma as if a spine injury exists, because the majority of cervical spine injuries are associated with head injury. Patients with evidence of major trauma above the clavicle should be considered at risk for an associated spine injury. The following high-risk mechanisms of injury strongly suggest spine injury, and require full spinal motion restriction regardless of the physical examination findings. High-velocity collision, greater than 60 km per hour. Unrestrained occupant of moderate to high-speed motor vehicle collisions. Vehicular damage with compartmental intrusion, 30 cm, into the patient's seating space. Fall from greater than 1 meter increases risk, and from greater than 3 meters increases risk significantly. Penetrating trauma near the spine with neurologic deficit. There is no need to perform spinal motion restriction on a patient with penetrating neck trauma, and a normal neurologic exam. Ejection from a moving vehicle. Motorcycle collision at greater than 30 km per hour with separation of rider from vehicle. Diving injury. Vehicle pedestrian or vehicle bicycle collision at greater than 10 km per hour. Death of occupant in the same passenger compartment. Rollover collision, unrestrained. Mechanisms of uncertain or low risk for spine injury include the following events. In these cases, spinal motion restriction should be guided. Moderate to low velocity motor vehicle collisions, less than 60 km per hour. Motor vehicle collisions in which the patient has an isolated injury without positive assessment findings for spinal cord injury. Isolated minor head injury without positive mechanism for spine injury. Syncopal event in which the patient was already seated or supine. Syncopal event in which the patient was assisted to a supine position by a bystander. Determine as precisely as possible the circumstances of the incident and types of energy imparted to the patient, including the degree of force, and the speed and trajectory of impact. Was there blunt or penetrating trauma? Was it a flexion injury, such as the classic diving accident? Was there torsion on the neck? In the case of a fall, estimate the height of the fall, and determine whether anything was struck on the way down, how the patient landed, and what the patient landed on. In vehicular collisions, note the use and positioning of restraints, the patient's position in the vehicle, and the degree of damage to the vehicle. Find out the exact time of the initial injury and record any times and changes in the patient's presentation throughout the pre-hospital phase. Modify the physical examination of any patient with suspected spinal cord injury based on the patient's level of consciousness, reliability as a historian, and mechanism of injury. In cases of high or intermediate risk mechanisms, whenever possible complete the physical examination with the patient in a neutral position without any movement of the spine. Apply manual stabilization while asking the patient not to move unless specifically asked to do so. The neck and trunk must not be flexed, extended, or rotated. Frequent reassessments are necessary to determine whether the patient is stabilizing, improving, or deteriorating. Also, be sure to document suspected spinal cord injury, noting the area involved, sensation, dermatomes, discussed in the next section, motor function, and areas of weakness. Scene assessment. After donning personal protective equipment, the initial step of any assessment should be a determination of scene safety, and the need for any additional resources. Decide whether the trauma system should be activated, for example, Air evacuation of the patient to a level 1 trauma center. Note the general age and sex of the patient. Observe the position in which the patient is found and determine if the patient's condition is life-threatening. While maintaining the head and neck in neutral position through manual stabilization, determine the level of consciousness, using AVPU, awake verbal pain unresponsive, initially and then the Glasgow Coma Scale. Recall from Chapter 17 that the Glasgow Coma Scale score is a standardized method of relaying information regarding a patient's overall level of consciousness, as time allows. A cervical collar may be applied as soon as the assessment of the airway and neck are complete. Sedation or rapid sequence intubation procedures, depending on local protocols, may be required for a combative patient to ensure the patient's protection and spine stabilization. Initial assessment. Airway. After confirming that the scene is safe and determining the patient's mental status, the next priority is to ensure an open airway. Sonorous respirations usually indicate a positional problem, while gurgling respirations often indicate a need for suction. The oropharynx may become occluded by the tongue, secretions, blood, vomitus, foreign bodies, or improperly inserted airways. A retropharyngeal hematoma associated with injury of the upper cervical spine, C2, may also compromise the airway. While maintaining the head and neck in neutral alignment, clear the mouth, and carefully but quickly suction if necessary. Use a jaw thrust maneuver to open the airway. If this technique is successful, insert an oropharyngeal airway or a nasopharyngeal airway as appropriate. An intact gag reflex is a contraindication for an oropharyngeal airway, because vomiting will increase the likelihood of airway compromise and increase the risk of aspiration. Facial fractures and physical findings or suspicion for a basilar skull fracture are relative contraindications for a nasopharyngeal airway. If the patient is awake with an impaired airway or has a deteriorating Glasgow Coma Scale score, 8 or less, consider sedative-facilitated orotracheal intubation or rapid sequence intubation with inline stabilization. However, paramedics should note that pre-hospital evidence supporting improved outcomes, decreased mortality, in patients treated with tracheal intubation versus bag mask ventilation is lacking. On occasion, it may be impossible to oxygenate and ventilate a patient conventionally, and a more invasive airway approach might be required. Examples include supraglottic devices, tracheal tubes, or cricothyroidotomy devices. During placement of these devices, the cervical collar should be open to allow for proper mouth opening, and a second practitioner should be assigned to support the head and minimize cervical spine motion. Practitioners must balance the risk of causing further cervical spine injury during airway placement with the risk of being unable to visualize the airway and properly secure it. Various techniques, including backwards-upwards rightward pressure upon the glottis, and indirect laryngoscopy with fiber optic devices, might help. However, they are certainly not reliable solutions, nor do they necessarily reduce cervical spine motion during intubation. Allowing for some limited neck motion to secure a difficult airway may be preferable to patient asphyxiation. If vomiting occurs, log roll the patient to the side maintaining manual inline stabilization of the head and neck, then suction as required. In all cases, paramedics should follow their local and regional protocols to determine the optimal approach to airway management in the setting of spinal cord injury. Breathing. Evaluate the patient's breathing, noting the rate, depth, and symmetry of each respiration. The diaphragm is innervated by the phrenic nerve, C3 to C5. Lesions occurring at or above C3 to C4 may consequently lead to diaphragmatic paralysis. A complete lesion at this level will result in no diaphragmatic, intercostal, or abdominal muscle function. There may be some residual accessory neck muscle function, sternocleidomastoid, depending on the level, but this is inadequate to maintain oxygenation and ventilation. An injury involving the lower cervical or upper thoracic spinal cord, T2, may result in paralysis of the intercostal muscles, leaving the patient dependent on the diaphragm and accessory muscles of the neck for breathing. Inadequate respirations with or without evidence of decreased oxygenation will require assisted ventilation at 10 to 12 breaths per minute with the bag mask device with 12 to 15 liters per minute of supplementary oxygen flowing. If a head injury is suspected, use end-tidal carbon dioxide monitoring to maintain carbon dioxide levels at 35 to 45 millimeters of mercury. Circulation. To assess perfusion, verify the pulses for their presence, rate, quality, regularity, and equality, and examine the patient's skin color, temperature, and moisture. Patients with significant sensory loss from spinal cord injury may equilibrate to the surrounding environmental temperature due to the lack of input from the periphery for temperature control. In neurogenic shock, the skin is usually warm, dry, and flushed due to vasodilation and the absence of sweating. These findings should be correlated with the patient's mental status and any other injuries that may be contributing to shock in the patient. In the absence of a pulse, immediately initiate cardiopulmonary resuscitation. Control any external bleeding with direct pressure or pressure dressings. Volume resuscitation may be necessary in patients with absent or diminished pulses, especially in the setting of multi-system trauma with hypovolemic shock. Patients with spinal cord injury and pure neurogenic shock may not require large amounts of volume resuscitation, but may need vagolytic drugs, for example, atropine, and vasopressors, such as dopamine or norepinephrine, to reverse the unopposed vagal stimulation, bradycardia, and loss of vasomotor tone, hypotension, associated with this type of shock. Transport decision. Early on in the initial assessment, you must decide whether to complete the focused history and physical examination on scene or to transport the patient immediately with interventions en route. The unstable or potentially unstable patient should be transported as soon as possible to the most appropriate hospital according to local trauma guidelines or direct medical control instruction. Focused history and physical examination. An accurate history and physical examination are critical for directing management of patients with potential spinal cord injuries. A patient's reliability as a historian must always be assessed before performing a focused or detailed assessment. To assess for spinal injury, the patient must be non-impaired and able to perform cognitive functions appropriately. This results in decreased stroke volume and cardiac output. Patients with suspected spinal injury should have continuous spinal protection until the receiving physician clinically and, when indicated, radiographically clears the spinal percussion at the receiving hospital. The focused history should follow the sample format, and the focused physical exam should begin with baseline vital signs. In case of potential spine injuries, the examination includes rapid inspection and palpation of the head, neck, chest, abdomen, pelvis, extremities, and back for injuries. Use the mnemonic DCAP BTLS, deformities, contusions, abrasions, punctures, or penetrations, burns, tenderness, lacerations, and swelling, to help you remember specific points. An evaluation of neurovascular integrity should include distal pulse, motor, and sensory function for all four extremities. Any deficits in the neurologic examination must be noted and monitored. In addition to evaluating responsiveness with IVPU during your initial assessment, also obtain a Glasgow Coma Scale score because it provides more specific clinical information. Assess the pupils for their size, shape, equality, and reactivity to light. If possible, obtain a blood glucose level in patients who show evidence of alterations in sensation. During the examination, you should carefully cut away the clothes to minimize motion of the spine. Directly observe the back by log roll to assess for penetrating trauma. Palpate the spine to assess for deformity or displacement, step off, of vertebral bodies. Once the examination is completed, cover the patient with a blanket to maintain normal body temperature. Hypothermia will increase the morbidity and mortality in trauma patients for a number of reasons, including coagulopathy, hypocoagulable, especially diminished platelet function, and suboptimal oxygen delivery to tissues. In colder climates, move the patient to a warmer environment, such as the ambulance, as quickly as possible without compromising the spine further. Placement on the backboard. A backboard, or longboard, is an extrication device that facilitates safe movement of a patient from an unsafe and dynamic environment to a stretcher or bed. Historically, the term spinboard was commonly used, but this term is falling out of favor as backboards do not inherently protect the spinal column. In addition, the term spinal motion restriction is replacing spinal immobilization, as it is almost impossible to truly immobilize the spine, particularly in the pre-hospital environment. Most patients can be log-rolled with visualization for deformity or injury as well as palpation over each posterior spinous process for pain, deformity, or step-off. In a reliable patient, the absence of pain or tenderness along the spine, coupled with the normal neurologic examination, and the absence of distracting injuries, may eliminate the need for manual inline spinal motion restriction in select patients. A patient is considered reliable if he or she is alert and oriented. There is no language barrier, there is no evidence of brain injury or intoxication by drugs or alcohol, and the patient is not so emotionally upset as to impair his or her ability to make decisions or adequately recognize pain and injury. In addition, patients with severe injuries to other body parts, for example, femur fracture, may have such significant pain that it sufficiently distracts them from being able to discern spinal pain or tenderness, rendering them effectively unreliable. Patients with clinical suspicion of spinal injury should always have motion of their spine minimized. Such patients should be maintained supine with a cervical collar in place. Patients in severe pain may require an alternative method of transfer to a backboard. Using a scoop stretcher often results in less movement than is required for a log roll. When the scoop stretcher is in place, and the patient has been lifted, another crew member can slide the backboard, air mattress, or vacuum mattress underneath the patient. Although you can still palpate the patient with this method, a disadvantage of this procedure is that you cannot visually inspect the area. Time on a backboard should be kept to a minimum because skin breakdown can be a major complication of spinal cord injury. This condition is caused by excessive pressure over the bones of the buttocks, the scapular ridges, and the base of the occiput. These 5 areas are the primary points supporting the patient's weight. The initial stages of pressure lesions may begin in a matter of hours. 32% of patients with spinal cord injury develop a skin lesion within 24 hours of injury. Blood distribution shifts to the skin and subcutaneous tissues, and decreased muscle tone and sensation predispose the spinal cord injury patient to these injuries. Several devices have been developed to improve patient comfort. The back raft is a device that takes pressure off specific areas of the back and fills voids that may otherwise allow patient movement. This low-profile air mattress fits under the patient from the shoulders to the waist. Slightly flexing the patient's knees with towel rolls or a blanket, and slightly separating the legs with the pillow or blanket increases patient comfort, and decreases the likelihood of complications while adequately restricting spinal motion for the patient. Concave backboards also conform more closely to a patient's anatomy than do flat boards. Use 5 straps to properly restrict motion. Patients may be log-rolled off the backboard, and onto the EMS stretcher for transport. This is most appropriate for patients who will require prolonged transport times of greater than 1 hour. Elevating the head of bed for such patients is generally avoided, but might be considered in special cases wherein patients with underlying lung disease or morbid obesity cannot ventilate adequately when fully supine. Consultation with direct medical control would typically be pursued in these special cases. Detailed physical examination. A detailed physical examination for a trauma patient with a significant mechanism of injury should take place while en route to the hospital. Closely examine the head, neck, chest, abdomen, pelvis, extremities, back, and buttocks. A detailed head-to-toe examination can often reveal significant findings, especially in patients with questionable reliability, unclear mechanisms, or multi-system trauma. Thoroughly assess the head and neck, because many spinal cord injury patients will have associated head and facial injuries. A complaint of pain is most predictive of a spine injury. Examination of the neck should include gentle palpation of the cervical spine for pain, deformity, or dislocation. Step off. Evaluate the chest and abdomen for both internal and external injuries. Fractures of the ribs, sternum, clavicle, scapula, or pelvis are often associated with spinal cord injury in patients with multi-system trauma. Visualization and palpation are the mainstays of this evaluation. Bear in mind that the physical examination in the spinal cord injury patient may be skewed due to potentially decreased sensation below the level of the spine injury. Assess the chest wall visually for symmetry of chest wall movement, work of breathing, and use of accessory muscles. Auscultation to assess breath sounds may reveal a shortened inspiratory phase. Inadequate ventilation, accessory muscle use, or paradoxical respirations may indicate diaphragmatic impairment due to spinal cord injury. Continually monitor the cardiovascular system for signs of shock. Neurogenic shock may require pharmacologic management, volume replacement, and/or transcutaneous spacing. Examination of the gastrointestinal system may be unreliable in the presence of a neurologic deficit. First, inspect the abdomen for evidence of trauma, noting its contour. Severe gastric distension may impair respiration and lead to airway compromise due to vomiting. Palpate all four quadrants for tenderness, guarding, or rigidity, but remember that patients may be insensitive to pain and, because muscle tone may be absent, they may not develop a rigid abdomen. Lower abdominal distension with or without suprapubic tenderness may be due to urinary retention. In male patients, assess the urethral meatus for evidence of blood, scrotal swelling, and scrotal ecchymosis, which may occur with pelvic fractures. Also assess for priapism. Inspect all extremities for deformity, contusions, abrasions, punctures, lacerations, and edema. Palpate for deformity, tenderness, instability, or crepitus. Look for any abnormal posturing and assess the patient for potential long bone or other significantly distracting painful injuries that may mask a potential spine or cord injury. Neurologic examination. The focused neurologic evaluation in the pre-hospital environment is intended to establish a baseline level of the lesion for later comparison, that is, to determine the completeness of the lesion, and to identify cord syndromes if the lesion is incomplete. A normal neurologic examination does not rule out the possibility of spinal cord injury. The neurologic assessment is intended not only to determine whether the patient should be in spinal motion restriction, but also to furnish data to the hospital about the precise initial presentation of the patient so that medical facility personnel can measure any changes and determine whether immediate surgery is necessary. The initial step of any neurologic assessment is a determination of the level of consciousness. You first note the patient's AVPU in the initial assessment, and then address the Glasgow Coma Scale level during further assessment. When assigning the Glasgow Coma Scale score, do not score the patient as having no motor response if limbs are paralyzed. Ask the patient to blink or move some facial muscles that would be innervated by a cranial nerve. Remember, an unresponsive patient is always at risk for having a spinal injury. Motor components of spinal nerves innervate discrete tissues and muscles of the body in regions called myotomes. You should examine these myotomes in the typical head-to-toe fashion, beginning with the cranial nerves. Cranial nerve assessment is especially important in circumstances suggesting a high cervical injury. Observe the patient for drooping of the upper eyelid, ptosis, a small pupil, miosis, and ipsilateral anhidrosis, Horner syndrome, which would indicate an injury of the sympathetic pathways to the eye. Bilaterally assess each major motor group from the top down to identify the lowest spinal segment associated with normal voluntary motor function. Because incomplete spinal cord lesions are possible, you must determine the extent of function in segments below this level. Monitor for possible ascending lesions, paying special attention to alterations in respiratory patterns resulting from cervical lesions. Ask the patient to flex, C5, and extend, C7, both elbows and then both wrists, C6. Have the patient abduct the fingers, and keep them open against resistance, and then adduct the fingers and attempt to close them against resistance, T1. As an alternative maneuver, have the patient curl all four fingers while you apply opposing pull with your fingers to determine strength against resistance. This tests the finger flexors, C8. To evaluate the lower extremities, ask the patient to bend and extend the knees, L3 and L4. Next, ask the patient to plantar flex the feet and ankles, S1 and S2, and to dorsiflex the toes against resistance, L5. Assessment of motor integrity in an unresponsive patient is based mostly on the patient's response to a painful stimulus. Spinal injury with loss of motor function is likely if an unresponsive patient grimaces, vocalizes, or opens his or her eyes to a painful response above the level of the neurologic deficit but does not move the limbs. Test pain responses at several locations before assuming an absence of response. If the motor examination cannot be completed because to local injury, the examination is considered unreliable and spinal motion restriction is necessary. Sensory components of spinal nerves innervate specific and discrete areas of the body surface called dermatomes. In addition to testing a general loss of sensation, ask the patient about abnormal sensations in these areas such as pins and needles, electric shock, or hyperacute pain to touch, hyperesthesia. As with the motor examination, sensory integrity must be assessed bilaterally, but from the feet up. Identify the lowest level of normal sensation, and any areas below this level in which the patient retains sensation. In the responsive patient, a thorough evaluation will include perception of light touch, temperature, and position, proprioception. Reflexes can produce valuable information regarding sensory input, especially in the unresponsive patient. In significant spinal cord injuries, reflexes are usually absent, but return several hours to several weeks after injury. If reflexes are intact, the preservation of motor and sensory activity in the same spinal cord segment is likely. In a patient older than 2 years, the Babinski reflex is positive when the toes move upward in response to stimulation of the sole of the foot. Under normal circumstances, the toes move downward. Ongoing assessment. Vital signs should be monitored every 5 minutes, unstable patients, to 15 minutes, stable patients, with special attention to the patient's cardiovascular status. Watch for hypotension without other signs of shock. The combination of hypotension with a normal or slow pulse and warm skin is highly suggestive of neurogenic shock. The spinal cord injury responsible for neurogenic shock also usually produces a flaccid paralysis and complete loss of sensation below the level of the injury. In contrast to neurogenic shock, hypovolemic shock is associated with pale, cold, clammy skin and tachycardia. Check interventions such as oxygen flow and spinal motion restriction to ensure that they are still effective. Some paramedic systems may administer an antiemetic for direct medical control. The administration of corticosteroids for spinal cord injury is no longer recommended and may be harmful. Repeat the physical exam and reprioritize the patient as necessary. Document suspected spinal cord injury and note the area involved, sensation, dermatomes, motor function, and areas of weakness. Management. Spinal motion restriction, risk versus benefit. Current principles of spine trauma management include recognition of potential or actual injury, appropriate spinal motion restriction, and prevention of secondary injury. However, spinal motion restriction can be painful at pressure points of the occiput and lumbosacral areas, cause significant feelings of claustrophobia and anxiety, and restrict ventilation. Spinal motion restriction also increases the risk for aspiration. Rigid cervical collars have been implicated as contributing to elevated intracranial pressure, limit access to the neck, limit mandibular opening, and may actually distract unstable fractures in the cervical spine. Prolonged scene times can also be an issue, as with any trauma patient. The goal of all paramedics, no matter what level, should be to spend no more than the platinum 10 minutes on the scene before the patient is transported to the most appropriate facility unless lengthy extrication is taking place or the team is awaiting arrival of air transport. Although a definitive pre-hospital clinical spine clearance protocol has not yet been established, current practices reflect the principles of hospital-based models. Spinal splinting procedures. For splinting purposes, the spine should be considered one long bone articulating with the head and the pelvis at either end. Thus, you cannot isolate and splint at only one level of the spinal column. There is simply no such thing as partial spinal motion restriction. Supine patients. A supine patient can have effective spinal motion restriction when secured to a backboard. The methods available to transfer a patient from the ground to a backboard, listed in the order of the amount of spinal motion generated, are the scoop stretcher, 6+ person lift and slide, 6 people, straddle lift and slide, 5 people, and 4-person log roll. It is unknown if these differences are clinically significant. The scoop stretcher, which is used to lift the patient a few centimeters off the floor or ground while a paramedic slides the backboard under the patient, is particularly good on smooth, hard surfaces such as ice. Its latch mechanism may catch on soft surfaces, such as a bed. The patient's condition, the scene, and the available resources will dictate what method you choose. If a log roll is performed, the patient should ideally be rolled away from the site of the injury. Your job is to ensure that the head, torso, and pelvis move as a unit, with your teammates controlling the movement of the body. If necessary, you may recruit bystanders to the rescue team, but instruct them fully before moving the patient. To apply spinal motion restriction on a backboard, follow the steps in Skill Drill 25-1. Skill Drill 25-1. Performing spinal motion restriction of a supine adult patient. Step 1. Take routine precautions, and begin manual inline stabilization from a kneeling position at the patient's head. Hold the head firmly with both hands. The provider at the head directs all patient movement. Support the lower jaw with your index and middle fingers, and support the head with your palms. If the patient's head is not facing forward, gently move it until the patient's eyes are looking straight ahead and the head and torso are in line, neutral alignment. Never twist, flex, or extend the head or neck excessively. Do not remove your hands from the patient's head until the patient is properly secured to a backboard, and the head is immobilized. Evaluate the patient's reliability and giving a history. Assess distal pulses and motor and sensory function in each extremity. Apply an appropriate size cervical collar. Step 2. The other rescuer should position the backboard beside the patient and place their hands on the patient's far side to increase leverage while kneeling. Instruct them to use their body weight, shoulders, and back muscles to ensure a smooth, coordinated pull. The pull should concentrate on the heavier portions of the patient's body. On command from the paramedic at the patient's head, the rescuer should roll the patient toward themselves until the patient is balanced on his or her side. This rolling technique prevents the patient from twisting as he or she is pulled down by gravity and up by the provider. One rescuer should quickly examine the back while the patient is rolled on the side, then slide the backboard behind and under the patient. The team should then roll the patient back onto the backboard, avoiding rotation of the head, shoulders, and pelvis. Ensure the patient is centered on the backboard. Step 3. Apply padding as necessary to fill the voids between the patient and the device. When possible, prepare blanket rolls ahead of time, and have them ready to go. When you have the blankets prepared, you only need seconds to place them. Use of blanket rolls has been shown to dramatically improve the effectiveness of spinal motion restriction. Center the patient on the backboard. Step 4. Secure the upper torso to the board after the patient has been centered on the backboard. Secure the pelvis and upper legs, using padding as needed. For the pelvis, use straps over the iliac crest and/or groin loops, leg straps. Pad behind the patient's neck and head area as needed to maintain a neutral inline position. Step 5. Secure the head to the backboard by positioning a commercial device or towel rolls on both sides of the head. Secure the head to the backboard only after the entire torso has been secured. If the head is secured first and the body shifts, the spine may be compromised. Securing most of the body weight first creates better protection. Step 6. Secure the patient's lower legs to the backboard. Secure the patient's arms with the single strap. Check and readjust straps as needed to ensure that the entire body is snugly secured and will not slide during movement of the backboard or during patient transport. Reassess distal pulse, motor, and sensory function in each extremity, and repeat periodically. This is the end of Skill Drill 25-1. A cervical collar is used in addition to, not instead of, manual inline cervical spinal motion restriction. Select the collar based on the manufacturer's specifications, and make sure it fits correctly. An improperly sized device could cause further injury. If you do not have the right size, use a rolled towel. You can use 1 or 2 long towels twisted as a rope, and apply it like a scarf to replace the collar. You may also roll up towels, place the roll around the patient's head, and tape it to the backboard as a head immobilizer. Do not force the head into a neutral inline position if the patient has muscle spasms in the neck, if there is resistance to movement or increased pain with movement, or if there is numbness, tingling, or weakness in the extremities. In these situations, Maintain the cervical spine, also called C-spine, in the position found. Neutral positioning provides the most space for the spinal cord, and may reduce secondary injury due to cord hypoxia and excess pressure on the injured spinal cord. Do not place pillows under the patient's head. However, magnetic resonance imaging studies have revealed that the adult cervical spinal canal is anatomically aligned if the head is elevated by placing a folded towel or pad under the occiput, 1 to 5 centimeters. Pediatric patients have relatively larger heads, so they need padding under the torso to maintain neutral alignment and prevent neck flexion. Newer pediatric backboards have a recessed portion that accommodates the head or half-torso padding. Straddle lift technique. Maintain manual inline stabilization of the head and neck. 3 other rescuers straddle the patient in preparation for lifting the torso, hips and pelvis, and extremities. The 5th rescuer positions the backboard to slide it under the patient from the feet to the head. On command from the paramedic at the head, the 3 rescuers straddling the patient lift the patient approximately 2 to 3 centimeters off the ground as the 5th rescuer slides the board under the patient from the foot end. Straddle lift and slide technique. This technique is identical to the straddle lift, but the patient is moved to the board instead of the board to the patient. This is used in tight spots, such as if a patient was in a corner against a wall or where it would be difficult or impossible to slide in the backboard during a straddle lift or log roll. Patients who are found in a prone position or on their side should be log rolled into the supine position with the head and neck manually stabilized in the position in which they were found, and then spinal motion restricted as described earlier. One rescuer should take control of the cervical spine using a crossed hand position to roll the patient. The second rescuer should be positioned at the torso, with any additional help at the pelvis and legs. The paramedic at the head counts, and the patient is rolled as a unit into a supine position. Assessment and spinal motion restriction should then continue as usual. An unresponsive patient whose head and neck are passively rotated to one side should be maintained in this position unless respiration is compromised. In case of respiratory distress, attempt to bring the head into axial alignment with gentle traction. A responsive and reliable patient can be asked to turn the head if there are no overt signs of injury or neurologic deficit. If the patient experiences neck pain or nervous system complaints, this movement should be halted, and the patient should be transported in the position of comfort. Seated patients. As with supine patients, not all seated patients may need to be placed upon a backboard. Local protocols may allow clinical clearance of the cervical spine in patients with a low-risk mechanism of injury and meeting the Canadian C-spine rule criteria. A study with healthy volunteers has shown that there is less cervical spine movement with carefully instructed self-extrication than during extrication with a vest-type extrication device, but has not been validated during actual extrication from motor vehicle collisions. Patients found in a sitting position, for example, after a motor vehicle collision, who are without cardiorespiratory compromise but require spinal motion restriction should also be approached with manual stabilization of the head and neck. A rigid cervical collar should be measured and placed appropriately, and a vest-type extrication device should be used to facilitate the transfer of the patient onto a backboard. Exceptions to this rule include the following situations in which you do not have time to first secure the patient to the shortboard. You or the patient are in danger. You need to gain immediate access to other patients. The patient has life-threatening injuries that justify urgent removal. In these situations, your team should lower the patient directly onto a backboard, using the rapid extrication technique discussed later in this chapter. Provide manual stabilization of the cervical spine as you move the patient. Rapid extrication is indicated only in cases of life or limb-threatening injury. In all other cases, follow the steps in Skill Drill 25-2 to secure a sitting patient. Skill Drill 25-2. Performing spinal motion restriction of a seated adult patient. Step 1. Take routine precautions, and direct your assistant to place and maintain the head in neutral inline position. Stabilize the head and neck with manual stabilization until the patient is secured to the backboard. Evaluate the patient's reliability as a historian. Assess distal pulse and motor and sensory function in each extremity. Apply an appropriate size cervical collar, if it fits comfortably. Because the cervical collar does not completely stabilize the cervical spine, continue manual stabilization of the patient's head and neck until the patient is fully immobilized on a backboard. Insert a short backboard device between the patient's upper back and the seat back. Open the board side flaps, if present, and position them around the patient's torso, snug to the armpits. When the device is properly positioned, secure the upper torso straps. Position and fasten both groin loops, leg straps. Pad the groin as needed. Check all torso straps, and make sure they are secure. Make any adjustments necessary without excessive movement of the patient. Step 2. Pad any space between the patient's head and the device. Secure the forehead strap or tape the head securely, then fasten the lower head strap around the rigid cervical collar. Re-evaluate the patient to ensure he or she is adequately immobilized. Reassess distal pulses and motor and sensory function in each extremity. Place the backboard next to the patient's buttocks, perpendicular to the trunk. Step 3. Turn the patient parallel to the backboard, and slowly lower him or her onto it. Lift the patient and the vest-type device together as a unit, without rotating the patient, and slip the backboard under the patient and device. Slide the patient onto the backboard as a unit using any handles that may be built into the device. Release the leg straps, and loosen the chest strap to allow the legs to straighten and give the chest room to fully expand. Step 4. Secure the short device and backboard together. Do not remove the vest-type device from the patient. Reassess distal pulse and motor and sensory function in all 4 extremities. Note your findings on the patient care report, and prepare for transport. This is the end of skill drill 25-2. Rapid extrication. With the rapid extrication technique, the patient can be moved from sitting in a car to lying supine on a backboard in approximately 2 minutes. You should use the rapid extrication technique in the following situations. The vehicle or scene is unsafe. The patient cannot be properly assessed before being removed from the car. The patient needs immediate intervention that requires a supine position. The patient's condition requires immediate transport to the hospital. The patient blocks your access to another seriously injured patient. In such cases, the delay that results from applying an extrication-type vest or half-board is contraindicated and unacceptable. Unfortunately, the manual support and stabilization that you provide when using the rapid extrication technique carry a greater risk of spine movement. You should not use the rapid extrication technique if no urgency exists. The rapid extrication technique requires a team of 3 providers who know and have practiced the procedure. Follow these steps. 1. The first rescuer manually stabilizes the patient's head and cervical spine in line from behind. Support may be applied from the side, if necessary, by reaching through the driver's door. 2. The second rescuer serves as a team leader and gives the commands to coordinate the team's moves until the patient is supine on the backboard. Because the second rescuer lifts and turns the patient's torso, he or she must be physically capable of moving the patient. The second rescuer works from the driver's doorway. If the first rescuer is also working from that doorway, the second rescuer should stand closer to the door hinges toward the front of the vehicle. The second rescuer applies a rigid cervical collar and performs an initial assessment. 3. The second rescuer continuously supports the patient's torso until the patient is supine on the backboard. When the second rescuer takes control of the torso, usually in the form of a body hug, he or she should not let go of the patient for any reason. Some type of cross-chest shoulder hug usually works well, but you must decide which method will work best for any given patient. You cannot simply reach into the car and grab the patient, because this will twist the patient's torso. You must rotate the patient as a unit. 4. The third rescuer works from the front passenger seat and rotates the patient's legs and feet as the torso is turned, ensuring that they are free of the pedals and any other obstruction. The third rescuer should first carefully move the patient's nearer leg laterally, without rotating the patient's pelvis and lower spine. The pelvis and lower spine rotate only as the third rescuer moves the second leg during the next step. Moving the nearer leg first makes it much easier to move the second leg in concert with the rest of the body. When the third rescuer moves the legs together, they should be moved as a unit. 5. The patient is rotated 90 degrees so that the patient's back faces out the driver's door, and the feet are on the front passenger's seat. This coordinated movement is done in 3 or 4 short, quick, 1/8 to 1/4 turns. The second rescuer coordinates the sequence of moves, and the first rescuer directs each quick turn by saying, "Ready, turn," or "Ready, move." Hand position changes should be made between moves. 6. During the rotation, the first rescuer will be working from the back seat in most cases. At some point, either because the doorpost is in the way or because he or she cannot reach farther from the back seat, the first rescuer will be unable to follow the torso rotation. At that time, the third rescuer should assume temporary manual inline stabilization of the head and neck until the first rescuer can regain control of the head from outside the vehicle. If a fourth rescuer is present, the fourth rescuer stands next to the second rescuer. The fourth rescuer takes control of the head and neck from outside the vehicle without involving the third rescuer. As soon as the change has been made, the rotation can continue. 7. When the patient has been fully rotated, the backboard is placed against the patient's buttocks on the seat. Do not try to wedge the backboard under the patient. If only 3 rescuers are present, place the backboard within arm's reach of the driver's door before the move so that the board can be pulled into place when needed. The far end of the board can be left on the ground. When a fourth rescuer is available, the first rescuer exits the rear seat of the car, places the backboard against the patient's buttocks, and maintains pressure and toward the vehicle from the far end of the board. When the door opening allows, some rescuers prefer to insert the backboard onto the car seat before the patient is rotated. 8. As soon as the patient has been rotated, and the backboard is in place, the second and third rescuers lower the patient onto the board while supporting the head and torso so that neutral alignment is maintained. The first rescuer holds the backboard until the patient is secured. 9. The third rescuer moves across the front seat to be in position at the patient's hips. If the third rescuer stays at the patient's knees or feet, he or she will be ineffective in helping to move the body's weight. The knees and feet follow the hips. 10. The fourth rescuer maintains inline support of the head, and takes over giving the commands. If a fourth rescuer is not present, you can direct a volunteer to assist you. The second rescuer maintains direction of the extrication. This rescuer stands with his or her back to the door, facing the rear of the vehicle. The backboard should be immediately in front of the third rescuer. The second rescuer grasps the patient's shoulders or armpits. On command, the second and third rescuers slide the patient 20 to 30 centimeters along the backboard, repeating the slide until the patient's hips are firmly on the backboard. 11. The third rescuer gets out of the vehicle, and moves to the opposite side of the backboard, across from the second rescuer. The third rescuer takes control at the shoulders, and the second rescuer moves back to take control of the hips. On command, these 2 rescuers move the patient along the board in 20 to 30 centimeter slides until the patient is completely on the board. 12. The first, or fourth, rescuer continues to maintain manual inline support of the head. The second and third rescuers grasp their side of the board, and then carry it and the patient away from the vehicle onto the prepared stretcher nearby. In some cases, you'll be able to rest the head end of the backboard on the stretcher while the patient is moved onto the backboard. In others, you'll not. Once the backboard and patient have been placed on the stretcher, you should begin life-saving treatment immediately. If you use the rapid extrication technique because the scene was dangerous, you and your team should immediately move the stretcher a safe distance away from the vehicle before you assess or treat the patient. The steps of the rapid extrication technique must be considered a general procedure to be adapted as needed. Every situation will be different, a different car, a different size and priority patient, and a different crew. The key is to respect the principles of the technique: inline stabilization of the C-spine, rotation of the torso and legs without hip or spine movement, and sliding the patient onto the board. Your resourcefulness and ability to adapt are necessary elements of a successful rapid extrication. Standing patients. Ambulatory patients found on the scene may require spinal motion restriction after assessment and determination of mechanism of injury. If you suspect underlying head, neck, or spine injuries, apply a cervical collar, and allow the patient to place himself or herself on the stretcher. 1. Establish manual, inline stabilization, apply a rigid cervical collar, and instruct the patient to remain still. 2. Position the board upright, directly behind the patient. 3. 2 rescuers stand on either side of the patient, the third is directly behind the patient, maintaining motion restriction. 4. The 2 rescuers grasp the handholds at shoulder level or slightly above by reaching under the patient's arms while standing at either side. 5. Prepare to lower the patient to the ground. 6. Carefully lower the patient as a unit under the direction of the rescuer at the head. The rescuer at the head must make sure the head stays against the board, and carefully rotate his or her hands while the patient is being lowered to maintain inline stabilization. Packaging and removal of injured patients from the water. Whatever the type of incident, the principles of packaging and removal are the same. Keep the head, neck, and trunk in alignment. When the patient may have sustained a spine injury in a confirmed diving accident, spinal motion restriction must be initiated even before the patient is removed from the water. If respiratory arrest is suspected, ventilation can be done while still in the water. In the case of a cardiac arrest, you need to quickly determine if the mechanism of injury could have caused a spinal trauma. If there is no mechanism for, and no apparent, spinal injury, then immediately remove the patient from the water, and begin cardiopulmonary resuscitation. However, if there is any indication of a spine injury, follow these steps to stabilize the patient in the water. 1. If the patient is prone in the water, approach the patient from the top of the head and place your arm under the body so the head is supported on your arm, and the chest on your hand. Place your other arm across the head, and back to splint the head and neck between your arms. Continue to support the patient's head and neck in this fashion. Take a step backward and smoothly turn the patient to the supine position. 2. 2 rescuers are usually needed to turn the patient safely, but in some cases 1 rescuer is enough. Always rotate the entire upper half of the body as a unit. Twisting only the head, for example, may aggravate any injury to the cervical spine. 3. Open the airway, and begin ventilation if required. Immediate ventilation is the primary treatment of all drowning and submersion patients. As soon as the patient is face up in the water, use a pocket mask if one is available. Have the other rescuers support the head and trunk as a unit while you open the airway, and begin artificial ventilation. 4. Float a buoyant backboard under the patient as you continue ventilation. 5. Secure the head and trunk to the backboard to eliminate motion of the cervical spine. Do not remove the patient from the water until this step is complete. 6. Remove the patient from the water, using the backboard. 7. Remove wet clothes, and cover the patient with a blanket. Give supplementary oxygen if the patient is breathing adequately. Give positive pressure ventilation if the patient is apneic or breathing inadequately. Begin cardiopulmonary resuscitation if there is no pulse. Effective chest compressions cannot be performed when the patient is still in the water. 8. Consider using an advanced airway device to maintain the airway if needed. Place the patient on a cardiac monitor and treat dysrhythmias according to the advanced cardiac life support algorithms, discussed in Chapter 30 and Appendix A. 9. Note that all submersion patients who have either lost consciousness or are likely to have aspirated a significant amount of water should be transported to the hospital. Later onset pulmonary edema from water aspiration often results in delayed presentations of hypoxia and respiratory distress several hours after the initial event. Patients wearing helmets. The use of helmets has been shown to reduce both the incidence and the severity of brain injuries associated with trauma, and their use is widely encouraged to prevent injury during sport and other high-risk activities. Most helmets consist of an inner foam layer surrounded by a durable plastic shell. Helmets can inhibit full exposure of the patient and could hinder efforts at airway management and spine stabilization. but the removal of most types of helmets will result in some spinal motion even under the best of circumstances. Fortunately, a securely fitting helmet can provide a degree of stabilization and, under the proper circumstances, can actually assist in maintaining the spine in a neutral position. The Inter-Association Task Force for the Appropriate Care of the Spine-Injured Athlete recommend helmet removal in the following situations. The helmet and chin strap fail to hold the head securely, as with a loose-fitting helmet. The helmet and chin strap design prevent adequate airway control, even after the removal of a face mask. A helmet with a face mask cannot be removed after a reasonable amount of time. The helmet prevents proper motion restriction for transport. The National Athletic Trainers Association position statement on acute management of cervical spine injuries adds that for football and ice hockey, if the helmet is to be removed, the shoulder pads must also be removed, as removing one without removing the other compromises cervical spine alignment. Removal of helmets and shoulder pads in these sports must be considered an all-or-nothing endeavor. Only providers familiar with the procedure should attempt helmet removal. A single rescuer should not attempt helmet removal, because the maneuver requires two providers. 1. Kneel at the patient's head. Leave enough room between your knees and the helmet so that you can remove the helmet. Your partner should kneel on one side of the patient, at the shoulder area. 2. Stabilize the helmet by placing your hands on either side of it, with your fingers on the patient's lower jaw to prevent movement of the head. Once your hands are in position, your partner can loosen the chin strap. 3. Your partner should open the face shield, if there is one, and assess the patient's airway and breathing. Remove eyeglasses if the patient is wearing them. 4. When the strap has been unfastened, your partner should place one hand on the patient's lower jaw at the angle of the jaw, and the other behind the head at the back of the helmet. You may then pull the sides of the helmet away from the patient's head. 5. Gently slip the helmet partly off the patient's head, stopping when the helmet reaches the halfway point. 6. Your partner then slides his or her hand from the back of the helmet to the occiput, preventing the head from falling back once the helmet is completely removed. 7. When your partner's hand is in place, remove the helmet, and provide manual inline cervical spine stabilization. 8. Apply a rigid cervical collar, and secure the patient to the backboard. 9. With large helmets or small patients, you may need to add padding under the shoulders to prevent flexion of the neck. If the patient is wearing shoulder pads or a heavy jacket, you may need to pad behind the head to prevent extension of the neck. You do not need to remove a helmet if you can access the patient's airway, the head is snug inside the helmet, and the helmet can be secured to a spinal motion restriction device. Pharmacotherapy of spinal cord injury. Short-acting, reversible sedatives are recommended for the acutely agitated patient after a correctable cause of agitation, for example, hypoxia, has been excluded. The risk of secondary injury due to movements from acute agitation must be balanced with potential airway and ventilatory compromise as well as a reliable neurologic examination. Pain medication may also be necessary. The American Association of Neurological Surgeons and the Congress of Neurological Surgeons recommend that steroids not be administered in the management of acute spinal injury. Complications of spinal cord injury. The complications of spinal cord injury are a consistent cause of the high morbidity and mortality rates and the high financial cost associated with this type of injury. Many of the acute phase complications of spinal cord injury have already been addressed in this chapter, such as the potential for aspiration or respiratory arrest, especially with high cervical injuries. Lower cervical lesions may preserve the diaphragm, but the loss of intercostal muscles ultimately impairs coughing and deep breathing, predisposing the patient to atelectasis and pneumonia. Deep vein thrombosis and pulmonary embolism are late complications that may result from immobility and can become potentially life-threatening. Autonomic dysreflexia, also called autonomic hyperreflexia, is typically a late complication of spinal cord injury but can occur acutely. This potentially life-threatening emergency most commonly occurs with injuries above T4 through T6 and results from the loss of parasympathetic stimulation of vasculature below the level of the injury. Patients present clinically with evidence of a massive, uninhibited, Uncompensated cardiovascular response due to some stimulation of the sympathetic nervous system below the level of injury. The irritated area sends a signal that is not able to reach the brain, and unabated sympathetic nervous system stimulation results in vasoconstriction, as evidenced by cool, pale extremities, systolic blood pressures greater than 200 mm of mercury, and diastolic blood pressures of 130 mm of mercury or greater. Hypertension activates the vasomotor center in the medulla, leading to parasympathetic stimulation. Vagal compensation causes bradycardia and vasodilation of peripheral and visceral vessels above the level of the lesion, although vessels below the spinal cord injury remain constricted. Selective vasodilation results in flushed, diaphoretic skin and nasopharyngeal vessel congestion. Autonomic dysreflexia can be precipitated by antinoxious stimuli below the level of a cervical or thoracic spine injury. Common causes include skin lesions such as insect bites, a distended bladder or rectum, constrictive clothing, or sharp objects compressing the skin. In women, menstrual cramps or pregnancy can also be a trigger. Sharp objects should therefore be removed from pockets or seat cushions. Localized wounds such as lacerations, abrasions, decubitus ulcerations, or ingrown toenails should be dressed, and cold packs applied. Catheters should be irrigated or replaced, and the rectum may need to be disimpacted manually, usually by a physician in hospital. Tight condom catheters can also pinch genitalia, and should be checked and removed if necessary. Management of autonomic dysreflexia is usually not a pre-hospital intervention. If the source cannot be found or minimized to an effective extent, it may be necessary to reduce blood pressure with intravenous vasodilators. Non-traumatic spinal conditions. Back pain is one of the most common physical complaints in emergency departments. An estimated 60% to 90% of the population is afflicted with some form of lower back pain. Expenses related to back pain are high due to the extensive costs of therapy and lost wages from missed work days. Upright posture brings a significant amount of weight to bear on the lumbar spine, specifically at L4 to L5, where the natural bend in the spine's curvature changes. As a consequence, most people are susceptible to injury or degenerative disease. Spinal tumors can also be a cause of pain and debilitation. Occupations that require repetitive lifting, exposure to vibrations from vehicles or industrial machinery, and comorbid diseases such as osteoporosis are all risks for developing lower back pain. Most cases of lower back pain are idiopathic, and making a precise diagnosis can be difficult. When evaluating non-traumatic back pain, it is important to consider disease processes that can result in significantly debilitating lesions, including spinal cord injury. In the absence of trauma, the patient who presents with the complaint of lower back pain must be assessed with the anatomy and neurophysiology of the spine and spinal cord in mind. Pay particular attention to the medications the patient is taking, because patients with chronic back pain and tumors may require very high levels of narcotics to control the intense pain. Pain may result from strain or sprain of paravertebral muscles and supporting ligamentous structures without significant injury to nerve elements. Older patients, especially women, with a history of osteoporosis are at high risk for spontaneous compression fractures of the spine. These typically stable fractures are not associated with spinal cord injury. Tumors in the spine from a variety of metastatic carcinomas can cause pathologic spine fractures, with extension of bone fragments or the tumor itself into the spinal canal causing spinal cord injury. Degenerative disc disease is a common entity in patients older than age 50 years. Over time, biomechanical alterations of the intervertebral disc will result in loss of height and reduce the shock-absorbing effect of the disc. Significant narrowing may result in variable segment stability. Disc herniation is usually caused by some degree of trauma in patients with pre-existing disc degeneration. It typically affects men between the ages of 30 and 50 years, and often results from poor lifting technique. Herniation most commonly occurs at L4 to L5 and L5 to S1, but may also occur in C5 to C6 and C6 to C7. Patients will present with pain, usually with straining. They may have tenderness of the spine, and often have limited range of motion. Patients may have alterations in sensation and motor functions as well. Cervical herniations may present with upper extremity pain or paresthesias that worsen with neck motion. Motor weakness may also occur due to spinal cord compression. Definitive diagnosis of back pain may require multiple types of radiographic imaging. Pre-hospital management of lower back pain in the absence of trauma is primarily for symptom relief, directed at decreasing any pain or discomfort with movement. Chapter 33. Allergic reactions. Introduction. Allergic reactions and anaphylaxis have been documented for many years. One of the earliest accounts may have been noted by the late 17th century clergyman Increase Mather. Some men also have strange antipathies in their natures against that sort of food which others love, and live upon. I have read of one that could not endure to eat either bread or flesh, of another that fell into a swooning fit at the smell of a rose. There are some who, if a cat accidentally comes into the room, though they neither see it, nor are told of it, will presently be in a sweat, and ready to die away. Although these cases cannot be proven to be anaphylaxis, the descriptions suggest some type of reaction was present, possibly an allergic reaction or anaphylactic reaction given the severity and fatality of the descriptions. This chapter explores these types of reactions, including their typical signs and symptoms, and the steps you should take to manage such patients. In addition, it discusses the common causes of allergy so we can be better prepared to provide pre-hospital care for affected patients. The term anaphylaxis was first used in 1902, when Portier and Richet were experimenting with vaccinating dogs with cyanemone toxin. After the second dose of the toxin, one of the dogs died due to a severe allergic response. Because this response was the opposite of the protection they were expecting, it was referred to as anaphylaxis, from the Greek word and meaning without and a word of unclear origin, phylaxis meaning protection. In 2006, the American National Institute of Allergy and Infectious Disease defined anaphylaxis as a serious allergic reaction that is rapid in onset and may cause death. In Canada, 1 person in 3 million dies each year due to anaphylaxis. Death in anaphylaxis usually occurs from brain hypoxia or from the side effects from treatment with epinephrine. Unfortunately, no exact cause for anaphylaxis can be determined in up to 2/3 of patients. Neither race nor sex seems to affect the incidence of anaphylaxis. Anaphylactic reactions have been documented in children as young as 6 months and adults as old as 89 years. Pathophysiology. Allergy and anaphylaxis are examples of immune system dysfunction. Under normal circumstances, the immune system protects the body against cellular attack via 2 types of systems, cellular immunity and humoral immunity. In cellular immunity, the body produces special white blood cells called T cells that attack and destroy invaders. In humoral immunity, the B cells produce antibodies, also called immunoglobulins, Ig closing square bracket closing parenthesis in response to antigens, proteins found on the surface of cells, to fight off infection or toxins. B cells produce 5 types of immunoglobulins and make up 20% by weight of plasma, which is found throughout the body in the lymph nodes, spleen, and gastrointestinal tract. Table 33-1 lists common antibodies with their actions and locations. A hypersensitivity reactions can be a local reaction of a systemic reaction resulting from the immune response to antigens. Most allergic reactions and anaphylaxis are type 1 hypersensitivity reactions, which occur in immediate response to antigens in our environment. This occurs in people who have been previously sensitized to that antigen, that is, they have encountered that antigen before and the immune system has been primed to recognize it the next time. In response to this antigen, referred to as an allergen, the body inappropriately produces IgE antibodies. Common allergens are foods, medications, or insect stings. Anaphylaxis is an extreme systemic and life-threatening form of hypersensitivity. In response to this allergen, IgE directs mast cells and basophils to release pro-inflammatory substances, leading to many of the symptoms observed in anaphylaxis. Mast cells are found throughout the body, but they are abundant in the skin and near blood vessels. There are several pro-inflammatory substances released by mast cells that cause havoc throughout the body in anaphylaxis. One you may have heard of is histamine. In fact, histamine is so potent that injecting it can reproduce most of the symptoms observed in anaphylaxis. Table 33-2 lists the common antigens associated with anaphylaxis. The release of pro-inflammatory mediators leads to a cascade of effects on the body as a whole. Histamine is extremely potent, but there are other mediators that also amplify its effects. Histamine increases vascular permeability, leading to capillary leakage of fluid into the extravascular space. In fact, as much as 50% of the vascular volume can be shifted to the extravascular space within 10 minutes of exposure to an antigen. This leakage of fluid results in swelling of the skin and mucosal tissues, leading to angioedema and potentially compromising the airway. This also results in the characteristic urticaria seen in the skin as an erythematous, raised, and pruritic rash. Histamine can further compromise the airway and breathing through bronchoconstriction and increased mucus production. From a cardiovascular standpoint, histamine's effects on vascular permeability and vasodilation can lead to profound hypotension. Histamine increases heart rate and can cause myocardial depression, potential causing cardiac dysrhythmia and worsening hypotension and shock. Histamine's effects on the gastrointestinal system are to increase gastric acid secretion and intestinal and smooth muscle contraction, which leads to nausea, abdominal pain, vomiting, and diarrhea. The physiologic effects of epinephrine include vasoconstriction, cardiac chronotropic and inotropic effects, bronchodilation, and suppression of the release of histamine and other mediators from mast cells and basophils, resulting in increased cardiac output, increased peripheral vascular resistance, and decreased mucosal edema and airway resistance. Clinical symptoms of anaphylaxis. The classic presentation of anaphylaxis includes rash, respiratory symptoms, and hypotension, or some combination of these symptoms. Gastrointestinal symptoms such as abnormal cramping, nausea, vomiting, and diarrhea may also be present. Depending on the severity of any one symptom, the patient may focus on that symptom and neglect to recognize or describe the other symptoms they are experiencing unless specifically asked. This is a contributing factor in failure to recognize anaphylaxis early in its clinical course. Table 33-3 summarizes the signs and symptoms of anaphylaxis. The timing, route, and amount of potential exposure to an allergen can predict severity. For example, if a substance is injected or ingested, the reaction is more likely to be severe. An anaphylactic reaction can occur in a biphasic response, the initial response, which occurs within the first 30 minutes after exposure, and resolves within 1 hour, consists of vasodilation, vascular leakage, and smooth muscle spasm, and a delayed response, which can occur hours later and last for days, consisting of more intense infiltration of tissues with inflammatory cells, and more severe symptoms. Anaphylaxis can be protracted, lasting days, or delayed in onset, with symptoms occurring much later after exposure. As with any patient, gathering the past medical history is important. For example, a strong cardiac history may affect the dosing or frequency of epinephrine given later. A personal history of atopy, that is, diseases related to allergies, such as allergic rhinitis, asthma, and atopic dermatitis, can increase the potential for anaphylactic reactions and severity of reactions. Table 33-4 lists other risk factors for severe reaction. 1/3 to 1/2 of patients with anaphylaxis have a history of atopic diseases. In patients with history of atopy, 50% have a positive family history of allergy. Absence of personal or family history of allergy or atopy does not exclude diagnosis of anaphylaxis. Diagnosis. Early recognition of anaphylaxis is critical to timely administration of life-saving treatment. Currently, there is not an agreed-on definition and, unfortunately, this can sometimes lead to delayed diagnosis and treatment. Commonly accepted criteria for diagnosing anaphylaxis are presented in Table 33-5. The most common presentation of anaphylaxis is swelling of skin or mucosa with respiratory or cardiovascular compromise. However, anaphylaxis can present as involvement of any two systems, for example, severe gastrointestinal symptoms combined with a rash in response to a known allergen may also be anaphylaxis. On the other hand, Criterion 3 aims to identify rare individuals who present with only severe hypotension in response to an allergen. Anaphylaxis can affect multiple body systems, and it is important to keep the differential diagnosis broad. For example, respiratory distress observed in anaphylaxis can resemble other conditions such as asthma or pulmonary edema. Hypotension is common in any sick patient with conditions ranging from sepsis to myocardial infarction. Assessment. Initial assessment. Assessment of a patient with an anaphylactic reaction can be highly challenging. You may have to simultaneously assess the patient, identify the problem, and intervene within seconds of arriving on the scene to save the patient's life. Index of suspicion for anaphylaxis must be high on your list if any of the symptoms discussed previously are present. You may not have a second opportunity as the patient's condition can deteriorate before your eyes. Symptoms may progress slowly or alarmingly fast. You may have only minutes to halt this rapid, life-threatening process. As with all patients, careful examination of the airway, breathing, and circulation are prudent. Airway. Angioedema involving the lips or tongue may immediately get your attention on arrival at the scene. You may also hear stridor or hoarseness if there is severe upper airway swelling of the laryngeal and epiglottic areas. Affected patients may report a lump in the throat, and may exhibit frequent coughing or sneezing in an effort to clear it. All of these symptoms should prompt immediate treatment with epinephrine, and immediate action to stabilize the airway. Stabilizing the airway means ensuring the airway is patent and secure. If the patient can speak and is awake, then applying high-flow oxygen via non-rebreathing mask, and allowing the patient to assume a position of comfort may be all that is immediately needed. For any patient experiencing anaphylaxis, the future clinical course over the next few hours is unpredictable. Although the airway may be patent at the moment, this requires frequent ongoing reassessment to ensure that it remains patent. If the airway is compromised, advanced airway management by bag mask device or tracheal intubation may be necessary. Airway edema, secretions, and bronchoconstriction may make ventilation via either of these routes difficult. When confronted with a patient with anaphylaxis, it is important to prepare for a difficult intubation and emergency cricothyrotomy should the patient deteriorate. This includes selecting smaller tracheal tubes to be used if necessary and preparing for a surgical airway by ensuring the equipment is available, landmarking and set up prior to intubating, and being prepared to move on to cricothyrotomy immediately should intubation prove to be too difficult. Breathing. Ventilation may be affected due to bronchoconstriction and increased secretions. Observe the patient for tachypnea, labored breathing, accessory muscle use, abnormal retractions, and prolonged expiration. The severity of these findings predicts the stability of the patient's condition. Absence of wheezing may be an ominous sign, as this can be a result of less air moving in the lungs due to fatigue, and extreme difficulty getting a full breath due to edema, bronchospasm, and increased secretions in the airways and alveoli. A silent chest in severe anaphylaxis is a dangerous sign. Breathing distress may respond to high-flow oxygen and salbutamol nebulizations. However, epinephrine is the drug of choice to induce bronchodilation. In severe cases of airway edema, there has been some success in administering nebulized epinephrine. Continue to monitor the patient's pulse oximetry and tidal carbon dioxide and overall respiratory status throughout your assessment and transport. Circulation. Tachycardia, hypotension, and shock are all potential and common signs of anaphylaxis. In fact, for some rare patients, hypotension and shock may be the only clinical signs of anaphylaxis. Pallor and cyanosis may be present. There may be confusion due to brain hypoperfusion. Cardiac monitoring and intravenous access are critical steps in the management of any sick patient. Cardiac dysrhythmias are associated both with the anaphylaxis and are a known complication of administration of epinephrine. Intravenous access is important because the anaphylactic patient will need fluid replacement. Anaphylaxis causes leakage of fluid into tissues, necessitating administration of large amounts of intravenous fluid. You may need upwards of 1 to 2 liters of intravenous fluid, lactated Ringer solution or normal saline, initially. If there is no response after 3 or 4 liters of fluid, then consider adding a vasopressor. Disability or level of consciousness. Altered mental status such as confusion, restlessness, and agitation may be signs of shock or brain hypoxia. As the patient's condition deteriorates and brain perfusion decreases, the patient will become untended or even completely unresponsive. Any change in mental status in an anaphylactic patient should direct you to immediate epinephrine administration and airway evaluation and management. Vital signs. A patient with an allergic reaction will often present with tachypnea, tachycardia, and hypotension. When these signs are noted in conjunction with flushed skin and hives, anaphylaxis should be one of the major considerations. Skin changes. The skin is the body's first line of defense against would-be invaders, so skin symptoms are often the first indications of a hypersensitivity reaction. Initially, the person may be aware of feeling warm and flushed. Pruritus, itching, and urticaria, hives, are often experienced early on in anaphylaxis, and may persist or may have resolved prior to ambulance arrival. It is important to ask if there was any rash present earlier and if there is any suspicion of allergy or anaphylaxis. Gastrointestinal symptoms. Gastrointestinal symptoms may also be part of an anaphylactic response, particularly if the offending antigen has been ingested. Abdominal cramping is a common presentation, but nausea, bloating, vomiting, abdominal distension, and profuse, watery diarrhea may also be present. History taking. Gathering history at the scene is invaluable. The patient may not have had a reaction before and may not know the inciting allergen or that symptoms they are experiencing are allergy-related. If the patient does have a history of allergy or anaphylaxis, it is helpful to inquire how severe these reactions were. For example, if a child had a life-threatening reaction to peanuts in the past that now presents within minutes after a peanut exposure, then treatment, that is, epinephrine, should be started right away rather than waiting for symptoms to occur because clinical deterioration can be rapid. When taking the history, it is important to remember that the exposure to the antigen may have occurred hours before the onset of symptoms. A detailed history of medications prescribed and taken is important. Medications and insect stings are the most common cause of anaphylaxis in adults. If the patient has already taken an antihistamine, he or she may not have a rash. If the patient has administered his or her own EpiPen autoinjector, it is important to know at what time it was used, and whether their symptoms have improved. Self-administration of Ventolin may have treated bronchospasm. If the patient is on a beta blocker, it may reduce his or her response to epinephrine or mask some anaphylaxis symptoms such as tachycardia. Ongoing assessment. The ongoing assessment is typically conducted en route to the emergency department. In case of anaphylaxis, it involves reassessment of the patient's airway, breathing, and circulations, and serial vital signs, and intervening as needed. Always think ahead to prepare for deterioration of the patient's condition, have additional intramuscular doses of epinephrine drawn up, mentally prepare for a difficult airway, ensure intravenous access is open, and consider an additional intravenous line if needed. Management of anaphylactic reactions. Anaphylaxis is a life-threatening emergency, and must be treated as such. It takes rapid recognition and intervention to reverse the anaphylactic process, and save the patient's life. Although the actions to reverse anaphylaxis will be reviewed here sequentially, in reality, these interventions will need to be performed simultaneously. As with any sick patient, assessment and treatment beginning with the airway, breathing, and circulations are critical first steps in the treatment of anaphylaxis, but none of these should delay the administration of epinephrine, which will reverse the symptoms of anaphylaxis, and treat the underlying cause. In a review of deaths caused by anaphylaxis, deaths from ingested allergens occurred within 30 minutes, deaths from stings occurred within 15 minutes, and death from iatrogenic injection of allergens occurred within 5 minutes. Therefore, epinephrine should be given as soon as the diagnosis of anaphylaxis is made. Epinephrine is the only medication that can reverse anaphylaxis through vasoconstriction, improvement of cardiac contractility, bronchodilation, and suppression of the release of histamine, and other pro-inflammatory mediators. The net effect is increased peripheral vascular resistance, improved cardiac output, decreased mucosal edema, and decreased airway resistance. Its onset of action is fast and there is no absolute contraindication to the use of epinephrine in the setting of anaphylaxis. Special consideration should be given if administering epinephrine to older patients or those with a cardiovascular disease history, but this should not preclude its use in anaphylaxis. Epinephrine comes in different concentrations to be given via different routes, and for different purposes. The 1 to 1000, that is, 1 mg per milliliter, concentration of epinephrine is used for intramuscular injections. The dose is 0.01 mg per kilogram, maximum of 0.5 mg in adults, 0.3 mg in children, intramuscularly at a site in the anterolateral thigh, every 5 to 15 minutes as needed. Patients may self-administer autoinjectors, which typically give 0.3 mg per dose. However, most adults weigh over 50 kg, so they are safe to receive 0.5 mg intramuscularly. Pediatric autoinjectors dispense 0.15 mg, and are intended for use in children weighing 15 to 30 kg. The adult EpiPen delivers the medication intramuscularly in a dose of 0.3 mg of an 1 to 1000 solution. Compare intramuscular doses to the concentration of intravenous epinephrine 1 to 10,000. The 1 to 10,000 formulation is 10 times more dilute, so prudence is paramount in ensuring the proper concentration of epinephrine is used via the appropriate route. Administering epinephrine as an intravenous bolus has been associated with errors in dosing, dysrhythmias, and deaths in anaphylaxis. For this reason, and due to potential delays in obtaining intravenous access, epinephrine should be given intramuscularly as soon as the diagnosis of anaphylaxis is made. Intramuscular administration of epinephrine is preferred over subcutaneous injections because it provides more rapid and reliable absorption. In some cases, repeated epinephrine doses are required or shock persists despite intramuscular injections of epinephrine. These are the patients for whom intravenous epinephrine is indicated. Certainly, any patient in a pericardiac arrest state should be given intravenous epinephrine. The intravenous formulation of epinephrine is the 1 to 10,000 concentration, often referred to as cardiac epi because it is the same vial used in a cardiac arrest. To administer the 1 to 10,000 concentration as a bolus, dilute 1 milliliter of cardiac epinephrine, that is, 1 to 10,000 concentration, in 10 milliliters of normal saline such that 0.05 to 0.1 milligram, that is, 0.2 milligram per kilogram, becomes a 0.1 milligram per milliliter intravenous solution. An intravenous infusion of epinephrine can also be administered at 1 to 4 micrograms per minute, that is, 1 milligram in 250 milliliters of saline equals a 4 microgram per milliliter concentration. The advantage of an intravenous infusion is that the dose can be more easily titrated to effect, thus eliminating the need for repeated doses. In some circumstances, for example, if the patient is on a beta blocker, there may not be a good response to epinephrine. For these patients, glucagon may be administered. Glucagon acts intracellularly and does not depend on the adrenergic beta receptors. It increases intracellular cyclic adenosine, and there are some data to support its success in reversing hypotension and bronchospasm in anaphylaxis where epinephrine has failed. Nausea and vomiting are significant side effects of glucagon, so airway protection prior to its use is necessary to prevent aspiration. The usual dose is 1 to 5 milligrams intravenously over 5 minutes, and this can be followed by an infusion of 5 to 15 milligrams per minute titrated to clinical response. For patients who are still in refractory hypotension, other vasopressors such as Levophed or vasopressin can be considered. Aggressive fluid resuscitation should continue. These patients may even be considered for extracorporeal membrane oxygenation, if it is available in your system. Consult with the local emergency department early if your patient is not responding to usual management with epinephrine. Inhaled beta-adrenergic agents such as salbutamol may also be included as part of the pre-hospital care regimen if bronchospasm is present. Inhaled epinephrine can also be considered. Epinephrine is the mainstay in the treatment of anaphylaxis. Other treatments such as antihistamines should be considered only after epinephrine has been administered. Antihistamines block the histamine 1, H1, and 2, H2, receptor sites. The antihistamine diphenhydramine, Benadryl, is commonly used in the pre-hospital setting following the administration of epinephrine. This medication does not prevent histamine release, but rather blocks histamine effects at the H1 receptor sites. The typical dose of Benadryl is 25 to 50 milligrams administered slowly via the intramuscular or intravenous route. Hydrogen blockers such as cimetidine, Tagamet, and ranitidine, Zantac, are also indicated, but are more commonly used in the in-hospital setting. There is no evidence showing antihistamines to be effective in anaphylaxis despite the theoretical usefulness based on their mechanism of action and effectiveness in other allergic conditions. This may be related to their slow onset of action. Antihistamines are, therefore, considered potentially useful adjuncts, but their use should not delay or substitute epinephrine administration in anaphylaxis. Corticosteroids are another theoretically useful adjunct in the management of anaphylaxis. Corticosteroids are believed to prevent late-phase anaphylactic reactions. Their onset of action is slow and they do not have a role in the acute management of anaphylaxis, as they will not reverse the immediate life-threatening effects of anaphylaxis. Common corticosteroids include methylprednisolone, solumetrol, hydrocortisone, solucortef, and dexamethasone, Decadron. Psychological support is a crucial component of management. Anaphylaxis can progress rapidly and has the potential to be a life-threatening event. Patients and their families will need reassurance as you perform the necessary interventions. Many of the patients have experienced similar events and may recognize how serious their condition has become. For others, this may be a first-time event. You must be professional and reassuring and focus on early intervention and transport. Transport decisions. All patients experiencing hypersensitivity reactions should be strongly encouraged to go to the hospital. Even patients with mild symptoms may rapidly progress later on. As many as 20% of patients will have a recurrence of the symptoms within the next 8 hours, even if they have been symptom-free for a period of time. This is true for patients who have had a good response to treatment as well. Consultation in the emergency department allows for observation, discussions around allergist referral, allergen avoidance, and prescription of an EpiPen. Even patients with self-limited mild reactions to allergens should be discharged from the hospital with a prescription to get an EpiPen, because it is impossible to predict future reactions or their severity. Consider early transport if the patient needs resources beyond your capabilities. When the patient has been symptom-free after a period of in-hospital observation times vary between 4 to 8 hours, depending on the patient's clinical condition and circumstances. They will be discharged. On discharge, it should be assured that the patient will have the means to fill the prescription for an EpiPen. Patient education. The best management of anaphylaxis and allergic reactions is to educate patients about prevention and self-preservation. At a minimum, discuss the following topics. How to avoid the antigen. Review information on the offending item. For example, if the patient is allergic to penicillin, he or she should be provided with a list of medications that include penicillin, and the alternative names for penicillin. Medications that may produce a cross-reaction should also be discussed. Notify all health personnel of the allergy. Review the need to alert health personnel to the allergy. This is important because people often think only the physician would need this information, not the paramedic. Wear identification tags or medical alert bracelets. These items notify paramedics of allergies in case the patient is unable to do so. Carry an anaphylaxis kit. A reaction may happen rapidly or worsen before help can arrive. Many anaphylactic reactions require more than one dose of epinephrine, so patients should consider carrying 2 kits or a kit with more than 1 dose. Make sure the patient and his or her family know how to use the kit. Report symptoms early. Ideally, intervention should begin before the situation becomes life-threatening. The patient should recognize that reactions can occur more rapidly and with greater severity with repeated exposures. Biphasic reactions. Explain to patients that they may develop a biphasic reaction, so monitoring for up to 4 to 8 hours after an anaphylactic incident is recommended.
Chapter 28. Musculoskeletal Injuries. Introduction. Musculoskeletal injuries are one of the most common reasons that patients seek medical attention. Physicians in Canada report that almost 6 million hospital visits annually are related to the musculoskeletal system, more than for any other reason. Approximately 1 in 7 Canadians will experience some type of musculoskeletal impairment, leading to missed days of work or school, and costing billions of dollars yearly. In Canada, unintentional falls account for the majority of these injuries, followed by motor vehicle collisions. An estimated 70% to 80% of all patients with multi-system trauma have one or more musculoskeletal injuries. Some areas of public policy, legislative changes, and public education have been effective in reducing the injury problem. For example, efforts related to reducing cell phone use by drivers, improving child safety seat use and availability, and minimizing falls in older people have had positive impacts. Injuries related to the musculoskeletal system are usually easily identifiable because of the associated pain, swelling, and deformity. Although these injuries are rarely fatal, they often result in short or long-term disability. By providing prompt temporary measures, such as splinting and analgesia, you may help reduce the period during which patients are disabled. However, although these injuries may appear dramatic, never focus on the musculoskeletal injury without first determining that no life-threatening injury exists. Never forget the airway, breathing, and circulation. Anatomy and physiology of the musculoskeletal system. The musculoskeletal system gives the body its shape, and allows it to move. It is essential that you understand its basic anatomy and physiology. Functions of the musculoskeletal system. The musculoskeletal system performs many important functions, such as providing support to the soft tissues. It enables erect posture and body movement. The musculoskeletal system also provides protection to critical underlying organs and structures. Remember, damage to the musculoskeletal structure may be a surrogate marker for deeper and more significant injuries. Another important function of the musculoskeletal system is hematopoiesis, the process of generating blood cells. In adults, it most commonly occurs in the red bone marrow of the sternum, ribs, vertebral bodies, pelvis, and the proximal portions of the femur and humerus. Each day, the body produces new red blood cells, white blood cells, and platelets from the stem cells that are present in the bone marrow, thereby replacing those that have been lost or that are no longer functional. The body's scaffolding. The skeleton. The integrated structure formed by the 206 bones of the body is called the skeleton. It may be divided into two distinct portions, the axial skeleton and the appendicular skeleton. The axial skeleton is composed of the bones of the central part, or axis, of the body. Its divisions include the vertebral column, skull, ribs, and sternum. The skull is composed of the cranium, basilar skull, face, and inner ear. The spine is composed of 33 spinal vertebrae, 7 cervical, 12 thoracic, 5 lumbar, 5 fused, sacral, and 4 fused, coccygeal. Moving anteriorly, the thorax is formed by the sternum and 12 pairs of ribs. The appendicular skeleton is divided into the pectoral girdle, the pelvic girdle, and the bones of the upper and lower extremities. Shoulder and upper extremities. The pectoral girdle, also referred to as the shoulder girdle, consists of 2 scapulae and 2 clavicles. The scapula, shoulder blade, is a flat, triangular bone held to the rib cage posteriorly by powerful muscles that buffer it against injury. The clavicle, collarbone, is a slender, S-shaped bone attached by ligaments at the medial end to the sternum, and at the lateral end to the raised tip of the scapula, called the acromion. The clavicle acts as a strut to keep the shoulder propped up. However, because it is slender and very exposed, this bone is vulnerable to injury. The upper extremity joins the shoulder girdle at the glenohumeral joint. The upper arm is formed by the humerus, a bone that articulates proximally with the scapula, and distally with bones of the forearm, the radius and ulna, to form the hinge elbow joint. The radius and ulna make up the forearm. The radius, the larger of the 2 forearm bones, lies on the thumb side of the forearm. The ulna is on the small finger side of the forearm. It is narrow distally but quite thick proximally, where it makes up the protrusion of the elbow. It serves as the pivot around which the radius turns at the wrist to rotate the palm upward, supination, or downward, pronation. Because the radius and the ulna are arranged in parallel, when one is broken, the other is often broken as well. Think of the radius and ulna as a ring. It is very difficult to break a ring in only one location. The hand contains 3 sets of bones: wrist bones, carpals, hand bones, metacarpals, and finger bones, phalanges. The carpals, especially the scaphoid, are vulnerable to fracture when a person falls on an outstretched hand. Phalanges are more apt to be injured by a crushing injury, such as being slammed in a car door. Pelvis and lower extremities. The pelvic girdle is actually 3 separate bones: the ischium, ilium, and pubis, fused together to form the innominate bone. The 2 iliac bones are joined posteriorly by tough ligaments to the sacrum at the sacroiliac joints. The 2 pubic bones are connected anteriorly by equally tough ligaments to one another at the pubic symphysis. These joints allow very little motion, so the pelvic ring is strong and stable. The lower extremity consists of the bones of the thigh, leg, and foot. The femur is the long, thick thigh bone that articulates proximally in the ball and socket joint of the pelvis, and distally in the hinge joint of the knee. The head of the femur is the ball-shaped part that fits into the acetabulum of the innominate bone, the socket of the ball and socket joint. It is connected to the shaft, or long tubular portion of the femur, by the femoral neck. The lower leg consists of 2 bones, the tibia and the fibula. The tibia, shin bone, forms the inferior component of the knee joint. Anterior to this joint is the patella, kneecap, a bone that is important for knee extension. The tibia runs down the front of the lower leg, where it is vulnerable to direct blows, and can be felt just beneath the skin. The much smaller fibula runs posteriorly and laterally to the tibia. The fibula is not a component of the knee joint, but it does make up the lateral knob of the ankle joint, lateral malleolus, at its distal articulation. The foot consists of 3 groups of bones: ankle bones, tarsals, foot bones, metatarsals, and toe bones, phalanges. The largest of the tarsal bones is the heel bone, or calcaneus, which is subject to injury when a person jumps from a height and lands on his or her feet. Characteristics and composition of bone. Bone shapes. Bones may be classified based on their shape. Long bones are longer than they are wide. Examples include the femur, humerus, tibia, fibula, radius, ulna, metacarpals, metatarsals, and phalanges. Short bones are nearly as wide as they are long. They include the carpals and tarsals. Flat bones are thin, broad bones. They include the sternum, ribs, scapulae, and skull. Irregular bones do not fit into one of the other categories, but rather have a shape that is designed to perform a specific function, such as the bones of the vertebral column and the mandible. Round bones are often referred to as sesamoid bones because of their small size and shape, derived from sesamum, the Latin word for sesame seed. They are embedded within a muscle or tendon. The patella is the largest and most well-known sesamoid bone in the human body, although most people have others, usually considered a normal variant. Sesamoid bones are found near joints, where they act like pulleys to assist with joint action. Typical long bone architecture. Long bones have several distinct regions and anatomic features. These bones can grow to such long lengths because of the presence of the growth plate, or physis, in children. Once a person reaches adulthood, the growth plate closes, and the mature adult bone is complete. The long bone is divided into 3 regions: the diaphysis, the epiphysis, and the metaphysis. The articular surfaces of a long bone come in contact with other bones to form articulations, joints. These regions of the bone are covered by articular cartilage, a substance that acts as a cushion to protect the bone from damage and wear. The portion of bone that is not covered by articular cartilage is, instead, covered by the periosteum. This dense, fibrous membrane contains capillaries and cells that are important for bone repair and maintenance. The periosteum also contains the nerve endings that are responsible for the severe pain of bone fractures. In the inner portion of the long bone, blood comes from the nutrient artery of the bone. Once it penetrates the bone's outer cortex, the artery enters the medullary canal, the hollow inner portion of the shaft that is lined by the endosteum, similar to the periosteum, but on the inside, and contains yellow, fatty, marrow in adults. Age-associated changes in bone. Bone ages just like any other tissue of the body, decreasing in density after the age of 35 years, and leading to a loss of height and changes in facial structure. In women, this decrease in density is further accelerated once menopause is reached because of the loss of estrogen, a hormone that helps promote bone formation. A significant decrease in bone density, called osteoporosis, is associated with a higher risk of fracture. People with osteoporosis are at risk for incurring a fracture, especially in the hip, spine, and wrist, with little or no trauma. Other changes associated with aging of bone include aging of muscles, cartilage, and other connective tissues that may also lead to degradation of joints and disc herniation. For example, the water content of the intervertebral discs decreases, increasing the risk of disc herniation. In some joints, the cartilage may become degraded, leading to arthritis and pain. In others, the cartilage becomes calcified, leading to restricted motion. Joints. When two bones come together, they articulate with one another to form a joint. Some joints are fused and allow for no motion, such as the joints of the skull. Other joints allow for motion by permitting movement between the two bones, typically within a certain plane of motion that is defined by the structure of the bones that form it. The various motions that a joint may allow include flexion, extension, abduction, adduction, rotation, circumduction, pronation, and supination. Types of joints. The three general types of joints are fibrous, cartilaginous, and synovial. Fibrous joints, also referred to as synarthrosis or fused joints, contain dense fibrous tissue that does not allow for movement. Examples include the bones of the skull and the distal tibiofibular joint. Cartilaginous joints, also called amphiarthroses, allow for very minimal movement between the bones. The pubic symphysis and the joints connecting the ribs to the sternum are examples of this type of joint. Synovial joints, or diarthroses, are the most mobile joints of the body. They are surrounded by an extension of the periosteum called the joint capsule, and the bones that form them are held in place by very strong ligaments. Within the joint are the articular cartilage, and the synovial membrane, which lines the joint capsule, and secretes synovial fluid into the joint cavity to lubricate it. Bursa. A bursa is a pad-like sac or cavity located within the connective tissue, usually in proximity to a joint. It contains a lubricating fluid that helps reduce the amount of friction between a tendon and a bone or between a tendon and a ligament. Examples include the olecranon bursa of the elbow and the propatellar bursa of the knee. A bursa can become enlarged due to inflammation or from acute trauma resulting in rapid bleeding within. Skeletal connecting and supporting structures. Tendons connect muscle to bone. These flat or cord-like bands of connective tissue are white and have a glistening appearance. Ligaments connect bone to bone, and help maintain the stability of joints, and determine the degree of joint motion. These inelastic bands of connective tissue have a structure similar to that of tendons. Cartilage consists of fibers of collagen embedded in a gelatinous substance. This flexible connective tissue forms the smooth surface over bone ends where they articulate, provides cushioning between vertebrae, gives structure to the nose and external ear, forms the framework of the larynx and trachea, and serves as the model for the formation of the skeleton in children. Cartilage has a very limited neurovascular supply. It receives nutrients through diffusion from the outer covering of the cartilage or from the synovial fluid, so it does not heal well if it is injured. The moving forces. Muscles. Muscles are composed of specialized cells that contract, shorten, when stimulated to exert a force on a part of the body. Three types of muscle are found in the body: skeletal, smooth, and cardiac muscle. Skeletal muscle. Skeletal muscle is also called voluntary muscle, because its contractions are largely under voluntary control, or striated muscle, because it appears striped on microscopic examination. Skeletal muscle includes all of the muscles attached to the skeleton and forms the bulk of the tissue of the arms and legs. It is also found along the spine and buttocks. By maintaining a state of partial contraction, this type of muscle allows the body to maintain its posture, and to sit or stand. It varies greatly in size and shape, from thin strands to the large muscles of the thigh and back. It also constitutes the muscles of the tongue, soft palate, scalp, pharynx, diaphragm, upper esophagus, and eye. Approximately 40% to 50% of normal body weight is skeletal muscle, as it has a high water content. In addition, because of its high metabolic rate and demand for energy and oxygen, skeletal muscle has a very rich blood supply, which causes it to bleed significantly when injured. Skeletal muscles are profoundly affected by the amount of training and work to which they are subjected. Unused muscles quickly atrophy, shrink or waste away, whereas physical training promotes hypertrophy, increase in size. Skeletal muscles are attached to bones by tendons. Tendons cross joints to create a pulling force between two bones when a muscle contracts. The biceps brachii muscle, for example, has its origin on the scapula. One of the biceps tendons passes over the head of the humerus, where it fuses with the body of the biceps muscle. At the distal end of the biceps, a tendon passes over the anterior surface of the elbow and inserts on the radius. Thus, when the biceps muscle contracts, the force causes the elbow to bend, flex. Muscle contraction requires energy. This energy is derived from the metabolism of glucose and results in the production of lactic acid, lactate. Lactic acid, in turn, must be converted into carbon dioxide and water, a process that requires oxygen. For that reason, vigorous muscular activity is often followed by an increase in respiratory and heart rates, which increases oxygen delivery to and carbon dioxide removal from the tissues. The sensation of muscle fatigue occurs when the energy supply to the muscle is inadequate to meet the energy demands. If muscle fatigue occurs as a result of excessive muscular activity, rest produces quick recovery. However, if it occurs from a lack of oxygen, essential nutrients, or electrolytes, such as sodium or calcium, rest will not lead to such a quick recovery. Muscle innervation. Skeletal muscle is innervated by somatic motor neurons. These neurons transmit electrical stimuli to a muscle, which causes it to contract. The combination of the neuron and the muscle cells that it innervates constitutes a motor unit. A motor unit that receives a signal to contract responds as forcefully as possible or does not contract at all. It is an all-or-nothing response. To generate a more forceful contraction, more neurons need to signal more muscle cells to contract, a process called recruitment. Innervation of the upper extremities arises from the brachial plexus. The brachial plexus is formed by a network of nerves that originate from the spinal cord at the C5 to T1 levels. After the fibers of these nerves network with one another, 5 distinct nerves are formed: the axillary, radial, musculocutaneous, ulnar, and median. Innervation of the lower extremities is provided by the lumbar and lumbosacral plexuses, which are formed by the spinal nerves that originate from L1 to S4. The networking of nerves within these two plexuses leads to the formation of multiple distinct nerves, including the femoral nerve and the sciatic nerve, which branches in the popliteal fossa to form the peroneal and tibial nerves. Musculoskeletal blood supply. When a person has a musculoskeletal injury, the arteries that supply the injured region may also be damaged. Therefore, it is important to realize which arteries are present in each part of the extremity. The upper extremity's blood supply originates from the subclavian artery. When the subclavian artery reaches the axilla, it is referred to as the axillary artery. After giving off several branches that supply the shoulder region with blood, the artery leaves the axilla and becomes the brachial artery. After the brachial artery passes through the elbow, it divides into the radial artery and ulnar artery. In the hand, the radial and ulnar arteries form superficial and deep arcades of blood vessels that branch to form the arteries of each finger, the digital arteries. In the lower extremity, the blood supply originates from the external iliac artery. When the external iliac artery reaches the thigh, it travels down the medial aspect as the femoral artery. When it reaches the knee, the femoral artery turns posteriorly and laterally and is referred to as the popliteal artery. The popliteal artery divides into the anterior tibial artery and posterior tibial artery. The anterior tibial artery travels along the anterior and lateral surface of the tibia until it reaches the ankle, where it proceeds along the dorsal surface of the foot toward the great toe, and becomes the dorsalis pedis artery. The posterior tibial artery travels along the posterior aspect of the tibia until it reaches the ankle, where it follows a path just behind the medial malleolus until it reaches the plantar aspect of the foot. Within the foot, arcades of arteries supply the various structures with blood, and give off branches that form the digital arteries of the toes. Patterns and mechanisms of musculoskeletal injury. Skeletal injuries result from blunt and penetrating trauma. In adults and children, motor vehicle collisions, falls, and athletic activities are common causes of injury. Among infants and children, intentional trauma or maltreatment is a common cause of fractures and musculoskeletal injuries. Athletics account for a significant number of musculoskeletal injuries. Injury forces and motions. Direct force. An object that strikes a person will transfer its energy to its point of impact. If the force of the object exceeds the strength of the bone, a fracture occurs. If the point of impact is close to a joint, then there can be a dislocation, which may or may not be associated with a fracture. Soft tissues local to the injury are often contused and occasionally rupture. Penetrating injuries, in addition to soft tissue damage, may lead to a fracture or other musculoskeletal injury. A high-velocity injury, such as that caused by a high-powered rifle, typically severely shatters bone and causes extensive soft tissue damage. Remember, the speed of the penetrating object has more effect than the size of that object. An impalement injury commonly causes a soft tissue injury similar to that seen in a low-velocity penetrating injury. If the impaled object happens to strike a bone, then it may cause a fracture. In any case of impalement, it is essential to stabilize the object to protect the tissues from further injury. Indirect force. An indirect injury occurs when a force is applied to one region of the body, but causes an injury in another region of the body. In this type of injury, the force is transmitted through the skeleton until, at some point, it reaches an area that is structurally weak in comparison with the other parts of the musculoskeletal system through which the force has traveled. For example, a hip fracture may occur when a person's knee strikes the dashboard during a motor vehicle collision. In this case, the force is applied to the knee and travels proximally along the femur. When this force reaches the femoral neck, it causes the femoral neck to fracture. Forces may be transmitted along the entire length of a bone or through several bones in series, and may cause an injury anywhere along the way. Thus, a person falling on an outstretched hand, fuchs injury, may have one or more injuries as a result of forces transmitted proximally from the point of impact. 1. Fracture of the scaphoid bone of the hand, direct blow. 2. Fracture of the distal ulna and radius, Cole's fracture. 3. Fracture dislocation of the elbow. 4. Fracture dislocation of the shoulder, or 5. Fracture of the clavicle. Other injury patterns. Twisting injuries, such as those that commonly occur in football or skiing, result in fractures, sprains, and dislocations. Typically, the distal part of the limb remains fixed, as when cleats or a ski holds the foot to the ground, while torsional force increases in the proximal section of the limb. The resulting force causes tearing of tendons and ligaments and spiral fractures of bone. Fatigue, stress. Fractures are caused by repetitive stress. When they occur in the metatarsal after prolonged walking, marching, or dancing, they are called march fractures. In some cases, a force that might not generally cause harm to normal healthy bone produces a fracture. Such a pathologic fracture occurs when a medical condition, such as metastatic cancer, or the use of corticosteroids cause the bone to become abnormally weak. Older people, particularly those with osteoporosis, also have weaker, more brittle bones, and are more susceptible to fractures than younger people. Some injuries are commonly encountered together because of the way the causative forces are transmitted. Fractures that occur in this manner are called associated fractures. If you find one of these fractures, then look for the others. Pain and swelling over the scaphoid, navicular, bone of the wrist, for example, means that the patient fell hard against an outstretched hand, so he or she may have other injuries anywhere along the axis from the hand to the shoulder. Fractures. A fracture is a break in the continuity of a bone. Fractures occur when the magnitude of the force applied to a bone, a single application or an accumulation of repetitive applications, overcomes the strength of the bone. The strength of a bone is affected by age, osteoporosis, nutritional status, and disease processes. Fracture classification. Fracture type. A fracture may be classified based on the direction that the fracture line travels through a bone, number of fractures on the bone, or number of cortices involved. Fracture classification based on displacement. Fractures may be classified based on the type of displacement. Angulation of a fracture means the ends of the fracture are not aligned in a straight line, and that an angle has formed between them. Angulation may occur in any of the frontal, sagittal, or transverse planes. Open versus closed fractures. In an open fracture, sometimes called a compound fracture, a break in the skin allows the fracture to communicate with the outside environment. Inspect the skin carefully. Even a small break in the nearby skin may be indicative of an open fracture. In a closed fracture, the skin over the fracture site remains intact. In addition to having a higher risk of infection, open fractures have the potential for more blood loss than a closed fracture for two reasons. First, open fractures usually result from high-energy injuries, so they typically involve more soft tissue damage. Second, in most fractures, the periosteal vessels, and the vessels supplying the surrounding soft tissues are disrupted, leading to the formation of a hematoma. In a closed fracture, the increased interstitial pressure within the hematoma compresses the blood vessels, limiting the size of the hematoma. In a closed femur fracture, the blood loss may exceed 1 liter before enough pressure develops to tamponade the bleeding. In contrast, open fractures allow much of the blood to escape, so tamponade does not occur as readily or at all. Signs and symptoms of a fracture. The primary symptom of a fracture is pain that is usually well localized to the fracture site. In addition, the patient may report hearing a snap or feeling a break. Signs of fracture detected on physical examination include the following. Deformity is one of the most reliable signs of a fracture. The limb may be found in an unnatural position or show motion at a place where there is no joint. Compare the deformed limb with the extremity on the other side. Shortening occurs in fractures when the broken ends of a bone override one another. It is characteristic of femur fractures, for example, because the broken femur can no longer serve as a strut to oppose spasms in the powerful thigh muscles. Visual inspection will usually reveal swelling at the fracture site due to bleeding from the broken bone, and the accumulation of fluid. As blood infiltrates the tissues around the broken bone ends, ecchymosis will become apparent. Guarding and loss of use characterize most fractures. The patient will try to keep a fractured bone still and will avoid putting any stress on it. Sometimes the measures a patient takes to protect a fractured bone from movement are so characteristic that one can almost diagnose the fracture without examining the extremity. A patient who walks to the ambulance holding the dorsum of one wrist in the other hand, for example, almost certainly has a Coles fracture. A patient standing with the head cocked toward a knocked-down shoulder probably has a fracture of the clavicle on the side to which the head is leaning. Note that the commonly held belief that the ability to use an injured body part means it is not fractured does not always hold true. Always perform a thorough assessment, and transport any patient with a potential musculoskeletal injury to the emergency department for further evaluation. A fractured bone is almost invariably tender to palpation over the fracture site. Palpation may reveal crepitus, a grating sensation, over the broken bone ends. Crepitus may be noted as an incidental finding during splinting attempts. Avoid excessive manipulation of the injured extremity, as this will cause unnecessary pain. In an open fracture, exposed bone ends may be visible or the wound may be small and innocuous in appearance. Any break in the skin near a fracture should raise suspicion of an open fracture even if you do not see bone. Often, the fracture end ruptures the skin, and then retracts back into the soft tissue. Ligament injuries and dislocations. The shapes of the bones that form a joint and the tightness of the ligaments that hold them in place are key factors in determining a joint's range of motion. When forced beyond their normal limit, the bones that form a joint may break or become displaced, and the supporting ligaments and joint capsule may tear. Dislocations, subluxations, and diastasis. In a dislocation, a bone is totally displaced from the joint and the articular surfaces are no longer in contact. Typically, at least part of the supporting joint capsule, and some of the joint's ligaments are disrupted. Dislocations occur when a body part moves beyond its normal range of motion. The dislocated bones are then held in position by muscle spasms. Evaluation of the patient usually reveals an obvious and significant deformity, a significant decrease in the joint's range of motion, and severe pain. In all cases of dislocation, a fracture should be suspected until ruled out by radiographs. The partial dislocation of a joint is called a subluxation. In this type of injury, the articular surfaces of the bones that form the joint remain partially, but not completely, in contact. In some cases, part of the joint capsule and supporting ligaments may be damaged. Despite the subluxation, the patient may be able to move the joint to some degree. Failure to recognize and treat a subluxation may lead to persistent joint instability and pain. When the ligaments that hold two structures in a fixed position with respect to one another are disrupted, and the space between them increases, a situation known as a diastasis occurs. An example of this would be an injury to the ligaments that hold the pubic symphysis together, causing the width of the joint to increase, diastasis of the pubic symphysis. The principal symptom of a dislocation is pain or a feeling of pressure over the involved joint, plus loss of motion of the joint. A patient with a posterior dislocation of the shoulder, for example, is unable to raise the arm but holds it against the side instead. Sometimes the joint will seem frozen. The principal sign of dislocation is deformity. A dislocation is considered an urgent injury because of its potential to cause neurovascular compromise distal to the site of injury. If the dislocated bone presses on a nerve, there may be numbness or weakness distally. If an artery is compressed, there may be absent distal pulses, such as in a knee dislocation occluding the popliteal artery. For these reasons, you should always assess the patient's neurovascular status distal to the site of dislocation, check pulse, motor, and sensory functions prior to and after splinting. Sprains. Sprains are injuries in which ligaments are stretched or torn. They usually result from a sudden twisting of a joint beyond its normal range of motion that also causes a temporary subluxation. Most sprains involve the ankle or the knee because most occur after a person misjudges a step or landing. Evasive moves, like those done during an athletic event, commonly cause sprains in athletes. Sprains are typically characterized by pain, swelling, and discoloration over the injured joint and unwillingness to use the limb. In contrast with fractures and dislocations, sprains usually do not involve deformity, and joint mobility is usually limited by pain, not by joint incongruity. Because it may be difficult to differentiate among the various types of injuries in the pre-hospital environment, it is best to err on the side of caution, and treat every severe sprain as if it was a fracture. General treatment of sprains is similar to that of fractures, and includes the following. Remember the mnemonic priced. 1. Protect. Wrap or splint the injured area. 2. Rest. Avoid use of the injured area, reduce or protect weight bearing. 3. Ice. Place ice or a cold pack over the injury. 4. Compression. Compression can be applied with an elastic bandage, usually at the hospital once radiography rules out a fracture. 5. Elevation. Elevate to minimize swelling of the injured area. 6. Drugs. Provide pain management as soon as practical. Muscle and tendon injuries. Strains. A strain, pulled muscle or tendon, is an injury to a muscle and/or tendon that results from a violent muscle contraction or from excessive stretching. Often, deformity is not present and only minor swelling is noted at the site of injury. Some patients may report increased pain with passive movement of the injured extremity. Local or dependent bruising can start to show up within hours of strains as the tearing of muscle fibers produces bleeding under the soft tissue. Achilles tendon rupture. A rupture of the Achilles tendon usually occurs in adults older than 30 years who are involved in start and stop sports such as basketball or football. The most immediate indications are pain from the heel to the calf, and a sudden inability to plantar flex the foot. As time passes, the calf muscles begin to contract proximally and a deformity within the calf may develop. Additionally, there is often ecchymosis of the skin in the posterior calf, and there can be a palpable defect along the length of the tendon. The Thompson test can be performed in the pre-hospital setting to identify an Achilles tendon rupture. To perform this test, have the patient assume a prone position, and then squeeze the calf muscles of the injured leg. If the foot plantar flexes while squeezing, the tendon is at least partially intact. If there is no movement of the foot, then the Achilles tendon has likely been torn. Pre-hospital management of an Achilles tendon injury involves the priced mnemonic just described. These injuries are treated with surgery or multiple casts and can require up to 6 months for recovery. Inflammatory processes. When a muscle is subjected to frequent and repetitive use, its tendons or nearby bursae are at risk for becoming inflamed. When inflammation of the tendon causes pain, the patient is said to have tendinitis. There will typically be point tenderness on the inflamed tendon, with pain often increasing if the person performs the movement that led to the inflammation. The most common example of this is shoulder tendinitis, which is exacerbated by activities that require raising the arm above the shoulder. When a bursa becomes painful and inflamed, it is called bursitis. Patients with bursitis often report pain in the region of the inflamed bursa, especially with motions that cause the space where the bursa sits to become smaller. Examination of the site may reveal tenderness, swelling, erythema, and warmth. Tendinitis and bursitis are treated in the pre-hospital environment with priced. Many patients will require long-term management with steroid injections from their physicians. Arthritis. Arthritis means inflammation of a joint. Arthritis can have multiple etiologies and presentations and can lead to joint destruction, sepsis, and death in the worst cases. The 3 most common types of arthritis are osteoarthritis, rheumatoid arthritis, and gouty arthritis. Osteoarthritis is a disease that occurs as joints age and begin to wear. It is characterized by pain and stiffness, which typically get worse with use, and cracking or crunching of the affected joints. The spine, hands, knees, and hips are the most commonly affected sites. In general, the risk of developing osteoarthritis increases with age, but other factors also increase the risk, such as obesity and prior joint injury. Treatment of osteoarthritis involves low-impact physical therapy, pain control, anti-inflammatory medications, joint injections, and, in severe cases, joint replacement surgery. Rheumatoid arthritis is a systemic inflammatory disease that affects joints and other body systems. Rheumatoid arthritis can be a mild, non-progressive disease or can be a full-blown, fatal illness. In rheumatoid arthritis, significant bone erosion at the affected joints makes them more susceptible to fractures and dislocations. Of particular concern is the cervical spine, which is at high risk of subluxating following trauma or during intubation. Gout, or crystal-induced arthritis, is a recurrent condition in which the body has difficulty eliminating uric acid, hyperuricemia, and the result is buildup of the salts of uric acid. When the concentration of uric acid in the blood becomes too great, then uric acid may crystallize within a joint. The patient will then have a hot, red, swollen, and exquisitely tender joint with decreased range of motion. Gout very often manifests in the great toe. Pre-hospital treatment involves immobilization, pain relief, and transportation to an emergency department, where the fluid in the joint can be aspirated to search for the characteristic crystals of gouty arthritis. Injuries that may signify fractures. Amputations. An amputation is the separation of a limb or other body part from the remainder of the body. The amputation may be incomplete, leaving only a small segment of tissue connecting the part, or it may be complete, causing the part to be fully separated. Hemorrhage from complete or incomplete amputations can be severe and life-threatening. Fractures may also be present with amputations. Amputations are discussed in more detail in Chapter 22. Open wounds. Open wounds, in particular deep lacerations, impaled objects, or penetrating injuries, indicate high-energy injuries that may involve sufficient force to damage the bones below. In addition, open wounds may be caused by fractured bone ends themselves. Determine the mechanism of injury. If it is suggestive of significant trauma, then maintain a high index of suspicion for fracture or injuries to other deep structures. Vascular injuries. When blood vessels are damaged following a musculoskeletal injury, devascularization of the body part that is supplied by the vessel may occur. The types of injuries that a vessel may sustain include a contusion of the vessel wall, laceration, kinking, or bending, and formation of pseudoaneurysms, leakage of blood through the vessel wall into a contained cavity. In addition, a blood vessel may thrombose, become occluded by a clot, when the injury causes blood flow to become very slow. Regardless of the type of vascular injury involved, it is important to assess and reassess pulses, control bleeding, and maintain adequate intravascular volume by using intravenous fluid. General principles of assessment and management. As always, when assessing an injured patient, do not be distracted by visually impressive injuries. It is essential to complete the initial assessment of the patient before focusing on the extremities. In cases of musculoskeletal injuries, patients may be classified based on the presence or absence of associated injuries. Life or limb-threatening injury or condition, including life or limb-threatening musculoskeletal trauma. Life-threatening injuries, and only simple musculoskeletal trauma. Life or limb-threatening musculoskeletal trauma, and no other life-threatening injuries. Isolated, non-life or non-limb-threatening injuries. Volume deficit due to musculoskeletal injuries. Fractures may lead to significant blood loss from injury to vessels within the bone and surrounding musculature. In some cases, large blood vessels in the region of the fracture can also be damaged. When caring for patients with fractures, undertake interventions such as applying direct pressure, splinting, and administering intravenous fluids to prevent development of hemorrhagic shock. Table 28-4 lists the potential blood loss from various fracture sites, and may serve as a guideline for estimating the amount of resuscitation required. The goal of pre-hospital management should be to keep the patient's volume, vital signs, and mental status normal while expediting transport to the hospital. Principles of assessment. As with all patients, you should conduct a scene assessment, focusing on safety and body substance isolation precautions, and then proceed to an initial assessment focusing on the patient's mental status, airway, breathing, and circulation, and transport priority. If the initial assessment indicates the patient does not have an immediate life-threatening condition, and only localized musculoskeletal trauma, continue with a focused history and physical examination. If the patient has a significant mechanism of injury, complete a rapid trauma assessment, and perform a detailed physical examination en route to the emergency department. Your priorities throughout the assessment and management of musculoskeletal injuries should include identifying the injuries, preventing further harm or damage to the injured structures and surrounding tissues, supporting the injured area, and administering pain medication if necessary. History of present injury. Obtain information about the incident that led to the injury from the patient, and any bystanders who witnessed it. In particular, determine the condition of the patient immediately before the incident, the details of how and why the incident occurred, what, if any, safety equipment was used, and the patient's position after the incident. Also, ask the patient for a subjective description of the injury. How did this happen? Did you hear a pop? Do you have pain? What functional limitations do you now have? Medical history. Obtain the patient's medical history using the standard sample format. This history should also identify any pre-existing musculoskeletal disorders or injuries. Some information obtained will be very relevant to the injury, for example, if the patient is taking anticoagulant medications. Examination. When examining the patient, obtain a baseline set of vital signs. The focus can then shift to evaluating the injured extremity. One of the most effective methods to assess an extremity is to compare one side with the other, noting any discrepancy in length, position, shape, or skin color. Next, complete an examination noting decap BDLS, deformity, contusions, abrasions, penetrating injury, burns, tenderness, lacerations, swelling, as you observe, and palpate the soft tissue from head to toe, and assess the patient for limitations, such as inability to move a joint. While performing the examination, be sure to cover the 6 Ps of musculoskeletal assessment. Pain, paralysis, paresthesias, numbness or tingling, pulselessness, pallor, pale or delayed capillary refill in children, and pressure. During the secondary assessment is the time to consider distracting injuries, that is, the injuries that are immediately obvious. In the case of an obvious open fracture of the femur, a patient might direct you only to the site of greatest pain. Distal extremity injuries, fractures and dislocations of the feet and hands, are classically overlooked due to a distracting injury. Pain. A person experiences acute pain when peripheral pain receptors, nociceptors, convert painful stimuli into electrical impulses that are transmitted via the peripheral nerve fibers to the spinal cord. The signal ascends along the spinal cord to the pain-sensing region of the brain. When a tissue is injured, various chemical mediators are released from the damaged cells that facilitate the conduction of the painful stimulus to the brain. When assessing a patient's pain, remember the OPQRST mnemonic. Onset of the pain. Provoking or palliating factors. Quality of the pain, such as sharp, pressure, crampy. Region of the pain, including its primary location and areas where pain radiates or refers, severity of the pain, and the time, duration, that the patient has been experiencing pain, as well as how it has progressed over time, improved, stayed the same, worsened. It is also useful to have the patient quantify the severity of the pain by using a scale of 1 to 10 or with visual images, such as faces that appear to be happy or in pain. Inspection. When inspecting an injured extremity, always evaluate the joint above and the joint below the site of injury because the injuring force may have affected these sites as well. While inspecting a patient's injuries, look for the following signs. Deformity, including asymmetry, angulation, shortening, and rotation. Skin changes, including contusions, abrasions, avulsions, punctures, burns, lacerations, and bone ends. Swelling. Muscle spasms. Abnormal limb positioning. Increased or decreased range of motion. Color changes, including pallor and cyanosis. Bleeding, including estimating the amount of blood loss. Palpation. Like inspection, palpation of an injured extremity should include the injury site, and the regions above and below it. Regions of point tenderness should be identified. Reassess any tender areas frequently to determine whether there are changes in the location or severity of the elicited pain. Note, although the terms pain and tenderness are often used interchangeably, pain actually refers to the symptom a patient feels without palpation, and tenderness is a sign that is elicited when palpation generates pain or discomfort. Although point tenderness is one of the best indicators of an injury, healthcare providers should appreciate that it may be absent in patients who are intoxicated or who have an injury to the spinal cord. When palpating an injured site, attempt to identify instability, deformity, abnormal joint or bone continuity, and displaced bones. Feel for crepitus, which may be found at the site of a fracture, but do not actually try to elicit it. Simply note if it is palpable during your physical exam. Palpate distal pulses on all extremities, with special attention to comparing the strength of the pulses in the injured extremity with those in the normal one. On occasion, an arterial injury may be identified while palpating an extremity. Signs of an arterial injury include a pulsatile expanding hematoma, diminished distal pulses, a palpable thrill, vibration, over the site of injury that correlates with the patient's heartbeat, and difficult to control bleeding. This is a serious finding that should prompt rapid transport if it has not already been initiated. The upper and lower extremity examination should include palpation of the entire length of each arm and leg to identify any sites of injury. The most efficient way to palpate these body parts is to place your hands around the extremity and squeeze. Repeat this procedure every few centimeters until you reach the end of the extremity. While this is a fast way to find areas of tenderness, when a potential injury is identified, take on a more focused approach to determine specific injuries. When evaluating the upper extremities, always examine the cervical spine and shoulder because complaints within the arm may be caused by a more proximal injury. Likewise, with the lower extremities, always conduct an examination of the pelvis and hip if the patient reports pain in the leg. Motor function and sensory examination. In the case of a musculoskeletal injury, it is essential to assess a patient's distal pulse as well as motor and sensory function. When assessing sensory and motor function, consider the baseline, pre-injury, level of function. In some cases, weakness or motor deficits may be due to prior injuries, strokes, surgeries, or medical problems. Altered sensation can arise from diabetes or nerve disorders. For this reason, you should perform a careful review of the patient's history whenever a patient reports weakness, altered sensation, or inability to move an extremity. While performing a motor examination, perform each test with and without resistance because some patients may be too weak to overcome any outside resistance. Also, perform the test on both sides of the body simultaneously so that each extremity can be compared. When assessing sensation, it is important to assess not only for the presence or absence of sensation, but also for quality and symmetry. To perform a sensory examination, first ask the patient if he or she feels any abnormal sensations, such as numbness, tingling, or burning. Next, conduct a gross sensory examination by lightly touching the injured extremity and the unaffected side simultaneously. Have the patient report whether the two sides feel the same or different. In some cases, a patient may report an abnormally severe sensation of pain with just light palpation of the injury. Such hyperalgesia may be a sign of damage to the spinal cord. Skill Drill 28-1 shows the steps for performing a motor function and sensory examination. Skill Drill 28-1. Performing a motor function and sensory examination. Step 1. Have the patient flex his or her arms at the elbow to test musculocutaneous nerve motor function. Step 2. Have the patient extend the arms at the elbow to test radial nerve motor function. Step 3. Have the patient extend the thumbs up, to test distal radial nerve motor function. Step 4. Have the patient make an OK sign to test median nerve motor function. Step 5. Have the patient spread his or her fingers apart to test ulnar nerve motor function. Step 6. Instruct the patient to extend his or her legs at the knee to test femoral nerve motor function. Step 7. Have the patient flex his or her feet and ankles downward, plantar flex, to test tibial nerve motor function. Step 8. Instruct the patient to flex the feet and ankles upward opening parenthesis. Dorsiflex. Closing parenthesis to test deep perineal nerve motor function. Step 9. Lightly touch the lateral surface of the shoulder, over the deltoid, to test axillary nerve sensory function using the corner of a bandage or tissue to make contact with the skin. Step 10. Lightly touch the anterolateral surface of the forearm to test musculocutaneous nerve sensory function. Step 11. Lightly touch the dorsal surface of the web space of the thumb to test radial nerve sensory function. Step 12. Lightly touch the volar surface of the distal thumb, index, and middle fingers to test median nerve sensory function. Step 13. Lightly touch the distal volar surface of the small finger to test ulnar nerve sensory function. Step 14. Lightly touch the anteromedial surface of the thigh to test femoral nerve sensory function. Step 15. Lightly touch the plantar surface of the toes to test tibial nerve sensory function. Step 16. Lightly touch the web space between the great toe and the second toe to test perineal nerve sensory function. This is the end of skill drill 28-1. General interventions. The overall goal in the treatment of a musculoskeletal injury is to identify the type and extent of the injury, and to create a biologic environment that maximizes the normal healing process of the injured structure. This process begins in the pre-hospital environment with a thorough assessment of the patient, and proper immobilization of injuries to prevent further harm. Pain control. Orthopedic injuries are associated with pain that may be caused by continued movement of an unstable fracture, muscle spasm, soft tissue injury, nerve injury, or muscle ischemia. These injuries are often extremely painful, so the goal of pre-hospital pain control should be to diminish the patient's pain to a tolerable level. A number of interventions may be performed in the pre-hospital setting to control pain from a musculoskeletal injury. The first step is to assess the level of pain. Although perception of pain varies significantly from person to person, getting a baseline severity score gives you a mechanism for assessing the effects of your interventions on each particular patient. Simple methods for controlling pain include splinting in an anatomic position, resting and elevating the injured part, and applying ice or heat packs. When simple procedures do not effectively control a patient's pain, consider the administration of an analgesic agent. Analgesics used in the pre-hospital environment include narcotics, such as fentanyl and morphine, acetaminophen, nonsteroidal anti-inflammatory drugs, NSAIDs, and nitrous oxide. An increasingly used dissociative agent, ketamine, can also be extremely effective in complementing pain control. These agents should be reserved for patients in hemodynamically stable condition who have an isolated musculoskeletal injury. Obtain vital signs before and after administering any medication for pain, and monitor the patient's respiratory status for signs of respiratory depression. After pain medication is administered, reassess the patient's pain to ensure that pain relief is adequate. Anti-inflammatory agents can have an important role in pre-hospital pain management. When part of the body has been injured, the body's own inflammatory system is activated as part of the repair process. Inflammatory mediators cause pain, so temporarily interrupting the inflammatory process can alleviate pain. Ketorolac, Toradol, is a nonsteroidal anti-inflammatory drug for mild to moderately severe pain, and can be delivered by paramedics via the intramuscular or intravenous route. It must be used cautiously in some patients, has a number of contraindications, and should not be used in the setting of uncontrolled or internal bleeding. Emergency medical services providers should follow their medical protocols or consult their medical director regarding use of nonsteroidal anti-inflammatory drugs in the setting of traumatic injury. Administering pain medication before splinting may allow the extremity to be immobilized more effectively. Remember, it hurts to have an injured extremity held in the proper position for splinting. Pain medication may make it possible for the patient to tolerate that position longer and allow the splint to be applied properly. Cold and heat application. Cold packs are useful for treating patients during the initial 48 hours following an injury, and are very effective at decreasing pain and swelling. Cooling the injured area causes vasoconstriction of the blood vessels in the region, and decreases the release of inflammatory mediators. As a result, swelling and inflammation are reduced when cold packs are used during the acute stage of an injury. Conversely, heat therapy should not be used during the initial 48 to 72 hours following an injury because it may actually increase pain and swelling during this period. Once the acute phase of the injury ends, and the damaged blood vessels become clotted, heat packs are useful for increasing blood flow to the region to decrease stiffness, and to promote healing. As a consequence, heat packs may be beneficial for patients who report an injury that occurred several days before contacting paramedics. Splinting. Splinting is intended to provide support to, and prevent motion of, the broken bone ends, and two adjacent joints. Correctly splinting an injured extremity not only decreases the pain a patient experiences, but also reduces the risk of further damage to muscles, nerves, blood vessels, and skin. In addition, splinting helps to control bleeding by allowing clots to form where vessels were damaged. When a patient with multiple orthopedic injuries must be transported immediately, you will not have time to splint each fracture one by one. In this case, immobilize injuries as best as you can, but recognize that this is a patient who must reach definitive care urgently. Principles of splinting. Splinting is one of the most crucial skills to learn when caring for patients with musculoskeletal injuries. Failure to properly splint an injured extremity leads to unnecessary discomfort, and the possibility of further injury or harm. Allowing a closed fracture in the distal tibia to become an open fracture owing to mishandling or improper splinting will result in the need for surgery, and a hospital stay and may increase the patient's complication rate and rehabilitation time. Keep the following points in mind when applying a splint. 1. The injured area must be adequately visualized before splinting. Remove clothing as necessary so that you can inspect the area thoroughly. 2. Assess and record distal pulse, motor, and sensory functions before and after splinting. 3. Cover all wounds with a dry, sterile dressing before applying the splint. To prevent infection following an open fracture, you should brush away any obvious debris on the skin surrounding an open fracture before applying a dressing. Do not enter or probe the open fracture site in an attempt to retrieve debris, because doing so may lead to further contamination. Do not attempt to push exposed bone ends back under the skin. 4. Do not move the patient before splinting unless an immediate hazard exists. 5. For fractures, the splint must immobilize the bone ends, and the two adjacent joints. For dislocations, the splint must extend along the entire length of the bone above and the entire length of the bone below the dislocated joint. 6. Pad the splint well to prevent local pressure, and to provide optimal motion restriction. 7. Support the injured site manually with one hand above and one hand below the injury, and minimize movement until the splint is applied and secured. 8. If a long bone fracture is severely angulated, then gently apply longitudinal traction, tension, to attempt to realign the bone into a more natural position, and improve circulation. Use a smooth, firm grip to apply manual traction, and take care to avoid any sudden, jerky movements of the limb. Do not attempt to straighten fractures involving joints without first obtaining medical direction. The pain associated with straightening an unstable joint injury generally outweighs the benefits of doing so in the field, unless there is a loss of distal circulation, in which case it makes sense to attempt repositioning of the injured joint. 9. If the patient can tolerate it, splint the knee straight if not directly injured and angulated, splint the elbow at a right angle. 10. If the patient reports severe pain or is resistant to movement, then discontinue applying traction, splint in the position of deformity, and carefully monitor the distal neurovascular status, pulse, motor, and sensory. 11. Splint firmly, but not so tight as to occlude the distal circulation. 12. If possible, do not cover fingers and toes with the splint to allow for monitoring of skin color, temperature, and condition. 13. If possible, apply cold packs and elevate the splinted limb to minimize swelling. 14. When the patient has a life-threatening injury, individual splint application for possible fractures must not delay transport and might not be accomplished. Types of splints. Any device used to immobilize a fracture or dislocation is considered a splint. Commercially available splints include board splints, inflatable or vacuum splints, and traction splints. Lack of a commercially made splint should never prevent proper immobilization of an injured patient. Multiple casualties may tax the resources of even the best equipped ambulance, requiring improvisation. Rigid splints. A rigid splint is any inflexible device that may be attached to a limb to maintain stability, a padded board, a piece of heavy cardboard, or an aluminum ladder or SAM splint molded to fit the extremity. More elaborate rigid splints are designed to quickly fit around 2 or 3 sides of an extremity, and be secured with self-adhesive, Velcro, straps or cravats. Some rigid splints are made of a radiolucent material that allows radiographs to be obtained without removal of the splint. Whatever its construction, the splint must be generously padded to ensure even pressure along the extremity, and long enough to be secured well above and below the fracture site, beyond the proximal and distal joints. When applying a rigid splint, gently grasp the extremity above and below the fracture site. Your partner should then place the splint alongside the limb. While one of you continues to support the extremity, the other one should wrap the limb and splint in self-adhering bandages that are tight enough to hold the splint firmly to the extremity but not so tight as to occlude circulation. If the splint has its own straps that are used to secure it to the extremity, this step is not required. Leave the fingers or toes out of the bandage so that distal circulation can be monitored. Sling and swath. An arm sling may be fashioned from a triangular bandage, and is useful to immobilize injuries that involve the shoulder or as an adjunct to a rigid splint of the upper extremity. The sling holds the injured part against the chest wall, and takes some of the weight off the injured area. To apply a sling for a lower arm or shoulder injury, place the splinted extremity in a comfortable position across the chest with the elbow flexed and lay the long edge of a triangular bandage along the patient's side opposite the injury. Bring the bottom edge of the bandage up and over the forearm, and tie it at the side of the neck to the other end. Tie or pin the pointed end of the sling at the elbow to form a cradle. Secure the sling so that the hand is carried slightly higher than the elbow, and the fingers are visible for checking peripheral circulation. To apply a sling for a suspected humerus fracture, once again place the injured extremity in a comfortable position across the chest with the elbow flexed. For this sling, fold the triangular bandage until it is approximately 5 to 10 centimeters wide. Place the triangular bandage so that it supports the lower arm and wrist, and once again tie the two ends of the triangular bandage at the side of the patient's neck. This is beneficial for humerus fractures because it allows gravity to do the job of applying traction, bringing the fracture into a more anatomic position. An arm that is supported with either type of sling can be further immobilized by adding a swath. Create a swath by using one or more triangular bandages to secure the arm firmly to the chest wall. This technique is particularly useful for injuries to the clavicle, and for anterior dislocations of the shoulder. Do not use a sling if the patient has a neck injury. Be careful not to secure the swath so tight as to reduce chest expansion during respirations. Pneumatic splints. Pneumatic splints, also known as air splints or inflatable splints, are useful for immobilizing fractures involving lower leg or forearm. They are not effective for angulated fractures or for fractures that involve a joint because they will forcefully attempt to straighten the fracture or joint. Likewise, air splints should not be used on open fractures in which the bone ends are exposed. Air splints offer two distinct advantages. In addition to immobilizing the fracture, they can help slow bleeding and minimize swelling by applying pressure to decrease small vessel bleeding. The method of application for an air splint depends on whether it is equipped with a zipper. If it is not, then gather the splint on your own arm so that its proximal edge is just above your wrist. Grasp the patient's hand or foot while your partner maintains proximal countertraction, then slide the air splint over your hand, and onto the patient's extremity. Position the air splint so that it is free of wrinkles. Then, while you continue to maintain traction, your partner should inflate the splint with a commercially available device that is compatible with the splint system. Do not use a compressed air tank to inflate an air splint. If the air splint has a zipper, then apply it to the injured area while your partner maintains traction proximally and distally. Once applied, zip it up and inflate. In either case, inflate the splint just to the point at which finger pressure will make a slight dent in the splint surface. You must watch air splints carefully to ensure that they do not lose pressure or become overinflated. Overinflation is particularly likely when the splint is applied in a cold area, and the patient is subsequently moved to a warmer area because the air inside the splint will expand as it gets warmer, possibly increasing pressure, and causing pulses to cease. Air splints will also expand when going to a higher altitude if the patient compartment is unpressurized, a factor that must be considered when patients are transported by air ambulance. Vacuum splints. A vacuum splint consists of a sealed plastic container that is filled with air and thousands of small plastic beads. The device is wrapped around or otherwise formed to the limb being treated. A suction pump attached to the splint is then used to evacuate the air from inside. The resulting evacuation of air from inside the device compresses the beads in such a way that the whole splint becomes rigid, much like a plaster cast that has been molded to conform to the contours of the area of the body to which the splint is applied. The vacuum mattress, which is applied to the entire patient by laying the patient on the mattress, is an excellent splint, but there are a few factors that may limit its broad appeal. The splint is quite bulky, so it not only takes up a lot of storage room in the vehicle, but also can be difficult to work with in cramped quarters. Furthermore, like all vacuum splints, it requires a mechanical suction pump, yet another piece of equipment to grab. A smaller vacuum splint is available to splint individual limbs. This type of splint is applied by positioning the injured limb on the splint, and then evacuating the air from inside of it. The result is a splint that is molded to the extremity. This type of vacuum splint requires less space than a mattress-style vacuum splint, but is still relatively expensive compared with standard rigid splints. Traction splints. Following a femur fracture, the strong muscles of the thigh go into spasm, which often leads to significant pain and deformity. Traction splints provide constant pull on a fractured femur, thereby preventing the broken bone ends from overlapping as a result of unopposed muscle contraction. In addition, these splints help maintain alignment of the fracture pieces, and provide effective immobilization of the fracture site. As a result, patients are likely to experience less pain. Traction splints also reduce blood loss. Normally, the thigh is shaped like a cylinder. In a femur fracture, the thigh is shortened and becomes spherical. The volume of a sphere can be substantially greater than that of a cylinder, so a person with an untreated femur fracture can accumulate more blood in the thigh than a person whose thigh is pulled out to length by a traction splint. Traction splints are indicated for the treatment of mid-shaft femur fractures. They should not be used when the patient has an additional fracture at or below the knee or on the same extremity. They are also contraindicated in suspected pelvic fractures. The most commonly used traction splints are the Sager and the Hare devices. The basic principles of application are the same for both. After assessing the injured extremity for distal pulse, motor, and sensory functions, have one paramedic stabilize the leg, and apply manual traction while the other prepares the splint. Place the splint next to the uninjured leg to determine the proper length. The traction splint should extend 15 to 25 centimeters beyond the foot. Position the splint gently and apply the thigh or ischial and ankle straps. Once secured in place, apply gentle longitudinal traction using enough force to realign the extremity. Place the leg support straps, confirm that the thigh or ischial and ankle straps are still secure, reassess pulse, motor, and sensory functions, and prepare the patient for transport. Buddy splinting. Buddy splinting is used to splint injuries that involve the fingers or toes. With this technique, an adjacent uninjured finger or toe serves as a splint to the injured one. To buddy splint, tape the injured digit to an uninjured one. Place a gauze pad between the digits that are taped together, and ensure that the tape does not pass over joints. Ensure the tape is not so tight as to cut off circulation. Complications of musculoskeletal injuries. Musculoskeletal injuries can lead to numerous complications, not just those involving the musculoskeletal system, but also systemic changes or illness. It is essential to not focus all of your attention on the musculoskeletal injury. Keep in mind that there is a patient attached to the injured extremity. The likelihood of having a complication is often related to the strength of the force that caused the injury, the injury's location, and the patient's overall health. Any injury to a bone, muscle, or other musculoskeletal structure is likely to be accompanied by bleeding. In general, the greater the force that caused the injury, the greater the hemorrhage that will be associated with it. Infection. Following a fracture, the sharp ends of the bone may damage muscles, blood vessels and nerves, or the ends may penetrate the skin and produce an open fracture. Infection of a fracture site can have devastating complications, ranging from deep infections of the bone, osteomyelitis, to systemic infections, and potential death. To prevent infection following an open fracture, irrigate generously with sterile saline or water to remove any obvious debris on the skin surrounding an open fracture before applying a dressing. Do not enter or probe the open fracture site in an attempt to retrieve debris because this may lead to further damage and contamination. Neurovascular injuries. The skeletal system normally protects the neurovascular structures within the limbs from injury. These critical structures typically lie deep within the limb and close to the skeleton. For example, the brachial plexus is situated within the axilla, and the inner aspect of the arm, shielded from injury by the shoulder girdle. However, when the shoulder girdle or proximal humerus is fractured, displaced fracture fragments may lacerate or impale the nerves of the plexus, leading to a neurologic deficit. Neurovascular injuries are also likely to occur following a joint dislocation because the nerves and vessels in the region of a joint tend to be more securely tethered to the soft tissues, and are less likely to escape injury. This outcome is particularly common following knee joint dislocations. Compartment syndrome. Within a limb, groups of muscles are surrounded by an inelastic membrane called fascia. Thus, the muscles are confined to an enclosed space, or compartment, that can accommodate only a limited amount of swelling. When bleeding or swelling occurs within a compartment for any reason, but typically because of a fracture or severe soft tissue injury, the pressure within it rises. Pressure that is too high may prevent blood flow in vessels supplying the muscles within the same fascial compartment. This reduced blood flow leads to muscle ischemia and then possible subsequent muscle death, with symptoms including severe pain, tenderness, and sensory changes. This condition, known as compartment syndrome, is one of the most devastating consequences of a musculoskeletal injury. External and internal factors can lead to the development of compartment syndrome. External factors include bandages, splints, or casts that are applied too tightly and restrict circulation. A number of internal factors can also increase the amount of material within a compartment. For example, bleeding within a compartment may occur because of a fracture, dislocation, crush injury, vascular injury, soft tissue injury, bleeding disorder, or snake bite, though this is unusual. Alternatively, fluid leakage or edema may occur secondary to ischemia, excessive exercise, trauma, burns, or any condition associated with the leakage of proteins and fluid from vessels into the interstitial space. A common misconception is that open fractures are safe from compartment syndrome. It is important to understand that this is not true. Signs and symptoms of compartment syndrome include early and late findings. Typically, the first complaint is a searing or burning pain that is localized to the involved compartment, and out of proportion to exam findings, and the mechanism of injury. This pain is often severe and typically not relieved with pain medication, including narcotics. When examining the patient, passive stretching of an ischemic muscle will result in severe pain, as will attempts to actively use it. In the lower leg, test for this condition through flexion and extension of the great toe, and through dorsiflexion and plantar flexion of the foot. In the forearm, use finger and hand flexion and extension. During examination of the patient, the affected area may feel very firm, and there may be skin pallor. Typical neurologic changes include paresthesias, such as a burning sensation, numbness, or tingling, and paralysis of the involved muscles, which occurs late in the condition. Another late sign of compartment syndrome is pulselessness. If a plaster cast has been applied, then check pulses and check sensory and motor function distal to the cast terminus. By the time the pressure within the compartment reaches the point where it totally occludes the artery passing through it, significant muscle necrosis has probably occurred. The presence of peripheral pulses does not exclude the possibility of compartment syndrome. The goal of pre-hospital care is to deliver the patient to an emergency facility before the extremity is pulseless. Thus, management should include elevating the extremity to heart level, not above, placing cold packs over the extremity, and opening or loosening constrictive clothing and splint material. Thromboembolic disease. Thromboembolic disease, including deep vein thrombosis and pulmonary embolism, is a significant cause of death following musculoskeletal injuries, especially injuries to the pelvis and lower extremities that lead to prolonged immobilization. Signs and symptoms of deep vein thrombosis include disproportionate swelling of an extremity, discomfort in an extremity that worsens with use, and warmth and erythema of the extremity. When a portion of a deep vein thrombosis dislodges, it may cause a pulmonary embolism, a blood clot that travels to, and occludes, a pulmonary artery. Signs and symptoms of a pulmonary embolism include a sudden onset of dyspnea, pleuritic chest pain, either side, syncope, tachypnea, tachycardia, low-grade fever, right side heart failure, shock, and, in some cases, cardiac arrest. In addition to the risk of deep vein thrombosis, patients with long bone or pelvic fractures are at risk for developing a fat embolism. In this condition, fat droplets from the bone marrow enter the circulation and become lodged in arteries throughout the body, most commonly the lungs, brain, and skin. Generally, symptoms begin within 12 to 72 hours of injury. When a fat embolism lodges within the pulmonary arteries, symptoms may be similar to those of a pulmonary embolism. When other organs are involved, signs and symptoms may include altered level of consciousness, ranging from agitation to coma, skin petechiae, or fever. Treatment for thromboembolic disease in the pre-hospital setting is limited to maintaining an airway, adequate oxygenation, and intravascular volume, and rapid transportation to the emergency department. Large volume boluses should be avoided in patients with suspected massive pulmonary embolism as they can cause shifting of the interventricular septum into the left ventricular outflow tract, worsening shock. Direct medical control may order a trial of inotropic therapy in such cases. Long-term disability. Long-term disability is one of the most devastating consequences of a musculoskeletal injury. While in many cases a severely injured limb can be repaired and made to look almost normal, this is not always possible. Even with successful orthopedic repair, many patients cannot return to work for long periods because they require extensive rehabilitation or experience chronic pain. You have a critical role in mitigating the risk or duration of long-term disability by preventing further injury and subsequent complications. By evaluating and managing injuries carefully, you reduce the risk of wound infection, identify threats to the limb, minimize pain, and transport patients to an appropriate medical facility where their injuries can be repaired. Specific fractures. Shoulder girdle. The shoulder girdle consists of the clavicle, shoulder, and scapula. Clavicle. Clavicle fractures are very common and often occur in children. In most cases, the clavicle fractures in the middle third of the bone, typically from a fall onto an outstretched hand or from direct lateral trauma to the shoulder, as in contact sports, snowboarding, and cycling. Patients have pain in the region of the shoulder, swelling, unwillingness to raise the arm, and tilting of the head toward the injured side. Often, an obvious deformity will be seen. Shoulder. Fractures of the shoulder include those that involve the glenoid fossa of the scapula, the humeral head, and the humeral neck. Most shoulder fractures are caused by a fall onto an outstretched hand, and usually occur in older patients. Younger patients tend to dislocate the shoulder because they have stronger bones. Patients with a shoulder fracture rarely have evidence of a significant deformity, but instead have considerable swelling, ecchymosis, and pain with movement of the arm. In some cases, an associated injury to the brachial plexus may be identified during the neurologic examination. Scapula. The scapula is relatively well protected, so injuries here usually result from violent, direct trauma. Therefore, when a scapular injury is suspected, it is essential to look for associated injuries, particularly intrathoracic injuries, such as pneumothorax, hemothorax, and fractured ribs. Signs and symptoms of a scapular fracture include pain that increases with shoulder abduction, and swelling in the region of the scapula. Potential complications include axillary artery or nerve injury, brachial plexus injury, pulmonary contusion, and clavicle fractures. Treatment of shoulder girdle fractures. Fractures in the shoulder region are usually treated by using a sling and swath. These bindings should be applied to maintain the extremity in the position of comfort, keeping the arm against the chest wall to allow the body to act as a splint. In cases of suspected scapula fractures, spinal precautions are usually warranted given the amount of force required to cause a fracture. Midshaft humerus. Fractures of the shaft of the humerus usually occur in younger patients secondary to high-energy injuries, such as motor vehicle collisions. Unlike fractures that occur more proximally, these injuries typically involve substantial deformity. Examination of the extremity usually reveals a significant amount of swelling, ecchymosis, gross instability of the region, and crepitus. If the force that caused the injury is severe enough, the nerves and blood vessels in the upper arm may also be damaged. Of particular concern is the radial nerve, which runs directly in a bony groove along the humerus, and may be injured by the force itself by becoming entrapped within the fracture site. The classic sign of a radial nerve injury is wrist drop, inability to extend the wrist and fingers. Treatment of midshaft humerus fractures. If the fracture is angulated, then longitudinal traction may be applied to correct the deformity, but efforts should be halted if the patient's pain is too severe or if neurovascular status worsens. Once the extremity is in the desired position, apply a rigid splint that extends from the axilla to the elbow. Next, apply a sling and swath to immobilize the arm to the chest wall, and place cold packs over the fracture site to decrease the patient's pain and swelling. Elbow. Distal humerus. Supracondylar fractures of the humerus occur most often in children. The typical mechanism is a fall onto an outstretched hand with the elbow in extension, thereby breaking the distal humerus. As a result, the distal fragment of the humerus is pushed posteriorly and the humeral shaft is pulled anteriorly, where it compresses the brachial artery and the radial and median nerves. If the brachial artery is compromised, the patient is at risk for developing compartment syndrome in the forearm. This can lead to a Volkmann ischemic contracture, in which muscles of the forearm degenerate from prolonged ischemia and a claw-like deformity develops. The patient's muscles that allow for flexion of the fingers become contracted and non-functional, and the patient loses the ability to use her or his hand. Patients with a distal humerus fracture will report pain in the area of the elbow, and typically have a significant degree of swelling and ecchymosis. Proximal radius and ulna. Radial head fractures may result from a fall onto an outstretched hand or from a direct blow to the bone. Similar to distal humerus fractures, these injuries may lead to an injury of the nerves or blood vessels in proximity to the fracture site. Therefore, a careful neurovascular examination should be performed. Treatment of elbow fractures. Treatment of injuries in the region of the elbow is the same regardless of the exact location of the injury. The injured extremity must be repeatedly assessed for evidence of compartment syndrome. Before splinting the extremity, it is mandatory to document a neurovascular examination. The injured extremity should be splinted in the position in which it is found if the patient has a strong distal pulse, and cold packs should be applied. If the patient has an absent distal pulse or neurologic deficits, consult medical control to determine whether you should attempt fracture reduction. In any event, the patient must be transported urgently to the nearest appropriate medical facility for definitive treatment. Forearm. Fractures of the forearm may involve the radius, the ulna, or, more commonly, both. Injury may result from a direct blow to the bone, the classic example of which is the nightstick fracture of the ulna. In other cases, injury occurs because of a fall onto an outstretched hand, as in a Cole's fracture. This fracture typically occurs in older patients with osteoporosis who have fallen, but it may be found in younger patients as well. A patient with a Coles fracture, a type of distal radius fracture, usually has a dorsally angulated deformity of the distal forearm, the silver fork deformity, and pain and swelling near the injured site. Treatment of forearm fractures. A variety of splints may be used to secure a forearm fracture. Regardless of the type, the splint should provide immobilization of the entire forearm and wrist and elbow. Apply cold packs to the injury site to decrease pain and swelling. Frequent neurovascular examinations are warranted to monitor for evidence of compartment syndrome and acute carpal tunnel syndrome. Compression of the median nerve causes pain and paresthesias in the associated sensory distribution, the palmar aspect of the thumb and first two fingers. Wrist and hand. Injuries to the wrist and hand may lead to significant long-term disability, especially in people who rely on the use of their hands to earn a living. Sometimes these injuries occur while working, in other cases, they result from a fall or during a sporting event. Careful splinting of the injured site is essential to help reduce the risk of long-term disability. It is important to ask the patient whether they are left or right-handed and to pass this information along to the receiving hospital. Scaphoid. The scaphoid, also called the carpal navicular, is located just distal to the radius. It may be injured from a fall onto an outstretched hand, for which the classic finding is pain and tenderness in the anatomic snuff box. To identify the anatomic snuff box on yourself, extend your thumb, that is, make a thumbs up sign. Two tendons will be visible at the base of the thumb. The region between these two tendons is the snuff box. The major complications of a scaphoid fracture are avascular necrosis and poor fracture healing because the blood supply to this bone is limited and precarious. Boxer's fracture. A boxer's fracture is a fracture of the neck of the fifth metacarpal, small finger. It commonly occurs after punching a hard object, such as a wall or a door. The patient typically has pain over the ulnar aspect of the hand, and may have noticeable swelling. In some cases, the patient may have punched another person. If his or her fist struck the other person's mouth, this can create an open wound called a fight bite. A fight bite carries two important risks. First, if a portion of the other person's tooth becomes lodged in the wound, this is a foreign body, and will require specialized care to remove. Secondly, the human mouth is teeming with bacteria, which can lead to significant bone or joint infection. Irrigate the wound with copious sterile saline or water. If the victim is still present, assess whether his or her teeth are intact. If there is any concern that a piece of tooth or other material is lodged in the fight bite, ensure this information is passed along to the receiving hospital. Metacarpal shaft. Fractures of the metacarpals may result from a crush injury or from direct trauma. Assessment of the injured hand may reveal abnormal rotation or alignment of the fingers, swelling of the palm, and pain and tenderness in the region of injury. You should assess the neurovascular function of the hand and fingers following a crush injury, as compartment syndrome can develop within the hand. Mallet finger, baseball fracture. A mallet finger occurs when a finger is jammed into an object, such as a baseball or basketball, resulting in an avulsion fracture of the extensor tendon. The patient will not be able to extend the distal phalanx of the finger, and will maintain it in a flexed position. Treatment of wrist and hand fractures. Splint the injured hand in the position of function by placing the wrist in approximately 30 degrees of extension, with fingers slightly flexed. A roll of gauze approximately 5 to 8 centimeters in diameter accomplishes this nicely. Next, secure the extremity to an arm board or other rigid splint that extends proximally to the elbow, and is slightly elevated to help reduce swelling. For injuries that are isolated to the digits, use a foam-padded flexible aluminum splint to immobilize the injured digit, if available. A buddy splint is a good option here as well. In the case of penetrating injuries, regardless of whether a fracture is present, apply bulky dressings to the site of injury, and splint the injured hand in the position of function. Pelvis. Pelvic fractures are relatively uncommon injuries, accounting for fewer than 3% of all fractures. Despite their low incidence, these injuries are responsible for a significant number of deaths in blunt trauma patients. The risk of death following a pelvic fracture ranges from 8% to 50%, depending on the severity of the injury. When the fracture is open or has associated vascular injury, the mortality rate may exceed 50%. Death after a pelvic fracture commonly results from massive hemorrhage caused by damage to the arteries and veins of the pelvis. Disruptions of the pelvic ring occur secondary to high-energy trauma such as crush injuries, motorcycle collisions, and falls from a significant height. A number of structures within the pelvis are at risk for injury when it is fractured: the bladder, urethra, rectum, vagina, and sacral nerve plexus. The blood vessels that are most prone to damage are the veins within the pelvis, but there may be damage to the internal or external iliac arteries as well as vessels in the lumbar region. The nerves at greatest risk of injury are those in the lumbar and sacral regions and the sciatic and femoral nerves. Patients with pelvic ring disruptions who have a stable injury, such as a minimal lateral compression injury, may report pain in the pelvis and difficulty bearing weight. Patients with a more severe injury may show evidence of profound shock, gross pelvic instability, and diffuse pelvic and lower abdominal pain. There may also be bruising or lacerations in the perineum, scrotum, groin, suprapubic region, and flank, and hematuria, blood in the urine, or blood coming from the meatus of the penis, vagina, or rectum. The paramedic generally should not routinely inspect these areas, but the patient may provide this information. Lateral compression pelvic ring disruptions. Lateral compression injuries result from an impact on the side of the body, such as being struck by a car from the side or falling from a significant height and landing on one side of the body. The side of the pelvis that sustains the impact becomes internally rotated around the sacrum, and the actual volume within the pelvis decreases. Although this injury is not commonly associated with massive hemorrhage into the pelvis, it is often associated with injuries in other regions of the body. Anterior-posterior compression pelvic ring disruptions. These injuries may occur following a head-on motor vehicle collision, motorcycle collision, or fall, or in a pedestrian who is struck head-on by a vehicle. The force of the impact compresses the pelvis in the anterior to posterior direction, causing the pubic symphysis and posterior supporting ligaments to be disrupted and tear apart. The pelvis then spreads apart and opens like a book, hence the name open book pelvic fracture. Such an injury has the potential for massive blood loss because the volume of the pelvis is greatly increased. Vertical shear. Vertical shear injuries occur when a major force is applied to the pelvis from above or below, such as when a person falls from a significant height and lands on the feet. On landing, the force is transmitted through the legs to the pelvis, leading to the complete displacement of one or both sides of the pelvis toward the head, with disruption of the bony or ligamentous structures. Thus, this kind of injury has anterior and posterior components. The anterior component involves a fracture of the rami or disruption of the pubic symphysis. The posterior component involves a fracture of the ilium or sacrum or a disruption of the sacroiliac joint. The patient is likely to have significant shortening of the limb on the affected side, and is at risk for massive hemorrhage into the pelvis. Straddle fracture. A straddle fracture occurs after a fall when a person falls and sustains an impact in the region of the perineum, producing bilateral fractures of the inferior and superior rami. This injury does not interfere with weight bearing, but it does carry a risk owing to its associated complications, particularly those of the lower genitourinary system. Open pelvic fractures. Open pelvic fractures are life-threatening injuries. Such an injury is defined by the presence of a laceration of the skin in the pelvic region, vagina, or rectum. This uncommon fracture is caused by a high-velocity injury with subsequent massive hemorrhage. Treatment of pelvic fractures. Assessment of the patient with a possible pelvic fracture should begin as with any other trauma patient, with an initial assessment of the mental status, airway, breathing, and circulation, and taking spinal precautions. During the rapid trauma examination of the patient, you should search for injuries typically associated with pelvic fractures. Assess the pelvis for bleeding, lacerations, bruising, and instability. To assess for instability, apply pressure over the iliac wings in a medial direction. although paramedics may also assess for instability by pushing down and out on the iliac wings to distract the pelvis. Remember that the pre-hospital environment is uncontrolled, has limited resources, and is far away from definitive care. Consider the risks if you choose to take this approach to assessing pelvic trauma. Lack of instability on compression does not rule out injury, and unnecessary movement of a disrupted pelvis can worsen blood loss. Once instability of the pelvis is identified, the pelvis should not be reassessed for instability because the risk of bleeding increases with each manipulation. Treatment should include careful monitoring of airway, breathing, and circulation, spinal precautions, and intravenous access with at least one, if not two, large bore cannulas. Management of the pelvic injury is aimed at reducing the amount of bleeding, as large volume bleeding into the pelvic cavity can amount to more than 3 liters of blood loss. Methods used to accomplish stabilization may include application of a pelvic binder or simply tying a sheet around the pelvis. Applying lateral pressure across the pelvis and forcing together toward the midline reduces the potential space within the pelvis, which may allow for tamponade of the bleeding vessels. Once packaged, the patient should be rapidly transported to definitive care, typically a regional trauma center. Paramedics should administer crystalloid fluids intravenous to maintain adequate tissue perfusion while avoiding hypertension. Hip. A hip fracture involves a fracture of the femoral head, femoral neck, intertrochanteric region, or proximal femoral shaft. Fractures of the femoral head are uncommon injuries that are usually associated with a hip dislocation. Femoral neck and intertrochanteric fractures typically occur in older patients with osteoporosis who have fallen and sustained direct trauma to the hip. They may also occur in younger patients with healthy bone, typically as the result of a high-energy mechanism. Proximal femoral shaft fractures can occur in patients of any age and result from a high-energy mechanism. The type of hip fracture is essentially impossible to differentiate without radiographs, and pre-hospital management will be the same regardless. Patients with a hip fracture will report pain in the affected hip, especially with attempts at movement, and report an inability to bear weight. They may also report hearing or feeling something snap. If the fracture is displaced, then the patient almost always has an externally rotated and shortened leg. If there is no displacement, the leg may appear normal. Examination of the injury site usually finds tenderness to palpation, and there may be noticeable swelling, deformity, or ecchymosis. Treatment of hip fractures. Treat hip fractures by supporting the injured extremity in the position in which it is found. This may be accomplished by placing pillows or blankets under the affected extremity and securing them in place. A scoop stretcher is often a fantastic tool for safe extrication of the patient in the most comfortable manner possible. Treat the patient as you would any other trauma patient, establish vascular access, administer appropriate analgesia, consider the need for spinal precautions, monitor for shock, and transport to the most appropriate hospital. Depending on where you work, this may be the trauma center, but many community hospitals are capable of managing an isolated hip fracture. Definitive treatment of a hip fracture almost always requires surgery. If possible, the bone is repaired with plates, rods, or screws. Sometimes, however, the hip must be replaced. Femoral shaft. Femoral shaft fractures occur following high-energy impacts. Thus, the presence of a fracture of the femoral shaft should alert you to the risk of other injuries. Patients with femoral shaft fractures will report severe pain. The fracture may be severely angulated and lead to significant limb shortening, or it may be open. Examination may identify significant thigh edema, bruising, crepitus, and muscle spasm. There is often significant blood loss, perhaps 500 to 1,500 milliliters, at the fracture site. In addition, damage to the neurovascular structures of the thigh is possible. Femoral shaft fractures also place the patient at risk for fat emboli. Treatment of femoral shaft fractures. Management of femoral shaft fractures includes monitoring for evidence of shock, consideration of spinal precautions, and establishing adequate vascular access. Place the injured extremity in a traction splint. This reduces pain and the size of the compartment, minimizing the volume of blood loss. Because these injuries may be extremely painful, consider the administration of pain medication. Knee. Fractures of the knee may involve the distal femur, proximal tibia, or patella. An injury to this region may result from a direct blow to the knee, an axial load of the leg, or powerful contractions of the quadriceps. Assessment of the patient generally reveals significant pain in the knee, decreased range of motion, pain with movement and weight bearing, ecchymosis, swelling, and, in the case of displaced fractures, deformity. Treatment of knee fractures. Management of knee fractures depends on the position of the leg and the status of distal pulses. If the patient has intact distal circulation, then splint the extremity in the position in which it is found. If there is no distal pulse, then seek medical consultation to determine whether you should attempt manipulation before transport. When possible, elevate the leg to the heart level and apply cold packs. Frequent neurovascular checks are mandatory, given the high incidence of compartment syndrome and neurovascular injury in cases of knee fracture. Tibia and fibula. Fractures of the tibia and/or fibula may result from direct trauma to the lower leg or from application of rotational or compressive forces. These injuries often present with significant deformity and soft tissue injury. Complications may include compartment syndrome, neurovascular injury, infection, poor healing, and chronic pain. Treatment of tibia and fibula fractures. Apply a rigid, long leg splint, and administer pain medication as necessary. If there is neurovascular compromise or severe angulation, attempt to align the leg, documenting the pre-manipulation and post-manipulation neurovascular status. Monitor the patient closely for evidence of compartment syndrome, elevate the extremity to heart level, and apply cold packs. Ankle. Fractures of the ankle usually result from sudden, forceful movements of the foot that damage the malleoli and sometimes produce dislocation, called a fracture dislocation. In other cases, an axial load is transmitted through the foot and causes the talus, the bone of the foot that articulates with the tibia, to impact the distal tibia, leading to a fracture. Signs and symptoms of an ankle fracture include pain, deformity, and swelling. Ankle fractures, particularly if associated with a dislocation, can lead to damage of the nerves and blood vessels that supply the foot, the development of compartment syndrome, and chronic ankle pain and arthritis. Treatment of ankle fractures. All ankle fractures should be immobilized using a commercially available splint or a pillow splint. The toes should be exposed to allow for frequent checks of distal neurovascular function. Elevate the extremity to the heart level, administer appropriate analgesia, and apply cold packs to reduce swelling. If an ankle fracture dislocation is associated with a pulseless foot, medical direction may recommend that you attempt reduction. To reduce a fracture dislocation of the ankle, first relax the calf muscles to allow the foot to move more freely by flexing the patient's leg at the knee. With the leg flexed, grasp the heel and the foot just proximal to the toes, and apply gentle traction. Next, rotate the foot back into its normal position without forcing it. If this procedure is successful, reassess the distal neurovascular status, and splint the extremity in the reduced position, using care not to allow the ankle to dislocate again. If the fracture dislocation cannot be reduced, notify direct medical control and the receiving facility, and expedite transportation after splinting the ankle in the position in which it was found. Calcaneus. The calcaneus is most commonly fractured when a patient jumps from a height and lands on his or her feet. Less commonly, it can be fractured when a powerful force is applied directly to the heel. These injuries present with foot pain, swelling, and ecchymosis and should alert paramedics to the possibility of injuries in the knee, pelvis, and spine. Treatment of calcaneus fractures. When a calcaneus fracture is suspected, splint the injured extremity with a pillow, apply cold packs to help decrease swelling, and administer appropriate analgesia. Any patient with a suspected calcaneus fracture requires spinal precautions given the high risk of an associated spine injury, particularly bilateral fracture. Joint injuries and dislocations. Shoulder girdle injuries and dislocations. Acromioclavicular joint separation. Separation of the acromioclavicular joint, a separated shoulder, usually occurs from a direct blow to the superior aspect or point of the shoulder, as may happen during contact sports and falls. Patients generally report pain and tenderness in the region of the acromioclavicular joint, and the prominence of the distal clavicle may lead to a noticeable protrusion. Posterior sternoclavicular joint dislocation. Posterior dislocation of the clavicle at its junction with the sternum most often occurs as a result of a direct blow to the clavicle, but is sometimes seen after strong pressure is applied to the posterior shoulder, such as when a football player ends up at the bottom of a pileup. This injury is rarely difficult to identify because there is pain and swelling at the sternoclavicular joint. What makes this a potentially dangerous and even potentially fatal injury is not the dislocation itself, but the possible damage to underlying structures, specifically, the trachea, esophagus, jugular vein, subclavian vein and artery, carotid artery, and other vascular structures. Any symptoms that suggest such underlying injury, such as dyspnea, pain on swallowing, a sensation of choking, loss of pulses, or a sensory deficit in the upper extremity on the same side, are danger signals, and should prompt rapid transport of the patient to the hospital. Shoulder dislocation. Approximately 90% of shoulder dislocations are anterior dislocations. Anterior shoulder dislocations are often caused by a fall onto an outstretched arm that is abducted and externally rotated. Patients report severe pain and have significantly decreased range of motion at the shoulder. The arm is usually abducted and externally rotated, and any efforts at moving it result in extreme pain. A prominent bulge from the acromion is often noted on the anterior surface of the shoulder. The humeral head may be palpable, and the patient may experience frequent and painful muscle spasms. Posterior shoulder dislocations are much less common and are often caused by massive muscle contractions, such as those seen with electrical shocks and seizures. These injuries present with the same reports of pain and limited motion, but the arm is maintained in internal rotation and adduction. In some patients, a shoulder dislocation will produce a tear of the rotator cuff or a fracture of the glenoid. Some patients may have a concomitant injury to the brachial plexus, axillary artery, or axillary vein. The axillary nerve is also prone to injury during a shoulder dislocation. Assess sensation over the deltoid muscle to determine whether there is a sensory deficit in the distribution of this nerve. Patients with a shoulder dislocation are also at risk for future dislocations, especially during the first 2 years following the injury, and if the patient is young. Treatment of joint injuries involving the shoulder girdle. In cases of an acromioclavicular joint separation, a sling and swath will often provide significant pain relief. In the case of a posterior sternoclavicular joint dislocation, position the patient supine with the arm on the affected side abducted, and place a rolled towel under the shoulder blade. This position may take some of the pressure off the structures beneath the sternoclavicular joint. For a dislocated shoulder, splint the injured extremity in the position in which it was found by using blankets, pillows, and, when possible, a sling and swath. When applying the swath, it may be necessary to connect 2 cravats together so as to encircle the patient's body, extremity, and pillows or blankets. Given the likelihood of muscle spasm and pain, use of pain medication may be warranted. Perform neurovascular assessments frequently to monitor for changes in function. Elbow dislocation. Elbow dislocations are medical emergencies because of the high risk of neurovascular injury. The vast majority of elbow dislocations are posterior injuries that result from a fall onto an outstretched hand or from hyperextension of the elbow joint. Patients usually report significant pain in the region of the elbow, and may have a large degree of swelling and ecchymosis. A palpable deformity may be present at the elbow from the prominence of the olecranon process, and there is typically locking or resistance to movement of the joint. Major complications of an elbow dislocation include an associated fracture in the region of the joint, brachial artery injury, median nerve injury, and injury to the ulnar nerve. Radial head subluxation. Subluxation of the radial head, also referred to as nursemaid's elbow, is not a true elbow dislocation. It commonly occurs in children younger than 6 years, and is caused by a sudden pull on the child's arm. Clinically, the injured arm is held in flexion, and the child will often refuse to move the hand or elbow on the injured side. In general, there is only mild swelling in the region of the elbow. Treatment of elbow dislocation. When you suspect a dislocation or subluxation in the elbow, splint the injured extremity in the position in which it was found. A sling and swath may be applied to provide additional stabilization to the injured elbow. These patients should be transported to an emergency department as soon as possible to reduce the dislocation, and assess and manage any neurovascular injury. Finger dislocation. Finger dislocations are caused by a sudden jamming force or from extension of the fingers beyond the normal range of motion. There is generally pain and deformity at the affected joint, and there may be compromise of the neurovascular structures of the digit, leading to paresthesias. Treatment of finger dislocation. Manage the dislocated finger by splinting the entire hand in the position of function, and using soft dressings as needed to support the digit, or simply tape the fingers together, buddy taping. Do not attempt to relocate the injured digit in the pre-hospital setting unless you are directed to do so by medical control. To reduce a dislocated digit, if the digit is distally dislocated to the dorsal side, extend the digit. If it is dislocated to the volar side, flex the digit. Next, use gentle longitudinal traction to bring the digit back into its normal position. It may be helpful to apply pressure at the dislocated joint to push the distal part into position. Following reduction, the neurovascular status of the digit should be reassessed and the digit should be fully immobilized to prevent it from dislocating again. Hip dislocation. More than 90% of all hip dislocations involve posterior dislocation. Most of these occur due to deceleration injuries, in which a flexed knee strikes an immobile object with a great degree of force. When a patient has a posterior hip dislocation, the leg of the affected side is typically found in flexion, adduction, and internal rotation, and it is noticeably shorter. Patients report severe pain and inability to move the leg, and significant soft tissue swelling may be evident. Complications arising from such injuries include sciatic nerve injury, a vascular necrosis of the femoral head, and associated fractures of the acetabulum. Anterior hip dislocations usually follow a forceful spreading injury that occurs while the hip is flexed. The affected leg is usually flexed, abducted, and externally rotated, and the patient reports severe pain. Major complications of this type of injury include injury to the femoral artery or nerve, and a vascular necrosis of the femoral head. Treatment of hip dislocation. Because most hip dislocations are associated with a high-energy mechanism, a full trauma assessment should be conducted, and spinal precautions taken. Splint the injured extremity in the position in which it is found by using blankets, pillows, and the opposite leg. Perform and document frequent neurovascular checks on your patient care report. Once at the hospital, the patient generally requires general anesthesia to allow the hip to be reduced within the socket. Knee dislocation. Dislocations of the knee are true emergencies that may threaten the limb. The knee may be dislocated by high-energy trauma, as in motor vehicle collisions, or it may dislocate secondary to powerful twisting forces, as when athletes attempt to avoid another player. In most cases, the knee will spontaneously relocate itself following the injury, and there may be no obvious evidence of injury. The direction of dislocation refers to the position of the tibia with respect to the femur. Anterior knee dislocations, which result from extreme hyperextension of the knee, are the most common, occurring in almost 1/2 of all cases. Commonly, the posterior cruciate ligament is torn. There is a relatively low risk of injury to the popliteal artery in the form of intimal tear. In posterior dislocations, a direct blow to the knee forces the tibia to shift posteriorly. There is a high risk of damage to the anterior cruciate ligament and the popliteal artery. Medial dislocations result from a direct blow to the lateral part of the leg. Because the deforming force causes the medial aspect of the knee to stretch apart, there is a high likelihood of injury to the medial collateral and cruciate ligaments. When the force is applied from the medial direction, a lateral dislocation occurs, and the lateral part of the knee is stretched apart, injuring the lateral collateral ligament. Lateral and medial dislocations happen less commonly and have a lower risk of injuring the popliteal artery. Patients with a knee dislocation will typically report pain in the knee and report that the knee gave out. If the knee did not spontaneously replace itself, then there may be evidence of significant deformity and decreased range of motion. Complications may include limb-threatening popliteal artery disruption, injuries to the popliteal, peroneal, and tibial nerves, and joint instability. Do not confuse this injury with a relatively minor patella dislocation. Treatment of knee dislocation. In all cases of knee dislocation, distal neurovascular function must be assessed frequently and will often guide the management. If a pulse is palpable in the foot, splint the knee in the position in which it is found. If there is no palpable pulse, you may need to reduce the knee to restore circulation. A number of factors, including time to the hospital and duration of dislocation, will affect this decision, so you should always seek medical direction before reducing a dislocated knee. To reduce a dislocated knee, apply longitudinal traction to the tibia in the direction of the foot. While the first rescuer is applying traction, a second paramedic should apply pressure to the distal femur and proximal tibia. If the knee is dislocated anteriorly, apply pressure to the femur in the anterior direction, and to the tibia in the opposite direction. In the case of a posterior dislocation, apply pressure in the opposite manner, with the tibia pressed anteriorly and the femur pressed posteriorly. Once the reduction has been accomplished, check the patient's neurovascular status, and splint the leg securely. If the attempt at reduction fails, splint the knee in the position in which it is found and undertake rapid transportation to an appropriate facility. Chapter 24. Head and face injuries. Introduction. As a paramedic, you will commonly encounter patients with injuries to the head, neck, and face, ranging in severity from a broken nose to traumatic brain injury. The first part of this chapter provides a detailed review of the anatomy and physiology of the head and face. The second part discusses head and face injuries, including their respective signs and symptoms and the appropriate pre-hospital care for maxillofacial injuries, eye and ear injuries, oral and dental injuries, injuries to the anterior part of the neck, and head and traumatic brain injury. The skull and facial bones. The scalp. The brain, the most important organ in the body, requires maximum protection from injury. The human body ensures that it receives this protection by housing the brain within several layers of soft and hard wrappings. Starting from the outside and proceeding inward toward the brain, the first protective layer is the scalp, which consists of the following layers, given in descending order. Skin, with hair. Subcutaneous tissue, which contains major scalp veins that bleed profusely when lacerated. Gallia aponeurotica, a tendon expansion that connects the frontal and occipital muscles of the cranium. Loose connective tissue, alveolar tissue, which is easily stripped from the layer beneath in scalping injuries. This loose alveolar layer also provides room for blood to accumulate after blunt trauma between the scalp and skull bone, subgallial hematoma. Periosteum, the dense fibrous membrane covering the surface of bones. The skull. At the top of the axial skeleton is the skull, which consists of 28 bones in 3 anatomic groups, the auditory ossicles, the cranium, and the face. The 6 auditory ossicles function in hearing, and are located deep within the cavities of the temporal bone, 3 on each side of the head. The remaining 22 bones constitute the cranium and the face. The cranial vault consists of 8 bones that encase and protect the brain, 2 each of the parietal and temporal bones, and the frontal, occipital, sphenoid, and ethmoid bones. The brain connects to the spinal cord through a large opening at the base of the skull called the foramen magnum. The bones of the skull are connected at special joints known as sutures. The paired parietal bones joint together at the sagittal suture. The parietal bones abut the frontal bone at the coronal suture. The occipital bone attaches to the parietal bones at the lambdoid suture. Fibrous tissues called fontanelles, which are soft in infants, link the sutures. The layers of scalp and membranes overlying the brain can be palpated in the area of the fontanelles. Under normal conditions, the brain may not be felt through the fontanelles. By the time a child is 18 months old, the sutures should have solidified, and the fontanelles closed. At the base of each temporal bone is a cone-shaped section of bone known as the mastoid process. This area is an important site for attachment of various muscles. In addition, a portion of the mastoid process contains hollow mastoid air cells. The floor of the cranial vault. Viewed superiorly, the floor of the cranial vault is divided into three compartments: the anterior fossa, middle fossa, and posterior fossa. The crista galli forms a prominent bony ridge in the center of the anterior fossa, and is the point of attachment of the meninges, the three layers of membranes that surround the brain, and spinal cord. On the other side of the crista galli is the cribriform plate of the ethmoid bone, a horizontal bone that is perforated with numerous openings, foramina, that allow the passage of the olfactory nerve filaments from the nasal cavity. The olfactory nerves, the cranial nerves for smell, send projections through the foramina in the cribriform plate, and into the nasal cavity, the chamber inside the nose that lies between the floor of the cranium and the roof of the mouth. The base of the skull. When the mandible is removed, the base of the skull appears amazingly complex, with numerous foramina visible. The occipital condyles on the occipital bone, which are the points of articulation between the skull and the vertebral column, lie on either side of the foramen magnum. Portions of the maxilla and the palatine bone, the irregularly shaped bone in the posterior nasal cavity, form the hard palate, which is the bony anterior part of the palate, or roof, of the mouth. The zygomatic arch is the bone that extends along the front of the skull below the orbit. The facial bones. The frontal and ethmoid bones are part of the cranial vault and the face. The 14 facial bones form the structure of the face, without contributing to the cranial vault. They include the maxillae, vomer, inferior nasal concha, and the zygomatic, palatine, nasal, and lacrimal bones. The facial bones protect the eyes, nose, and tongue. They also provide attachment points for the muscles that allow chewing. The zygomatic process of the temporal bone and the temporal process of the zygomatic bone form the zygomatic arch, which lends shape to the cheeks. Two major nerves provide sensory and motor control to the face: the trigeminal nerve, 5th cranial nerve, and the facial nerve, 7th cranial nerve. The trigeminal nerve branches into the ophthalmic nerve, maxillary nerve, and mandibular nerve. The ophthalmic nerve, a sensory nerve, supplies the skin of the forehead, upper eyelid, and conjunctiva. The maxillary nerve, another sensory nerve, supplies the skin on the posterior part of the side of the nose, lower eyelid, cheek, and upper lip. The mandibular nerve, a sensory and motor nerve, supplies the muscles of chewing, mastication, and the skin of the lower lip, chin, temporal region, and part of the external ear. The facial nerve supplies the muscles of facial expression. Blood supply to the face is provided primarily through the external carotid artery, which branches into the temporal, mandibular, and maxillary arteries. Because the face is highly vascular, it tends to bleed heavily when injured. The orbits. The orbits are cone-shaped fossae that enclose and protect the eyes. In addition to the eyeball and muscles that move it, the orbit contains blood vessels, nerves, and fat. A blow to the eye may result in fracture of the orbital floor because the bone is thin and breaks easily. A so-called blowout fracture results in transmission of forces away from the eyeball itself to the bone. Blood and fat then leak into the maxillary sinus. The nose. The nose is one of the two primary entry points for oxygen-rich air into the body. The nasal septum, the separation between the nostrils, is located in the midline. Often, it bulges slightly to one side or the other. The external portion of the nose is formed mostly of cartilage. Several bones associated with the nose contain cavities known as the paranasal sinuses. These hollowed sections of bone, which are lined with mucous membranes, decrease the weight of the skull, and provide resonance for the voice. The contents of the sinuses drain into the nasal cavity. The mandible and temporomandibular joint. The mandible is the large movable bone forming the lower jaw, and containing the lower teeth. Numerous muscles of chewing attach to the mandible, and its rami. The posterior condyle of the mandible articulates with the temporal bone at the temporomandibular joint, EMJ, allowing movement of the mandible. The hyoid bone. The hyoid bone floats in the superior aspect of the neck just below the mandible. Although it is not actually part of the skull, it supports the tongue, and serves as a point of attachment for many important neck and tongue muscles. The eyes, ears, teeth, and mouth. The eye. The globe, or eyeball, is a spherical structure measuring about 3 centimeters in diameter that is housed within the eye socket, or orbit. The eyes are held in place by loose connective tissue, and several muscles. These muscles also control eye movements. The oculomotor nerve, third cranial nerve, innervates the muscles that move the eyeballs and upper eyelids. It also carries parasympathetic nerve fibers that cause constriction of the pupil and accommodation of the lens. The optic nerve, second cranial nerve, does not control movement, but provides the sense of vision. The structures of the eye include the following. The sclera, white of the eye, is a tough, fibrous coat that helps maintain the shape of the eye and protects its contents. In some illnesses, such as hepatitis, the sclera become yellow, icteric, from staining by bile pigments. The cornea is the transparent anterior portion of the eye that overlies the iris and pupil. The conjunctiva is a delicate mucous membrane that covers the sclera and internal surfaces of the eyelids. Cyanosis can be detected in a conjunctiva when it is not easily assessed on the skin of dark-skinned patients. The iris is the pigmented part of the eye that surrounds the pupil. It consists of muscles and blood vessels that contract and expand to regulate the size of the pupil. The pupil is the circular adjustable opening within the iris through which light passes to the lens. A normal pupil dilates in dim light to permit more light to enter the eye, and constricts in bright light to decrease the light entering the eye. Behind the pupil and iris is the lens, a transparent structure that can alter its thickness to focus light on the retina at the back of the eye. The retina, which lies in the posterior aspect of the interior globe, is a delicate, 10-layered structure of nervous tissue that extends from the optic nerve. It receives light impulses and converts them to nerve signals, which are conducted to the brain by the optic nerve, and interpreted as vision. The anterior chamber is the portion of the globe between the lens and the cornea. It is filled with aqueous humor, a clear, watery fluid. A loss of aqueous humor through a penetrating injury to the eye will gradually be replenished. The posterior chamber is the portion of the globe between the lens and the retina that is filled with vitreous humor, a jelly-like substance that maintains the shape of the globe. A loss of vitreous humor cannot be replenished, and blindness may result. Light rays enter the eyes through the pupil, and are focused by the lens. The image formed by the lens is cast on the retina, where sensitive nerve fibers form the optic nerve. The optic nerve transmits the image to the brain, where it is converted into conscious images in the visual cortex. There are 2 types of vision, central and peripheral. Central vision facilitates visualization of objects directly in front of you and is processed by the macula, the central portion of the retina. The remainder of the retina processes peripheral vision, which gives us visualization of lateral objects while looking forward. The lacrimal apparatus secretes and drains tears from the eye. Tears produced in the lacrimal gland drain into lacrimal ducts, then into lacrimal sacs that pass into the nasal cavity via the nasolacrimal duct. Tears moisten the conjunctivae. The ear. The ear is divided into 3 anatomic parts, external, middle, and inner. The external ear consists of the pinna, the external auditory canal, and the exterior portion of the tympanic membrane, commonly known as the eardrum. The middle ear consists of the inner portion of the tympanic membrane, and the ossicles, while the inner ear consists of the cochlea, and semicircular canals. Sound waves enter the ear through the auricle or pinna, the large cartilaginous external portion of the ear. They then travel through the external auditory canal to the tympanic membrane. Vibration of sound waves against the tympanic membrane sets up vibration in the ossicles, the three small bones on the inner side of the tympanic membrane. These vibrations are transmitted to the cochlear duct at the oval window, the opening between the middle ear and the vestibule. Movement of the oval window causes fluid within the cochlea, a shell-shaped structure in the inner ear, to vibrate. Within the cochlea, at the organ of Corti, vibration stimulates hair movements that form nerve impulses that travel to the brain via the auditory nerve. The brain then converts these impulses into sound. The teeth. The normal adult mouth contains 32 permanent teeth. The primary or deciduous teeth are lost during childhood. Adult teeth are distributed about the maxillary and mandibular arches. The teeth on each side of the arch are mirror images of each other and form 4 quadrants: right upper, right lower, and left lower. Each quadrant contains 1 central incisor, 1 lateral incisor, 1 canine, 2 premolars, and 3 molars. The third molars, called wisdom teeth, do not appear until late adolescence. The top portion of the tooth, external to the gum, is the crown, containing 1 or more cusps. Below the crown lie the neck and the root. The pulp cavity fills the center of the tooth and contains blood vessels, nerves, and specialized connective tissue, called pulp. Dentin and enamel surround the pulp cavity and protect the tooth from damage. Dentin forms the principal mass of the tooth, while the enamel, which is much denser and stronger than bone, covers the tooth. The bony sockets for the teeth in the mandible and maxilla are called alveoli. The ridges between the teeth, the alveolar ridges, are covered by the gingiva, or gums, which are thickened connective tissue and epithelium. Teeth are attached to the alveolar bone by a periodontal membrane. The mouth. Digestion begins in the mouth with mastication, or the chewing of food by the teeth. During mastication, food is mixed with secretions from the salivary glands. The tongue is the primary organ of taste. It is also important in the formation of speech, and in the chewing and swallowing of food. The tongue is attached at the mandible and hyoid bone, is covered by a mucous membrane, and extends from the back of the mouth upward and forward to the lips. The hypoglossal, glossopharyngeal, trigeminal, and facial nerves supply the mouth and its structures. The hypoglossal nerve, 12th cranial nerve, provides motor function to the muscles of the tongue. The glossopharyngeal nerve, 9th cranial nerve, provides taste sensation to the posterior portions of the tongue, and carries parasympathetic fibers to salivary glands on each side of the face. The mandibular branch of the trigeminal nerve, 5th cranial nerve, provides motor innervation to the muscles of mastication. The facial nerve, 7th cranial nerve, in addition to supplying motor activity to all muscles of facial expression, provides the sense of taste to the anterior 2/3 of the tongue, and cutaneous sensations to the tongue and palate. The anterior part of the neck. The principal structures of the anterior part of the neck include the thyroid and cricoid cartilage, trachea, and numerous muscles and nerves. The major blood vessels in this area are the internal and external carotid arteries and the internal and external jugular veins. The vertebral arteries run laterally to the cervical vertebrae in the posterior part of the neck. The major arteries of the neck, the carotid and vertebral arteries, supply oxygenated blood directly to the brain. Therefore, in addition to causing massive bleeding and hemorrhagic shock, injury to any of these major vessels can produce cerebral hypoxia, infarction, air embolism, and/or permanent neurologic impairment. Other key structures of the anterior part of the neck that may sustain injury from blunt or penetrating mechanisms include the vagus nerves, thoracic duct, esophagus, thyroid, and parathyroid glands, lower cranial nerves, brachial plexus, which is responsible for function of the lower arm and hand, soft tissue and fascia, and various muscles. The brain. The brain, which occupies 80% of the cranial vault, contains billions of neurons, nerve cells, that serve a variety of vital functions. The major regions of the brain are the cerebrum, diencephalon, thalamus and hypothalamus, brainstem, medulla, pons, midbrain mesencephalon, and the cerebellum. The remaining intracranial contents include cerebral blood, 12%, and cerebral spinal fluid, 8%. The brain accounts for only 2% of the total body weight, yet it is the most metabolically active and perfusion-sensitive organ in the body. The brain metabolizes 25% of the body's glucose, burning approximately 60 milligrams per minute, and consumes 20% of the total body oxygen. Because the brain has no storage mechanism for oxygen or glucose, it is totally dependent on a constant source of both fuels via cerebral blood flow provided by the carotid and vertebral arteries. As such, the brain will continually manipulate the physiology as needed to guarantee that a ready supply of oxygen and glucose is available. The cerebrum. The largest portion of the brain is the cerebrum, which is responsible for higher functions, such as reasoning. The cerebrum is divided into right and left hemispheres by a longitudinal fissure. The hemispheres of the cerebrum are not entirely equivalent functionally. In a right-handed person, for example, the speech center is usually located in the left cerebral hemisphere, which is then said to be the dominant hemisphere. The largest portion of the cerebrum is the cerebral cortex, which regulates voluntary skeletal movement and the level of awareness. Injury to the cerebral cortex may result in paresthesia, weakness, and paralysis of the extremities. Each cerebral hemisphere is divided functionally into specialized areas called lobes. The frontal lobe is important for voluntary motor action and personality traits. Injury to the frontal lobe may result in seizures or placid reactions, flat affect. The parietal lobe controls the somatic, or voluntary, sensory and motor functions for the opposite, contralateral, side of the body, as well as memory and emotions. It is separated from the frontal lobe by the central sulcus. Posteriorly, the occipital lobe, from which the optic nerve originates, is responsible for processing visual information. After a blow to the back of the head, a person may see stars, which results when the occipital lobe impacts against the back of the skull. The speech center is located in the temporal lobe. In approximately 85% of the population, the speech center is located on the left side of the temporal lobe. The temporal lobe also controls long-term memory, hearing, taste, and smell. It is separated from the rest of the cerebrum by a lateral fissure. The diencephalon. The diencephalon, which is located between the brainstem and the cerebrum, includes the thalamus, subthalamus, hypothalamus, and epithalamus. The thalamus processes most sensory input and influences mood and general body movements, especially those associated with fear and rage. The subthalamus controls motor functions. The functions of the epithalamus are unclear. The most inferior portion of the diencephalon, the hypothalamus, is vital in the control of many body functions, including heart rate, digestion, sexual development, temperature regulation, emotion, hunger, thirst, vomiting, and regulation of the sleep cycle. The cerebellum. The cerebellum is located beneath the cerebral hemispheres in the inferior part of the brain. It is sometimes called the athlete's brain because it is responsible for the maintenance of posture, equilibrium, and the coordination of skilled movements. The brainstem. The brainstem consists of the midbrain, pons, and the medulla. It is located at the base of the brain, and connects the spinal cord to the remainder of the brain. The brainstem houses many structures that are critical to the maintenance of vital functions. High in the brainstem, for example, is the reticular activating system, RAS, which is responsible for maintenance of consciousness, specifically one's level of arousal. The centers that control basic but critical functions, heart rate, blood pressure, and respiration, are located in the lower part of the brainstem. Damage to this area can easily result in cardiovascular derangement, respiratory arrest, or death. The midbrain lies immediately below the diencephalon, and is the smallest region of the brainstem. Deep within the cerebrum, diencephalon, and midbrain are the basal ganglia, which have an important role in coordination of motor movements and posture. Portions of the cerebrum and diencephalon constitute the limbic system, which influences emotions, motivation, mood, and sensations of pain and pleasure. The pons, which lies below the midbrain, and above the medulla, contains numerous important nerve fibers, including those for sleep and respiration. The inferior portion of the midbrain, The medulla is continuous inferiorly with the spinal cord. It serves as a conduction pathway for ascending and descending nerve tracts. It also coordinates heart rate, blood vessel diameter, breathing, swallowing, vomiting, coughing, and sneezing. The vagus nerve, 10th cranial nerve, a bundle of nerves that primarily innervates the parasympathetic nervous system, originates from the medulla. The meninges. The meninges are protective layers that surround and enfold the entire central nervous system, specifically the brain and spinal cord. The outermost layer is a strong, fibrous wrapping called the dura mater, meaning tough mother. The dura mater covers the entire brain, folding into form the tentorium, a structure that separates the cerebral hemispheres from the cerebellum and brainstem. The dura mater is firmly attached to the internal wall of the skull. Just beneath the suture lines of the skull, the dura mater splits into two surfaces and forms venous sinuses. When those venous sinuses are disrupted during a head injury, blood can collect beneath the dura mater to form a subdural hematoma. The second meningeal layer is a delicate, transparent membrane called the arachnoid. It is so named because the blood vessels it contains resemble a spider web. The third meningeal layer, the pia mater, soft mother, is a thin, translucent, highly vascular membrane that firmly adheres directly to the surface of the brain. The meningeal arteries are located between the dura mater and the skull. When one of these arteries, usually the middle meningeal artery, is disrupted, bleeding occurs above the dura mater, resulting in an epidural hematoma. Cerebral spinal fluid, CSF, which is manufactured in the ventricles of the brain, flows in the subarachnoid space, located between the pia mater and the arachnoid. Cerebral spinal fluid is manufactured by cells within the choroid plexus in the ventricles, hollow storage areas in the brain. These areas normally are interconnected, and cerebral spinal fluid flows freely between them. Cerebral spinal fluid is similar in composition to plasma. The meninges and cerebral spinal fluid form a fluid-filled sac that cushions and protects the brain and spinal cord. Face injuries. Soft tissue injuries. Although open soft tissue injuries to the face, lacerations, abrasions, and avulsions, by themselves are rarely life-threatening, their presence, especially following a significant mechanism of injury, suggests the potential for more severe injuries, for example, closed head injury, cervical spine injury. Furthermore, massive soft tissue injuries to the face, especially if associated with oropharyngeal trauma and bleeding, can compromise the patient's airway and lead to ventilatory inadequacy. Maintain a high index of suspicion when a patient presents with closed soft tissue injuries to the face, such as contusions and hematomas. These indicators of blunt force trauma suggest the potential for more severe underlying injuries. Impaled objects in the soft tissues or bones of the face may occur in association with facial trauma. Although these objects can damage facial nerves, the risk of airway compromise is of far greater consequence. This is especially true when an impaled object penetrates the cheek, because massive oropharyngeal bleeding can result in airway obstruction, aspiration, and ventilatory inadequacy. In addition, blood is a gastric irritant. For many people, swallowing a small amount of blood can make them vomit, further increasing the likelihood of aspiration. Maxillofacial fractures. Maxillofacial fractures occur when the facial bones absorb the energy of a strong impact. Forces up to 150 grams equals acceleration of the body due to gravity, are required to fracture the maxilla. A force of that magnitude will likely also produce closed head and cervical spine injuries. When assessing a patient with a suspected maxillofacial fracture, you should protect the cervical spine and monitor the patient's neurologic signs, specifically his or her level of consciousness. Deep facial lacerations, ecchymosis, and pain to bony palpation should increase your index of suspicion to the presence of a maxillofacial fracture. Other general signs and symptoms of maxillofacial fractures include swelling, bony crepitus or instability, dental malocclusion, misalignment of the teeth, facial asymmetry, impaired ocular movement, and visual disturbances. Nasal fractures. Because the nasal bones are not as structurally sound as the other bones of the face, nasal fractures are the most common facial fracture. These fractures are characterized by swelling, tenderness, and crepitus when the nasal bone is palpated. Deformity of the nose, if present, usually appears as lateral displacement of the nasal bone from its normal midline position. Nasal fractures, like any maxillofacial fracture, are often complicated by the presence of an anterior or a posterior nosebleed, epistaxis, which can compromise the patient's airway. Mandibular fractures and dislocations. Second only to nasal fractures in frequency, fractures of the mandible typically result from massive blunt force trauma to the lower third of the face. They are particularly common following an assault injury. Because significant force is required to fracture the mandible, this structure may be fractured in more than one place and, therefore, may be unstable. The fracture site itself is most commonly located at the angle of the jaw. Mandibular fractures should be suspected in patients with a history of blunt force trauma to the lower third of the face who present with dental malocclusion, numbness of fechin, and inability to open the mouth. There will likely be swelling and ecchymosis over the fracture site, and teeth may be partially or completely avulsed. Although TMJ dislocations may occur as the result of blunt force trauma to the lower third of the face, this outcome is rare. Mandibular dislocations are most often the result of yawning or opening the mouth very widely. The patient commonly feels a pop, and then cannot close his or her mouth. It is locked in an open position. The jaw muscles eventually go into spasm, causing severe pain. Maxillary fractures. Maxillary fractures to the mid-face area are most commonly associated with mechanisms that produce massive blunt facial trauma, such as motor vehicle collisions, falls, and assaults. They produce massive facial swelling, instability of the mid-facial bones, malocclusion, and an elongated appearance of the patient's face. Midfacial structures include the maxilla, zygoma, orbital floor, and nose. Lefort fractures are classified into three categories. Lefort 1 fracture. A horizontal fracture of the maxilla that involves the hard palate and inferior maxilla. Lefort 2 fracture. A pyramidal fracture involving the nasal bone and inferior maxilla. Lefort 3 fracture, craniofacial disjunction. A fracture of all midfacial bones, separating the entire midface from the cranium. Lefort fractures can occur as isolated fractures, Lefort 1, or in combination, Lefort 1 and 2, depending on the location of impact and the amount of trauma. Orbital fractures. The patient with an orbital fracture, such as a blowout fracture, may report double vision, diplopia, and loss of sensation above the eyebrow or over the cheek secondary to associated nerve damage. Fractures of the inferior orbit are the most common type, and can cause paralysis of upward gaze. The patient's injured eye will not be able to follow your finger above the midline. Zygomatic fractures. Fractures of the zygomatic bone, cheek bone, commonly result from blunt trauma secondary to motor vehicle collisions and assaults. When the zygomatic bone is fractured, that side of the patient's face appears flattened, and there may be paresthesia or loss of sensation over the cheek, nose, and upper lip. Paralysis of upward gaze may also be present. Other injuries commonly associated with zygomatic fractures include orbital fractures, ocular injury, and epistaxis. Assessment and management of face injuries. Table 24-1 summarizes the characteristics of various maxillofacial fractures. It is not important to distinguish among the various maxillofacial fractures in the pre-hospital setting. This determination requires radiographic evaluation, usually via computed tomography, CT, in the emergency department. Rapid patient assessment, management of life-threatening conditions, airway management, spinal motion restriction, and prompt transport are far more important considerations. Management of the patient with facial trauma begins by protecting the cervical spine. Because many severe facial injuries are complicated by a spinal injury, you must assume that one exists. Open the airway with the jaw thrust maneuver while simultaneously maintaining manual stabilization of the head in the neutral position unless the patient reports severe pain or discomfort on movement. Should that occur, the head or neck should be immobilized in the position found. Inspect the mouth for fragments of teeth, dentures, or any other foreign bodies that could obstruct the airway, and remove them immediately. Suction the oropharynx as needed to keep the airway clear of blood and other liquids. Insert an oral airway adjunct as needed to maintain airway patency. After establishing and maintaining a patent airway, assess the patient's breathing, and intervene appropriately. Administer oxygen as needed to maintain an oxygen saturation level of 94% or greater if the patient is breathing adequately. Patients who are breathing inadequately, that is, fast or slow rate, reduced tidal volume, shallow breathing, irregular pattern of breathing, should receive bag mask ventilation with 100% oxygen. Maintain the patient's oxygen saturation level at greater than 94%. Airway management can be especially challenging in patients with massive facial injuries. Oropharyngeal bleeding poses an immediate threat to the airway, and unstable facial bones can hinder your ability to maintain an effective mask-to-face seal for bag mask ventilation. Therefore, perform tracheal intubation of patients with facial trauma, especially those who are unresponsive, to protect their airway from aspiration, and to ensure adequate oxygenation and ventilation. Cricothyrotomy, surgical or needle, may be required for patients with extensive maxillofacial injuries when tracheal intubation is extremely difficult or impossible to perform, that is, in cases of unstable facial bones, massive swelling, severe oral bleeding. Treat facial lacerations and avulsions as you would any other soft tissue injury. Control all bleeding with direct pressure, and apply sterile dressings. If you suspect an underlying facial fracture, apply just enough pressure to control the bleeding. Leave impaled objects in the face in place, and appropriately stabilize them, unless they pose a threat to the airway, such as an object impaled through the cheek. When removing an object from the cheek, carefully remove it from the same direction that it entered. Next, pack the inside of the cheek with sterile gauze, and apply counterpressure with the dressing and bandage firmly secured over the outside of the wound. If profuse bleeding continues, position the patient on his or her side, while maintaining stabilization of the cervical spine, to facilitate drainage of secretions from the mouth and suction the airway as needed. For severe oropharyngeal bleeding in patients with inadequate ventilation, suction the airway for 15 seconds, and provide ventilatory assistance for 2 minutes. Continue this alternating pattern of suctioning and ventilating until the airway is cleared of blood or secured with a tracheal tube. Monitor the pulse oximeter during this process to keep the patient from becoming hypoxic. Epistaxis following facial trauma can be severe and is most effectively controlled by applying direct pressure to the nares. If the patient is responsive and spinal injury is not suspected, instruct the patient to sit up and lean forward as you pinch the nares together. Unresponsive patients should be positioned on their side, unless contraindicated by a spinal injury. Proper positioning of the patient with epistaxis is important to prevent blood from draining down the throat and compromising the airway, either by occlusion or by vomiting, and then aspirating gastric contents. If the responsive patient with severe epistaxis is immobilized supine with spinal motion restrictions, you should consider pharmacologically assisted intubation. For example, rapid sequence intubation, to gain definitive control of the airway if within your scope of practice, and local or regional protocols permit its use. Although facial lacerations and avulsions can contribute to hemorrhagic shock, they are rarely the sole cause of this condition in adults. Severe epistaxis, however, can result in significant blood loss. To counter this problem, you should carefully assess the patient for signs of hemorrhagic shock, and administer intravenous crystalloid fluid boluses as needed to maintain adequate perfusion. If the facial fracture is associated with swelling and ecchymosis, cold compresses may help minimize further swelling and alleviate pain. Do not apply a compress to the eyeball, globe, if you suspect that it has been injured following an orbital fracture. Doing so may increase the intraocular pressure, IOP, and further damage the eye. Additionally, it may stimulate the oculocardiac reflex. Other than protecting the airway, little can be done to treat facial instabilities. However, firmly applying a self-adhering roller bandage, such as Curlix or Cling, can stabilize the mandible. Make sure that you do not compromise the airway when stabilizing the mandible. After addressing all life-threatening injuries and conditions, you should attempt to ascertain the events that preceded the injury, and determine whether the patient has any significant medical problems. The incident that caused the injury may have been preceded by exacerbation of an underlying medical condition, such as acute hypoglycemia, cardiac dysrhythmia, or seizure. For unresponsive patients, medications that the patient is taking may provide information about his or her medical history. Determine the approximate time that the injury occurred, and ask about any drug allergies, and the last oral intake during your sample history. Eye injuries. Each day, over 700 Canadian workers sustain an eye injury on the job, according to the Canadian National Institute for the Blind. Because trauma to the eyes is so common and the potential consequences are so serious, you must know how to assess and manage ocular injuries. Eye injuries are frequently caused by blunt trauma, penetrating trauma, or burns. Blunt mechanisms of injury may include motor vehicle collisions, motorcycle collisions, falls, and assaults. Penetrating injuries are often secondary to foreign bodies on the surface of the eye, such as sand, or an object impaled in the globe. Burns to the eye can result from a variety of corrosive chemicals or during industrial accidents, such as welding burns. Lacerations, foreign bodies, and impaled objects. Lacerations of the eyelids require meticulous repair to restore appearance and function. Bleeding may be heavy, but it usually can be controlled by gentle, manual pressure. If there is a laceration to the globe itself, do not apply pressure to the eye. Compression can interfere with the blood supply to the back of the eye and result in loss of vision from damage to the retina. Furthermore, pressure may squeeze the vitreous humor, iris, lens, or even the retina out of the eye and cause irreparable damage or blindness. The protective orbit prevents large objects from penetrating the eye. However, moderately sized and smaller foreign objects can still enter the eye and, when lying on the surface of the eye, produce severe irritation. The conjunctiva becomes inflamed and red, a condition known as conjunctivitis, almost immediately, and the eye begins to produce tears in an attempt to flush out the object. Irritation of the cornea or conjunctiva causes intense pain. The patient may have difficulty keeping the eyelids open because the irritation is further aggravated by bright light. Foreign bodies ranging in size from a pencil to a sliver of metal may be impaled in the eye. Clearly, these objects must be removed by a physician. Pre-hospital care involves stabilizing the object and preparing the patient for transport. The greater the length of the foreign object sticking out of the eye, the more important stabilization becomes in avoiding further damage. Whenever possible, cover both eyes to limit unnecessary movement as the patient tries to use the uninjured eye to compensate for the loss of or limited vision of the injured eye. Blunt eye injuries. Blunt trauma can cause serious eye injuries, ranging from swelling and ecchymosis to rupture of the globe. Hyphema is bleeding into the anterior chamber of the eye that obscures vision, partially or completely. It often follows blunt trauma, and may seriously impair vision. Approximately 25% of hyphemas are associated with globe injuries. In orbital blowout fractures, the fragments of fractured bone can entrap some of the muscles that control eye movement, causing double vision, diplopia, especially with upward gaze. Any patient who reports pain, double vision, or decreased vision following a blunt injury about the eye should be assumed to have a blowout fracture, and should be promptly transported to an appropriate medical facility. Another potential result of blunt eye trauma is retinal detachment, or separation of the inner layers of the retina from the underlying choroid, the vascular membrane that nourishes the retina. Retinal detachment is often seen in sports injuries, especially boxing. This painless condition produces flashing lights, specks, or floaters in the field of vision, and a cloud or shade over the patient's vision. Because it can cause devastating damage to vision, retinal detachment is an ocular emergency and requires immediate medical attention. Burns of the eye. Chemicals, heat, and light rays can all burn the delicate tissues of the eye and ocular adnexa, often causing permanent damage. Your role is to stop the burning process and prevent further damage. Chemical burns, which are usually caused by acid or alkali solutions, require immediate emergency care. Flush the eye with clean water or a sterile saline solution. Specific techniques for irrigating the eyes are discussed later in this chapter. Thermal burns occur when a patient is burned in the face during a fire, although the eyes usually close rapidly because of the heat. This reaction is a natural reflex to protect the eyes from further injury. However, the eyelids remain exposed and are frequently burned. Infrared rays, solar eclipse light, if the patient has looked directly at the sun, and laser burns can cause significant damage to the sensory cells of the eye when rays of light become focused on the retina. Retinal injuries that are caused by exposure to extremely bright light are generally not painful, but may result in permanent damage to vision. Superficial burns of the eye can result from ultraviolet rays from an arc welding unit, prolonged exposure to a sun lamp, or reflected light from a bright snow-covered area, snow blindness. This kind of burn may not be painful initially, but may become so 3 to 5 hours later as the damaged cornea responds to the injury. Severe conjunctivitis usually develops, along with redness, swelling, photophobia, the sensation of a foreign object in the eye, and excessive tear production. Assessment and management of eye injuries. The first step in assessing a patient with an eye injury is to note the mechanism of injury, that is, blunt or penetrating trauma, burn. If it suggests the potential for a spinal injury, use spinal motion restriction precautions. Ensure a patent airway, and adequate breathing, and control any external bleeding. If the mechanism of injury is significant, or if the patient's clinical status dictates it, perform a rapid trauma assessment. When obtaining the history, determine how and when the injury happened, when the symptoms began, and what symptoms the patient is experiencing. Were both eyes affected? Does the patient have any underlying diseases or conditions of the eye, such as glaucoma? Does the patient take medications for his or her eyes? A variety of symptoms may indicate serious ocular injury. Visual loss that does not improve when the patient blinks is the most important symptom of an eye injury. It may indicate damage to the globe or to the optic nerve. Double vision usually points to trauma involving the extraocular muscles, such as a fracture of the orbit. Severe eye pain is a symptom of a significant eye injury. A foreign body sensation usually indicates superficial injury to the cornea or the presence of a foreign object trapped behind the eyelids. During the physical examination of the eyes, evaluate each of the following visible ocular structures and ocular function. Orbital rim, for ecchymosis, swelling, lacerations, and tenderness. Eyelids, for ecchymosis, swelling, and lacerations. Corneas, for foreign bodies. Conjunctivae, for redness, pus, inflammation, and foreign bodies. Globes, for redness, abnormal pigmentation, and lacerations. Pupils, for size, shape, equality, and reaction to light. Eye movements in all directions, for paralysis of gaze or discoordination between the movements of the two eyes, disconjugate gaze. Visual acuity. Make a rough assessment by asking the patient to read a newspaper or a handheld visual acuity chart. Test each eye separately and document the results. Treatment for specific eye injuries begins with a thorough examination to determine the extent and nature of any damage. Always perform your examination using appropriate personal protective equipment, taking great care to avoid aggravating the injury. Although isolated eye injuries are usually not life-threatening, they should be evaluated by a physician. More severe eye injuries often require evaluation and treatment by an ophthalmologist. Injuries to the eyelids, lacerations, abrasions, and contusions require little in the way of pre-hospital care other than bleeding control and gentle patching of the affected eye. No eyelid injury is trivial, However, so every patient with eyelid trauma should be transported to the hospital. Most injuries to the globe, including contusions, lacerations, foreign bodies, and abrasions, are best treated in the emergency department, where specialized equipment is available. Rigid eye shields, not gauze patches, applied over both eyes are generally all that is necessary in the pre-hospital environment. Follow these 3 important guidelines in treating penetrating injuries of the eye. 1. Never exert pressure on or manipulate the injured globe in any way. 2. If part of the globe is exposed, gently apply a moist, sterile dressing to prevent drying. 3. Cover the injured eye with a protective rigid eye shield, cup, or sterile dressing. Apply soft dressings to both eyes, and provide prompt transport to the hospital. If hyphema or rupture of the globe is suspected, take spinal motion restriction precautions. Such injuries indicate that a significant amount of force was applied to the face and, thus, may include a cervical spinal injury. Elevate the head of the stretcher approximately 30 degrees to 40 degrees, and ensure that the cervical collar is not too tight to help decrease IOP. Discourage the patient from performing activities that may increase IOP, for example, coughing. For the same reason, consider giving an antiemetic drug to reduce the incidence of vomiting. On rare occasions following a serious injury, the globe may be displaced, avulsed, out of its socket. Do not attempt to manipulate or reposition it in any way. Cover the protruding eye with a moist, sterile dressing and stabilize it along with the uninjured eye to prevent further injury due to sympathetic eye movement, the movement of both eyes in unison. Place the patient in a supine position to prevent further loss of fluid from the eye, and provide prompt transport to the hospital. Burns to the eye that are caused by ultraviolet light are most effectively treated by covering the eye with a sterile, moist pad and an eye shield. The application of cool compresses lightly over the eye may afford the patient pain relief if he or she is in extreme distress. Place the patient in a supine position during transport, and protect the patient from further exposure to bright light. Chemical burns to the eye, acid or alkali, can rapidly lead to total blindness if not immediately treated. The most important pre-hospital treatment in such cases is to begin immediate irrigation with sterile water or saline solution. Never use any chemical antidotes, such as vinegar or baking soda, when irrigating the patient's eye. Use sterile water or saline only. Neutralizing the acid or alkali causes a chemical reaction that creates much heat, thereby worsening the burn injury. The goal when irrigating the eye is to direct the greatest amount of solution or water into the eye as gently as possible. Because opening the eye spontaneously may cause the patient pain, you may have to force the lids open to irrigate the eye adequately. Ideally, you should use a bulb or irrigation syringe, a nasal cannula, or some other device that will allow you to control the flow. In some circumstances, you may have to pour water into the eye by supporting the patient's head under a gently running faucet. You can have the patient immerse his or her face in a large pan or basin of water, and rapidly blink the affected eyelid. If only one eye is affected, take care to avoid contaminated water getting into the unaffected eye. Irrigate the eye for at least 5 minutes. If the burn was caused by an alkali or a strong acid, irrigate the eye continuously for 20 minutes because these substances can penetrate deeply. One common possibility occurs where anhydrous ammonia is used during the process of cooking methamphetamine. If the eyes are not irrigated promptly and efficiently, permanent damage is likely. Whenever you have to irrigate the eye or eyes, continue to irrigate the eye or eyes en route to the hospital if possible. Irrigation with a sterile saline solution will frequently flush away loose, small foreign objects lying on the surface of the eye. Always flush from the nose side of the eye toward the outside to avoid flushing material into the other eye. After its removal, a foreign body will often leave a small abrasion on the surface of the conjunctiva, which leads to continued irritation. For this reason, you should transport the patient to the hospital for further assessment and treatment. Gentle irrigation usually will not wash out foreign bodies that are stuck to the cornea or lying under the upper eyelid. To examine the undersurface of the upper eyelid, pull the lid upward and forward. If you spot a foreign object on the surface of the eyelid, you may be able to remove it with a moist, sterile, cotton-tipped applicator. Never attempt to remove a foreign body that is stuck or embedded in the cornea. When a foreign body is impaled in the globe, do not remove it. Stabilize it in place. Cover the eye with a moist, sterile dressing, place a cup or other protective barrier over the object, and secure it in place with bulky dressing. Cover the unaffected eye to prevent further damage caused by sympathetic eye movement, and promptly transport the patient to the hospital. Occasionally, you may provide pre-hospital care for a patient who is wearing an eye prosthesis, artificial eye. You should suspect an eye of being artificial when it does not respond to light, move in concert with the opposite eye, or appear quite the same as the opposite eye. If you are unsure as to whether the patient has an eye prosthesis, ask him or her. Although no harm will be done if you care for an artificial eye as you would a normal one, you need to clearly understand the patient's eye function. In addition, it can be quite embarrassing to pass on information during your radio report that the patient has a non-reactive pupil only to find out at the emergency department that the patient has a prosthetic eye. Ear injuries. Injuries to the ear may be isolated, or they may occur in conjunction with other injuries to the head or face. Although isolated ear injuries are typically not life-threatening, they can result in sensory impairment and permanent disfigurement. Soft tissue injuries. Lacerations, avulsions, and contusions to the external ear can occur following blunt or penetrating trauma. The pinna can be contused, lacerated, or partially or completely avulsed. Trauma to the earlobe can result in similar injuries. The pinna has an inherently poor blood supply, so it tends to heal poorly. Healing of the cartilaginous pinna is often complicated by infection. Ruptured eardrum. Perforation of the tympanic membrane, ruptured eardrum, can result from foreign bodies in the ear or from pressure-related injuries, such as blast injuries resulting from an explosion, or diving-related injuries that result in barotrauma to the ear. Signs and symptoms of a perforated tympanic membrane include loss of hearing and blood drainage from the ear. Although the injury is extremely painful for the patient, the tympanic membrane typically heals spontaneously and without complication. Nevertheless, a careful assessment should be performed to detect and treat other injuries, some of which may be life-threatening. Assessment and management of ear injuries. Assessment and management of the patient with an ear injury begins by ensuring airway patency and breathing adequacy. If the mechanism of injury suggests a potential for spinal injury, apply full spinal motion restriction precautions. An adequate assessment of the external ear canal and middle ear cannot be performed in the pre-hospital environment. In general, the ear's poor blood supply limits the amount of external bleeding. If manual direct pressure does not control this bleeding, first place a soft, padded dressing between the ear and the scalp, because bandaging the ear against the scalp can be painful. Then, apply a roller bandage to secure the dressing in place. An ice pack can also help reduce swelling and pain. If the pinna is partially avulsed, carefully realign the ear into position, and gently bandage it with sufficient padding that has been slightly moistened with normal saline. If the pinna is completely avulsed, attempt to retrieve the avulsed part for reimplantation at the hospital. If the detached part of the ear is recovered, treat it as any other amputation. Wrap it in saline moistened gauze, place it in a plastic bag, and place the bag on ice. If a chemical ice pack is used, it is recommended to shield the avulsed part with several 4x4-inch gauze pads to diffuse the cold because chemical ice packs are actually colder than ice, and inadvertent freezing of the part can occur. If blood or cerebral spinal fluid drainage is noted, apply a loose dressing over the ear, taking care not to stop the flow, and assess the patient for other signs of a basilar skull fracture. Do not remove an impaled object from the ear. Instead, stabilize the object, and cover the ear to prevent gross movement, and to minimize the risk of contamination of the inner ear. Because isolated ear injuries are typically not life-threatening, you must perform a careful assessment to detect or rule out potentially more serious injuries. You may then proceed with specific care of the ear, provide emotional support, and transport the patient to an appropriate medical facility. Oral and dental injuries. Oral and dental injuries are commonly associated with trauma to the face. Blunt mechanisms are commonly the result of motor vehicle collisions or direct blows to the mouth or chin. Penetrating mechanisms are commonly the result of gunshot wounds, lacerations, and punctures. The primary risk associated with oral and dental injuries is airway compromise from oropharyngeal bleeding, occlusion by a displaced dental appliance such as a bridge or partial plate, or possibly by the aspiration of avulsed or fractured teeth. Any patient with significant facial trauma should be carefully assessed for injuries to the mouth and teeth. Soft tissue injuries. Lacerations and avulsions in and around the mouth are associated with a risk of intraoral hemorrhage and subsequent airway compromise. Therefore, your assessment of any patient with facial trauma should include a careful examination of the mouth, including the teeth. Fractured or avulsed teeth and lacerations of the tongue may cause profuse bleeding into the upper airway. A responsive patient with severe oral bleeding is often unable to speak unless he or she is leaning forward. This position facilitates drainage of blood from the mouth. Patients may swallow blood from lacerations inside the mouth, so the bleeding may not be grossly evident. Because blood irritates the gastric lining, the risks of vomiting and aspiration are significant. Objects that are impaled in or through the soft tissues of the mouth, such as the cheek, can also result in profuse bleeding, and possibly vomiting. This may result in significant aspiration risk. Dental injuries. Fractured and avulsed teeth, especially the anterior teeth, are common following facial trauma. Dental injuries may be associated with mechanisms that cause severe maxillofacial trauma, such as motor vehicle collisions, or they may occur in isolation, such as a direct blow to the mouth from an assault. You should always assess the patient's mouth following a facial injury, especially in cases of fractured or avulsed teeth. Teeth fragments, or even whole teeth, can become an airway obstruction, and should be removed from the patient's mouth immediately. Assessment and management of oral and dental injuries. Ensuring airway patency and adequate breathing are the priorities of pre-hospital care when managing patients with oral or dental trauma. Suction the oropharynx as needed, and remove fractured tooth fragments to prevent airway compromise. Apply spinal motion restriction precautions as dictated by the mechanism of injury. If profuse oral bleeding is present and the patient cannot spontaneously control his or her own airway, such as with a decreased level of consciousness, pharmacologically assisted intubation may be necessary. Impaled objects in the soft tissues of the mouth should be stabilized in place unless they interfere with the patient's breathing or your ability to manage the patient's airway. In those cases, remove the impaled object from the direction that it entered and control bleeding with direct pressure. An avulsed tooth may be successfully reimplanted even if it has been out of the mouth for as long as 1 hour. Direct medical control may sometimes ask you to reimplant the tooth in its original socket. Carefully place the tooth in its socket, and hold it in place with your fingers or have the patient gently bite down. If pre-hospital reimplantation of a tooth is not possible, follow the guidelines established by the American Association of Endodontists, the American Dental Association, and the Canadian Dental Association. Retrieval and reimplantation or storage of an avulsed tooth is a low priority if the patient is in a clinically unstable condition, such as compromised airway or shock. In such cases, aggressive airway management, spinal precautions, and rapid transport of the patient are obviously more important, with the dental problem being addressed at a later time. Injuries to the anterior part of the neck. The neck is a very vulnerable stretch of anatomy because it houses a critical portion of the airway, that is, larynx, trachea, the major blood vessels to and from the head, and the spinal cord. Other structures contained within the neck that are also vulnerable to injury include muscles, nerves, glands, and the esophagus. Any injury to the anterior part of the neck, blunt or penetrating, must be considered critical until proven otherwise. One method used to identify the structures within the neck and assist in classification of neck injuries divides the neck into zones. Injuries in Zone 1 can extend into the chest, and may not be easily recognized on physical examination. Injuries in this area are associated with the highest mortality rate. Injuries in Zone 2 are the most common, are usually the most obvious, and have a lower mortality rate than do Zone 1 injuries. Injuries in Zone 3 often are difficult for a surgeon to access and repair because many of the structures enter the base of the skull. Soft tissue injuries. Blunt and penetrating mechanisms can damage the soft tissues of the anterior part of the neck, and its associated structures. In both cases, you must be alert for the possibility of cervical spine injury and airway compromise. Common mechanisms of blunt trauma include motor vehicle collisions, direct trauma to the neck, and hangings. Such injury often results in swelling and edema, injury to the various structures such as the trachea, larynx, or esophagus, or injury to the cervical spine. Less commonly, blunt injuries may damage the vasculature of the anterior part of the neck. Because blunt trauma to the neck is associated with a high incidence of airway compromise and ventilatory inadequacy, you must carefully assess the patient and be prepared to initiate aggressive management. Common mechanisms of penetrating trauma include gunshot wounds, stabbings, and impaled objects. The lacerations or puncture wounds produced may be superficial and involve only the fascia or fatty tissues of the neck, or they may be deep and involve injury to the larynx, trachea, esophagus, nerves, or major blood vessels. The primary threats from penetrating neck trauma are massive hemorrhage from major blood vessel disruption and airway compromise secondary to soft tissue swelling or direct damage to the larynx or trachea. A special danger associated with open neck injuries is the possibility of a fatal air embolism. If the jugular veins of the neck are exposed to the environment, they may entrain air into the vessel and occlude the flow of blood to the lungs. As such, open neck wounds should be sealed with an occlusive dressing immediately. Impaled objects in the neck can present several life-threatening problems for the patient, namely, injury to major blood vessels with massive hemorrhage, damage to the larynx, trachea, or esophagus, or injury to the cervical spine. Impaled objects should not be removed, but rather stabilized in place and protected from movement. The only exception is if the object is obstructing the airway or impeding your ability to effectively manage the airway. In some cases, an emergency cricothyrotomy may be necessary to establish and maintain airway patency. Injuries to the larynx, trachea, and esophagus. A variety of life-threatening injuries can result if the structures of the anterior part of the neck are crushed against the cervical spine following blunt trauma or if they are penetrated by a knife or similar object. The larynx and its supporting structures, that is, hyoid bone, thyroid cartilage, and cricoid ring, may be fractured. The trachea may be separated from the larynx, tracheal transection, or the esophagus may be perforated. Many injuries to the larynx, trachea, and esophagus are occult, because they are not as obvious and dramatic as penetrating neck injuries. They can be easily overlooked. Therefore, you must maintain a high index of suspicion, and perform a careful assessment of any patient with blunt trauma to the anterior part of the neck. Significant injuries to the larynx or trachea pose an immediate risk of airway compromise due to disruption of the normal passage of air, soft tissue swelling, or aspiration of blood into the lungs. In addition, esophageal perforation can result in mediastinitis, an inflammation of the mediastinum often caused by leakage of gastric contents into the thoracic cavity. Mediastinitis is associated with a high mortality rate if not surgically repaired in a timely manner. Patients with injuries to the anterior part of the neck may experience concomitant maxillofacial fractures, which can make bag mask ventilation difficult, usually because of an inadequate mask-to-face seal. Likewise, tracheal intubation may be extremely challenging, if not impossible, owing to distortion of the normal anatomy of the upper airway. If basic and advanced techniques to secure the patient's airway are unsuccessful or impossible, a surgical or needle cricothyrotomy may be your only means of establishing a patent airway and ensuring adequate oxygenation and ventilation. Prior to deciding to perform a surgical airway, Use of a lighted stylet or a gum bougie may get the airway secure in a timely fashion while avoiding more risky procedures. Assessment and management of injuries to the anterior part of the neck. Begin your assessment by noting the mechanism of injury, and maintaining a high index of suspicion, especially if the patient has experienced blunt or penetrating trauma between the upper part of the chest and head. Fractures of the first rib are associated with close to 50% mortality, not because of the rib fracture itself, but because fracturing such a short, stout bone takes so much force that significant face, head, and neck trauma are almost always present as well. Remember that obvious and dramatic appearing soft tissue injuries may mask occult injuries to the larynx, trachea, or esophagus. Also, the patient may have experienced trauma to multiple body systems, especially following a significant mechanism of injury. As you begin your initial assessment, manually stabilize the patient's head in a neutral inline position, and simultaneously open the airway with the jaw thrust maneuver if the patient is unresponsive. Use suction as needed to clear the airway of blood or other liquids. Assess the patient's breathing, rate, regularity, and depth and intervene immediately. If the patient is breathing adequately, apply a non-rebreathing mask at 15 liters per minute. If breathing is inadequate, that is, reduce tidal volume, fast or slow respirations, assist with bag mask ventilation and 100% oxygen. Your primary focus is always treating the injuries that will be the most rapidly fatal. Because death following trauma to the anterior part of the neck is usually the result of airway compromise or massive bleeding, aggressive airway management, and external bleeding control are the highest priorities of pre-hospital care. After addressing any life-threatening or other serious problems with the ABCs during the initial assessment, you may perform a rapid trauma assessment to detect and treat other injuries. To control bleeding from an open neck wound and prevent air embolism, immediately cover the wound with an occlusive dressing. In the case of a small wound or wounds, electrocardiogram electrodes can be fast and effective ways to seal a small hole or holes. Apply manual direct pressure over the occlusive dressing with a bulky dressing. As a last resort, you can secure a pressure dressing over the wound by wrapping roller gauze loosely around the neck, and then firmly through the opposite axilla. Do not circumferentially wrap bandages around the neck to secure the dressing in place. This is contraindicated, and could even be fatal, because it may impair cerebral perfusion by occluding both carotid arteries or interfere with the patient's breathing. Monitor the patient's pulse for reflex bradycardia, which indicates parasympathetic nervous stimulation due to excessive pressure on the carotid artery. Bruising or redness to the overlying skin, and palpable tenderness are common signs associated with injuries to the anterior part of the neck. If signs of shock are present, administer oxygen as necessary to maintain an oxygen saturation level of 94% or higher, control any external hemorrhage, and keep the patient warm. Establish vascular access with at least one large-bore intravenous catheter, and infuse an isotonic crystalloid solution, such as lactated Ringer solution or normal saline, as needed to maintain a systolic blood pressure of 80 to 90 millimeters of mercury. Many patients with serious laryngeal trauma have airway trauma, and require a surgical airway or percutaneous airway. Tracheal intubation may be hazardous in such cases because you cannot see the tip of the tracheal tube once it passes between the vocal cords. It may pass straight through a defect in the laryngeal or tracheal wall or could result in the complete transection of the trachea. Signs of this complication include increased swelling of the neck and worsening subcutaneous emphysema during assisted ventilation. If the patient has experienced an open tracheal wound, you may be able to pass a cuff tracheal tube directly through the wound to establish a patent airway. Use caution, however, the trachea may be perforated anteriorly and posteriorly, which would increase the risk of false passage of the tracheal tube outside the trachea. It is critical to use multiple techniques for confirming correct tube placement. Frequently monitor breath sounds, directly measure the expired carbon dioxide. Waveform capnography is preferred for this purpose, assess for adequate chest rise, and assess for vapor mist in the tracheal tube during exhalation. Head injuries. A head injury is a traumatic insult to the head that may result in injury to soft tissue, bony structures, or the brain. Approximately 160,000 people experience head injuries of varying severity in Canada each year, and approximately 8% of admissions for traumatic head injury are fatal, which is twice as high as the death rate for all traumatic injury hospitalizations in Canada, 4%. The majority of deaths occurred in the elderly. When head injuries are fatal, the cause is invariably associated with injury to the brain. Motor vehicle collisions are the most common mechanism of injury, with more than 2/3 of people involved in motor vehicle collisions experiencing a head injury. Head injuries also occur commonly in victims of assault, when elderly people fall, during sports-related incidents, and in a variety of incidents involving children. There are two general types of head injuries, open and closed. A closed head injury, the most common type, is usually associated with blunt trauma. Although the dura mater remains intact and brain tissue is not exposed to the environment, closed head injuries may result in skull fractures, focal brain injuries, or diffuse brain injuries. Furthermore, these injuries are often complicated by increased intracranial pressure, ICP. With an open head injury, the dura mater and cranial contents are penetrated, and brain tissue is open to the environment. Gunshot wounds, the most common penetrating mechanism of injury, have a high mortality rate, and for those who survive there is almost always significant neurologic deficit, and a decreased quality of life. Scalp lacerations. Scalp lacerations can be minor or very serious. Because of the scalp's rich blood supply, even small lacerations can quickly lead to significant blood loss. Hypovolemic shock in adults is rarely caused by scalp lacerations alone. This is more common in children. However, bleeding from the scalp can contribute to hypovolemia in any patient, especially one with multiple injuries. In addition, because scalp lacerations usually result from direct blows to the head, they often indicate deeper, more severe injuries. Skull fractures. 4 types of skull fractures are distinguished: linear, depressed, basilar, and open. The significance of a skull fracture is directly related to the type of fracture, the amount of force applied, and the area of the head that sustained the blow. Skull fractures are most commonly seen following motor vehicle collisions and significant falls. They may or may not be associated with soft tissue scalp injuries. Potential complications of any skull fracture include intracranial hemorrhage, cerebral damage, and cranial nerve damage, among others. Linear skull fractures. Linear skull fractures, non-displaced skull fractures, account for approximately 80% of all fractures to the skull. Approximately 50% of linear fractures occur in the temporal parietal region of the skull. Radiographic evaluation is required to diagnose a linear skull fracture because there are often no gross physical signs, such as deformity or depression. If the brain is uninjured and the scalp is intact, linear fractures are relatively benign. However, if a scalp laceration occurs in conjunction with a linear fracture, making it an open fracture, there is a risk of infection. In addition, if the fracture occurs over the temporal region of the skull, injury to the middle meningeal artery may result in epidural bleeding, which can rapidly become catastrophic. Depressed skull fractures. Depressed skull fractures result from high-energy, direct trauma to a small surface area of the head with a blunt object, such as a baseball bat to the head. The frontal and parietal regions of the skull are most susceptible to these types of fractures because the bones in these areas, compared with other bones of the skull, are relatively thin. As a consequence, bony fragments may be driven into the brain, resulting in underlying injury. The overlying scalp may or may not be intact. Patients with depressed skull fractures often present with neurologic signs, such as loss of consciousness. Basilar skull fractures. Basilar skull fractures also are associated with high-energy trauma, but they usually occur following diffuse impact to the head, for example, falls, motor vehicle collisions. These injuries generally result from extension of a linear fracture to the base of the skull, and can be difficult to diagnose, even with radiography. Signs of a basilar skull fracture include cerebral spinal fluid drainage from the ears, which indicates rupture of the tympanic membrane, and freely flowing cerebral spinal fluid through the ear. Patients with leaking cerebral spinal fluid are at risk for bacterial meningitis. Other signs of a basilar skull fracture include periorbital ecchymosis that develops under or around the eyes, which is also known as raccoon or panda eyes. Ecchymosis behind the ear, over the mastoid process, is known as battle sign. Depending on the extent of the damage, raccoon eyes and battle sign may appear relatively quickly, but in many cases, they may not appear until up to 24 hours following the injury, so their absence in the pre-hospital setting does not rule out a basilar skull fracture. Open skull fractures. Open fractures of the cranial vault result when severe forces are applied to the head, and are often associated with trauma to multiple body systems. Brain tissue may be exposed to the environment, which significantly increases the risk of a bacterial infection, such as bacterial meningitis. Open cranial vault fractures have a high mortality rate. Traumatic brain injuries. Traumatic brain injury, TBI, is defined as a traumatic insult to the brain capable of producing physical, intellectual, emotional, social, and vocational changes. TBI is classified into two broad categories: primary, direct, injury, and secondary, indirect, injury. Primary brain injury is injury to the brain and its associated structures that results instantaneously from impact to the head. Secondary brain injury is a consequence of the primary injury. It includes abnormal processes such as cerebral edema, intracranial hemorrhage, increased intracranial pressure, cerebral ischemia and hypoxia, hypoglycemia, hypotension, and infection. Secondary brain injury can occur at any time, from a few minutes to several days following the initial injury. The brain can be injured directly by a penetrating object, such as a bullet, knife, or other sharp object. More commonly, such injuries occur indirectly as a result of external forces exerted on the skull. Consider the most common cause of brain injury, the motor vehicle collision. When the passenger's head hits the windshield on impact with a fixed object, the brain continues to move forward until it comes to an abrupt stop by striking the inside of the skull. This rapid deceleration results in compression injury, or bruising, to the anterior portion of the brain, along with stretching or tearing of the posterior portion of the brain. As the brain strikes the front of the skull, the body begins its path of moving backward. The head falls back against the headrest and dorsete, and the brain impacts against the rear of the skull. This type of front-end rear injury is known as a coup contra coup injury. The same type of injury may occur on opposite sides of the brain in a lateral collision. The injured brain starts to swell, initially because of cerebral vasodilation. An increase in cerebral water, cerebral edema, then contributes to further brain swelling. Cerebral edema may not develop until several hours following the initial injury, however. Intracranial pressure. In adults, the skull is a rigid, unyielding globe that allows little, if any, expansion of the intracranial contents. It also provides a hard and somewhat irregular surface against which brain tissue and its blood vessels can be injured when the head sustains trauma. Accumulations of blood within the skull or swelling of the brain can rapidly lead to an increase in intracranial pressure, the pressure within the cranial vault. Increased intracranial pressure squeezes the brain against bony prominences within the cranium. Normal intracranial pressure in adults ranges from 5 to 15 millimeters of mercury. An increase in intracranial pressure, such as from cerebral edema or intracranial hemorrhage, decreases cerebral perfusion pressure and cerebral blood flow. Cerebral perfusion pressure, CPP, the pressure of blood flow through the brain, is the difference between the mean arterial pressure, MAP, the average, or mean, pressure against the arterial wall during a cardiac cycle, and intracranial pressure, cerebral perfusion pressure equals mean arterial pressure minus intracranial pressure. Obviously, decreasing cerebral blood flow is a potential catastrophe because the brain depends on a constant supply of blood to furnish the oxygen and glucose it needs to survive. The critical minimum threshold, or minimum cerebral perfusion pressure required to adequately perfuse the brain, is 60 mm of mercury in the adult. A cerebral perfusion pressure of less than 60 mm of mercury will lead to cerebral ischemia, potentially resulting in permanent neurologic impairment or even death. In fact, according to the Brain Trauma Foundation, a single drop in cerebral perfusion pressure below 60 mm of mercury doubles the chance of death in a patient with a brain injury. The body responds to a decrease in cerebral perfusion pressure by increasing mean arterial pressure, resulting in cerebral vasodilation and increased cerebral blood flow. This process is called autoregulation. However, an increase in cerebral blood flow causes a further increase in intracranial pressure. As intracranial pressure continues to increase, cerebral spinal fluid is forced from the cranium into the spinal cord. Clearly, the patient with increased intracranial pressure is caught in the midst of a vicious cycle. As intracranial pressure increases, cerebral blood flow increases secondary to autoregulation, which in turn leads to a potentially fatal increase in intracranial pressure. Conversely, if cerebral blood flow decreases, cerebral perfusion pressure decreases as well, and the brain becomes ischemic. Cerebral perfusion pressure cannot be calculated in the pre-hospital setting. Therefore, pre-hospital treatment must focus on maintaining mean arterial pressure while mitigating intracranial pressure rise as much as possible, a very fine balance to maintain. If increased intracranial pressure is not promptly treated in a definitive care setting, cerebral herniation may occur. In herniation, the brain is forced from the cranial vault, either through the foramen magnum or over the tentorium. You must closely monitor the patient with a head injury for signs and symptoms of increased intracranial pressure. The exact clinical signs encountered depend on the amount of pressure inside the skull, and the extent of brainstem involvement. Early signs and symptoms include vomiting, often without nausea, headache, an altered level of consciousness, and seizures. Later, more ominous signs include hypertension, with a widening pulse pressure, bradycardia, and irregular respirations, Cushing triad, plus a unilaterally dilated and non-reactive pupil, caused by oculomotor nerve compression, coma, and posturing. Decorticate, flexor, posturing is characterized by flexion of the arms and extension of the legs. Decerebrate, extensor, posturing is characterized by extension of the arms and legs. Diffuse brain injuries. Brain injuries are broadly classified as diffuse or focal. A diffuse brain injury is any injury that affects the entire brain. These injuries include cerebral concussion and diffuse axonal injury. Cerebral concussion. A cerebral concussion occurs when the brain is jarred around in the skull. This kind of mild diffuse brain injury is usually caused by rapid acceleration-deceleration forces, coup contra coup, such as those seen following motor vehicle collisions or falls. A concussion injury results in transient dysfunction of the cerebral cortex. Its resolution is usually spontaneous and rapid and is not associated with structural damage or permanent neurologic impairment. Signs of a concussion range from transient confusion and disorientation to confusion that may last for several minutes. Loss of consciousness may or may not occur. Retrograde amnesia, a loss of memory relating to events that occurred before the injury, or anterograde, post-traumatic amnesia, a loss of memory relating to events that occurred after the injury, may follow a concussion. Diffuse axonal injury. Diffuse axonal injury, DAI, is associated with or similar to a concussion. Unlike a concussion, however, this more severe diffuse brain injury is often associated with a poor prognosis. Diffuse axonal injury involves stretching, shearing, or tearing of nerve fibers with subsequent axonal damage. An axon is a long, slender extension of a neuron, nerve cell, that conducts electrical impulses away from the neuronal soma, cell body, in the brain. Diffuse axonal injury most often results from high-speed, rapid acceleration-deceleration forces, such as motor vehicle collisions, and significant falls. The severity and, thus, the prognosis of diffuse axonal injury depends on the degree of axonal damage, for example, stretching versus shearing or tearing. Diffuse axonal injury is classified as being mild, moderate, or severe. Focal brain injuries. A focal brain injury is a specific, clearly defined brain injury. For example, it can be seen on a CT scan. Such injuries include cerebral contusions and intracranial hemorrhage. Cerebral contusion. In a cerebral contusion, brain tissue is bruised and damaged in a local area. Because a cerebral contusion is associated with physical damage to the brain, greater neurologic deficits, such as prolonged confusion and loss of consciousness, are more commonly observed than with a concussion. The same mechanisms of injury that cause concussions, acceleration-deceleration forces, and direct blunt head trauma, also cause cerebral contusions. The area of the brain most commonly affected by a cerebral contusion is the frontal lobe, although multiple areas of contusion can occur, especially following coup contra coup injuries. As with any bruise, the reaction of the injured tissue will be to swell. This swelling inevitably leads to increased intracranial pressure, and its accompanying negative consequences. Intracranial hemorrhage. The closed globe of the skull has no extra room for accumulation of blood, so bleeding inside the skull also increases intracranial pressure. Bleeding can occur between the skull and dura mater, beneath the dura mater but outside the brain, within the parenchyma, tissue, of the brain itself, intracerebral space, or into the cerebral spinal fluid, subarachnoid space. Epidural hematoma. An epidural hematoma is an accumulation of blood between the skull and dura mater. It occurs in approximately 0.5% to 1% of all head injuries. An epidural hematoma is nearly always the result of a blow to the head that produces a linear fracture of the thin temporal bone. The middle meningeal artery courses along a groove in that bone, so it is prone to disruption when the temporal bone is fractured. In such a case, brisk arterial bleeding into the epidural space will result in rapidly progressing symptoms. Often, the patient loses consciousness immediately following the injury. This is often followed by a brief period of consciousness, lucid interval, after which the patient lapses back into unresponsiveness. Meanwhile, as intracranial pressure increases, the oculomotor nerve, third cranial nerve, is compressed against the tentorium, and the pupil on the side of the hematoma becomes fixed and dilated. Death will follow very rapidly without surgery to evacuate the hematoma. Subdural hematoma. A subdural hematoma is an accumulation of blood beneath the dura mater, but outside the brain. It usually occurs after falls or injuries involving strong deceleration forces, and occurs in approximately 5% of all head injuries. Subdural hematomas are more common than epidural hematomas and may or may not be associated with a skull fracture. Bleeding within the subdural space typically results from rupture of the veins that bridge the cerebral cortex and dura. A subdural hematoma is associated with venous bleeding, so this type of hematoma, and the signs of increased intracranial pressure, typically develop more gradually than with an epidural hematoma. The patient with a subdural hematoma often experiences a fluctuating level of consciousness, focal neurologic signs, such as unilateral hemiparesis, or slurred speech. Subdural hematomas are classified as acute, clinical signs developing within 24 hours following injury, or chronic, symptoms may not appear for as long as 2 weeks. Chronic subdural hematomas are more common in elderly patients, patients with alcoholism, patients with bleeding diatheses, such as hemophilia, and patients taking anticoagulants, such as warfarin Olmedin. Intracerebral hematoma. An intracerebral hematoma involves bleeding within the brain tissue itself. This type of injury can occur following a penetrating injury to the head or because of rapid deceleration forces. Many small, deep intracerebral hemorrhages are associated with other brain injuries, such as diffuse axonal injury. The progression of increased intracranial pressure and neurologic deficit depends on several factors, including the presence of other brain injuries, the region of the brain involved, frontal and temporal lobes are most common, and the size of the hemorrhage. Once symptoms appear, the patient's condition often deteriorates quickly. Intracerebral hematomas have a high mortality rate, even if the hematoma is surgically evacuated. Subarachnoid hemorrhage. In a subarachnoid hemorrhage, bleeding occurs in the subarachnoid space, where the cerebral spinal fluid circulates. It results in bloody cerebral spinal fluid and signs of meningeal irritation, such as nuchal rigidity and headache. Common causes of a subarachnoid hemorrhage include trauma or rupture of an aneurysm or arteriovenous malformation. The patient with a subarachnoid hemorrhage typically presents with a sudden, severe headache. This headache is often localized initially, but later becomes diffuse secondary to increased meningeal irritation. As bleeding into the subarachnoid space increases, the patient experiences the signs and symptoms of increased intracranial pressure, decreased level of consciousness, pupillary changes, posturing, vomiting, and seizures. A sudden, severe subarachnoid hemorrhage usually results in death. People who survive often have permanent neurologic impairment. Assessment and management of head and brain injuries. Pre-hospital assessment and treatment of the patient with a head injury should be guided by factors such as the severity of the injury and the patient's level of consciousness. As with any patient, your treatment priorities must be based on what will kill the patient first. Assessment of head and brain injuries. Motor vehicle collisions, direct blows, falls from heights, assaults, and sports-related injuries are common causes of head injuries and TBI. A patient who has experienced any of these events should immediately elevate your index of suspicion and prompt a search for signs and symptoms of these types of injuries. For example, a deformed windshield or dented or cracked helmet indicates a major blow to the head. Level of consciousness. A change in the level of consciousness is the single most important observation that you can make when assessing the severity of brain injury. The level of consciousness usually indicates the extent of brain dysfunction. Whenever you suspect a head injury, you should perform a baseline neurologic assessment using the AVPU scale: alert, responsive to verbal stimuli, responsive to pain, unresponsive, and record the time. Use the more detailed Glasgow Coma Scale, GCS, when performing serial neurologic assessments of a patient with a head injury, outlined in Chapter 17, Patient Assessment. The GCS, a widely accepted method of assessing level of consciousness, is based on 3 independent measurements: eye opening, verbal response, and motor response. The GCS score is used to classify the severity of the patient's brain injury, Table 24-6, and is a reliable predictor of the outcome in a patient with a brain injury. Pupillary assessment. Frequently monitor the pupil size, equality, and reactivity. The nerves that control dilation and constriction of the pupils are very sensitive to intracranial pressure. When you shine a light into the eye, the pupil should briskly constrict. A pupil that is slow, sluggish, to constrict is a relatively early sign of increased intracranial pressure. A sluggish pupil could also indicate cerebral hypoxia. Unequal or bilaterally fixed and dilated, blown, pupils are later, more ominous signs of increased ICP and indicate pressure on one or both oculomotor nerves. Assessing intracranial pressure. Although intracranial pressure cannot be quantified, assigned a numeric value, in the pre-hospital setting, the severity of increase can be estimated based on the patient's clinical presentation. Critical treatment decisions for patients with a brain injury are based on the presence or absence of certain key findings, specifically, posturing, hypotension, or hypertension, and abnormal pupil signs. Use serial assessments of the patient's GCS scores and pupillary assessment as indicators of the progression of intracranial pressure. Management of head and brain injuries. Patients with head injuries often have cervical spine injuries as well. Therefore, as you begin your initial assessment of a patient with a head injury, manually stabilize the cervical spine in a neutral, inline position. Avoid moving the neck unnecessarily, and continue manual stabilization until full spinal motion restriction precautions have been applied. Managing airway and breathing. The most important step in the treatment of any type of head injury is to establish and maintain a patent airway. Open the airway with the jaw thrust maneuver if the patient is unresponsive or is otherwise unable to maintain his or her own airway spontaneously. Patients with a head injury often vomit, especially children. Therefore, after opening the airway, you must be prepared to roll the patient to the side, while maintaining spinal stabilization, to prevent aspiration. If it is safe to do so, manually remove any large debris from the patient's mouth by sweeping the oropharynx with your gloved finger. Use suction to clear secretions, such as blood or thin secretions from the oropharynx. Mortality increases significantly if aspiration occurs. If the patient has a decreased level of consciousness, insert a basic airway adjunct, for example, oral or nasal airway. Do not insert a nasal airway if cerebral spinal fluid or rhinorrhea is present or if you suspect a nasal or basilar skull fracture. After you have cleared the airway, assess the patient's ventilatory status. Cerebral edema and intracranial pressure are aggravated by hypoxia and hypercarbia, therefore, you must constantly ensure adequate oxygenation and ventilation in any patient with a head injury. Administer 100% oxygen via non-rebreathing mask if the patient is breathing adequately, that is, adequate rate and depth tidal volume, regular respiratory pattern. An injured brain is even less tolerant of hypoxia than a healthy one, and research has demonstrated that prompt administration of supplemental oxygen can reduce the amount of brain damage and improve neurologic outcome. If the respiratory center of the brain, pons, medulla, has been injured, the rate, depth, or regularity of breathing may be ineffective. Ventilation may also be impaired by concomitant chest injuries or, if the spinal cord is injured, by paralysis of some or all of the respiratory muscles. Patients with inadequate ventilation, especially if associated with a decreased level of consciousness, should receive bag mask ventilation and 100% oxygen. Ventilate an adult with a brain injury at a rate of 10 breaths per minute or as dictated by local protocols. Avoid routine hyperventilation of patients with brain injuries. Although hyperventilation causes cerebral vasoconstriction, which will shunt blood from the cranium, and lower intracranial pressure, this outcome will merely provide additional room for the injured brain to swell or for more blood to accumulate in the skull. Most important, cerebral vasoconstriction shunts oxygen away from the brain and results in a drop in cerebral perfusion pressure, causing cerebral ischemia. The Brain Trauma Foundation recommends hyperventilation, 20 breaths per minute for adults, only if signs of cerebral herniation are present. In such patients, brief periods of hyperventilation may be beneficial. If available, end-tidal carbon dioxide should be monitored with digital capnometry. Optimally, you should ventilate the patient to maintain end-tidal carbon dioxide of 35 to 40 millimeters of mercury, an approximation of arterial partial pressure of carbon dioxide, between 30 and 35 millimeters of mercury. Under no circumstances should the end-tidal carbon dioxide be allowed to ever drop below 30 millimeters of mercury, corresponding to partial pressure of carbon dioxide below 25 millimeters of mercury, as the subsequent vasoconstriction will almost assuredly result in cerebral anoxia, secondary brain injury, and possibly brain death. Paramedics are advised to consult their service's medical protocols and advice from direct medical control or the medical director regarding appropriate indications for hyperventilation and target end-tidal carbon dioxide if hyperventilation is used. Tracheal intubation of a patient with head injuries in the pre-hospital environment is controversial. The decision to intubate requires special precautions or it may precipitate dangerous increases in intracranial pressure. The paramedic may need to factor in such issues as distance from destination center, his or her skill set, and local medical protocols. This must be balanced against the potential for hypercarbia, hypoxia, or hypotension that can occur during the intubation process. This is especially possible if pharmacologic intervention is used to facilitate intubation. If intubation of a patient with a head injury is required, for example, unresponsive, unable to effectively perform bag mask ventilation, observe the following guidelines. 1. Pre-oxygenate with 100% oxygen for at least 2 to 3 minutes or to a saturation of 100%. 2. Patients with potential head injury or traumatic head injury historically have been administered lidocaine, 1 to 1.5 milligrams per kilogram intravenous push, before intubation. This technique was believed to blunt an acute increase in intracranial pressure that may occur during intubation. This procedure is controversial, however, and the current view is that evidence is insufficient to support or refute its use during intubation in these patients. Consult your local or regional protocols to determine if lidocaine is part of your approach to intubating a patient with a head injury. 3. Perform intubation with the patient's head in a neutral inline position. Intubation of a patient with a head injury or any patient with significant trauma should be performed by two people, one to maintain manual stabilization of the patient's head, and the other to intubate. If a patient with a head injury requires intubation, but will otherwise not tolerate laryngoscopy and tracheal tube placement, for example, because of combativeness or clenched teeth trismus, perform pharmacologically assisted intubation, for example, rapid sequence intubation. This procedure involves using a sedative hypnotic drug and a neuromuscular blocking drug to facilitate placement of the tracheal tube. Refer to Chapter 13, Airway Management, for more on pharmacologically assisted intubation. Refer to your local or regional protocols for your service's preferred method to manage the airway. Closely monitor the patient's oxygen saturation, and maintain it at 95% or higher. Managing circulation. After you have secured the patient's airway, and ensured adequate oxygenation and ventilation, and while your partner continues to maintain manual inline cervical stabilization, you must turn your attention to supporting the patient's circulation. Control major bleeding with direct pressure, taking care not to apply excessive pressure to scalp lacerations in which an underlying fracture is present or suspected. Active bleeding will cause or worsen hypoxia, as well as decrease cerebral perfusion pressure, by reducing the number of oxygen-carrying red blood cells. An isolated closed head injury will not cause hypovolemic shock in an adult because the skull does not have enough room to accommodate large volumes of blood. If signs of shock are present, for example, persistent hypotension, tachycardia, diaphoresis, carefully assess the patient for occult injuries, such as intra-abdominal or intrathoracic hemorrhage. Establish at least one large-bore intravenous line with normal saline or lactated Ringer solution. Do not administer dextrose-containing solutions, such as 5% dextrose in water D5W, because they may worsen cerebral edema. The only indication for administering glucose to a patient with a head injury is confirmed hypoglycemia, that is, a glucometer reading less than 4 millimoles per liter. Patients with a severe closed head injury are often hypertensive, a sign of the body's autoregulatory response. Restrict your use of intravenous fluids for these patients to minimize cerebral edema and intracranial pressure, typically at a rate of 30 to 50 milliliters per hour. However, if hypotension develops, infuse fluids as needed, usually 20 milliliters per kilogram boluses or as directed by direct medical control, to maintain a systolic blood pressure of at least 90 millimeters of mercury. Hypotension in a patient with a brain injury can be lethal because it may decrease cerebral perfusion pressure with resultant cerebral ischemia, permanent brain damage, and death. Severe head injuries, especially if the lower brainstem is involved, can produce a variety of cardiac rhythm disturbances, so use a cardiac monitor for any critically injured patient. Use of a cardiac monitor also allows you to monitor the patient for acute heart rate changes. If cardiac arrest occurs, follow the Advanced Cardiac Life Support (ACLS) pulseless arrest protocol. Other management. Thermal management. Do not allow the patient to become overheated. Patients with head injury, unlike those with shock, can develop a very high body temperature, hyperpyrexia, which in turn may worsen the condition of the brain. Do not cover the patient with blankets if the ambient temperature is 21 degrees Celsius or higher. Treatment of associated injuries. If the patient has an open fracture of the skull with brain tissue exposed, cover it lightly with a sterile dressing that has been moistened with sterile saline. Likewise, for leakage of cerebral spinal fluid from the ears or nose, apply loose sterile dressings, just to keep the area clean. Objects impaled in the skull should be stabilized in place, and protected from being jarred. Pharmacologic therapy. Pharmacologic therapy can be used to facilitate and/or maintain intubation or treat seizure activity. Otherwise, it is usually not indicated for patients with brain injuries in the pre-hospital setting. However, if transport will be prolonged, direct medical control may order the administration of certain medications, such as mannitol, osmetrol, or hypertonic saline to reduce cerebral edema and decrease intracranial pressure. Seizures in a patient with a brain injury must be terminated as soon as possible, to avoid provoking further increases in intracranial pressure or body temperature. Benzodiazepines, such as diazepam, Valium, or lorazepam, Ativan, should be used to control seizure activity in patients with brain injuries. Follow local protocol or contact direct medical control regarding the doses of these drugs. Transport considerations. Prompt transport to a definitive care facility, that is, a trauma center, is crucial to the survival of a patient with a brain injury. If available, consider air transport if your transport time will be prolonged. If transporting the patient by ground, do so expeditiously, yet cautiously. Many patients with severe brain injuries and increased intracranial pressure require neurosurgical intervention. The extra time it takes to move the patient from one hospital to another could mean the difference between life and death. Therefore, transport the patient directly to a trauma center that has neurosurgical capabilities, even if it means bypassing the nearest hospital. Every paramedic should know their local and regional hospital bypass and air ambulance activation policies for patients with brain injuries to ensure the patient is transported to the most appropriate facility as expeditiously as possible.
Chapter 29. Respiratory Emergencies. Introduction. There are few incentives to dial 911 more powerful than having difficulty breathing, dyspnea. In the majority of cases, that distressing feeling is caused by a problem in the respiratory system itself. This chapter will examine some of the respiratory problems that produce dyspnea, beginning with a review of the anatomy and physiology of the respiratory system. Next, you will consider the assessment of a patient whose chief complaint is dyspnea, namely, which aspects to emphasize in taking the history and carrying out the physical examination. Then the various problems that may affect the normal functioning of the respiratory system will be discussed, from the respiratory control centers in the brain to the alveolus, the smallest functional unit of respiration in the lung. Review of respiratory anatomy and function. The primary components of the respiratory system are often compared to an inverted tree, with the trachea representing the tree's trunk, and the alveoli resembling the tree's leaves. This image is simple to understand, but in reality, a respiratory tree would have to branch 23 times, and have nearly a billion leaves. The upper airway. Air enters the upper airway primarily through the nares, nostrils, of the nose. Nares are lined with nasal hairs. The hairs serve as filters that catch particulate matter in the air we breathe. The external nares are separated by the nasal septum. After passing through the nares, air is pulled over the turbinates. These ridges of tissue are covered with a mucous membrane, and contain many blood vessels. The mucous membrane traps more particulate matter, and the large surface area of the turbinates warms and humidifies the air we breathe as the air passes over it. Processes such as intubation or a tracheostomy, a surgical opening into the trachea, allow inhaled air to skip this trip through the nose, bypassing the humidification and filtering. Because the turbinates contain many blood vessels, they easily swell, causing a stuffy nose, or bleed. It is very important to understand the orientation of the turbinates when passing a nasotracheal tube or nasogastric tube. The passage of a nasal tube should follow an axis parallel to the base of the nose, and not be directed upward toward the fragile cribriform plate. Anyone with hay fever can attest to the severe swelling that can occur in the nasal cavity. In children, foreign bodies such as pencil erasers, candy, and beans frequently obstruct a nostril. These items often sit in the nose for a day or two before the child presents with pain and a foul-smelling nasal discharge. Do not try to remove the obstruction yourself, because this process can occasionally be painful. It is better to attempt nasal foreign body removal in the controlled setting of an emergency department. Quiet breathing typically allows air to flow through the nose. Even people who breathe through their mouth usually have some nasal airflow. The mouth and oropharynx also contain many blood vessels, and are covered by a mucous membrane. Swelling can be extreme and potentially dangerous. Bee stings to the lips or tongue can cause profound swelling. Angioedema is a type of allergic reaction that may cause severe swelling of the mouth, tongue, or lips. Always ask patients who may be experiencing an allergic reaction if their tongue feels thick. Monitor their speech for symptoms, such as low volume or raspy voice, of oral or laryngeal swelling, and examine the upper airway for early signs of edema, such as swelling of the uvula. The oropharynx and nasopharynx meet in the back of the throat at the hypopharynx, sometimes called the posterior pharynx. The gag reflex is most profound in this area. Triggering the gag reflex, on purpose or by accident, can cause vagal bradycardia, a slow heartbeat caused by stimulation of the vagus nerve, vomiting, and increased intracranial pressure. A strong gag reflex may make the use of many airway devices difficult or inappropriate. Conversely, patients with a diminished or absent gag reflex may require tracheal intubation or use of a supraglottic airway to help isolate and protect the airway. The larynx, voice box, and glottis, opening at the top of the trachea, are typically considered the dividing line between the upper airway and the lower airway. The thyroid cartilage is the most obvious external landmark of the larynx. The glottis and vocal cords are found in the middle of the thyroid's cartilaginous structure. Several cartilages that support the vocal cords may be visible when intubating the patient. The arytenoid cartilages appear as two pearly white lumps at the inferior end of each vocal cord. On either side of the glottis, tissue forms a pocket called the piriform fossa. Sometimes nasogastric tubes or tracheal tubes will get stuck here during placement, causing tenting that is visible externally on the neck. Any device stuck in a piriform fossa must be withdrawn a few centimeters and reinserted. The glottic opening is covered by the epiglottis. You may have been taught that the epiglottis covers the glottis like a trapdoor when you swallow, keeping food and liquid from entering the trachea. In reality, many people aspirate around their epiglottis, but others seem to swallow just fine even after their epiglottis has been surgically removed. Because the epiglottis can make it difficult to see the vocal cords, one of your primary tasks during tracheal intubation is to identify the epiglottis and use the laryngoscope to move it out of the way. The cricoid cartilage can be palpated just below the thyroid cartilage in the neck. It forms a complete ring, and maintains the trachea in open position. Pressing on the anterior portion of this ring compresses the esophagus against the anterior aspect of the body of the sixth cervical vertebra while keeping the trachea open. The palpable gap between the thyroid and cricoid cartilages is the location of the cricothyroid membrane. The membrane does not contain many blood vessels, and is covered only by skin and minimal subcutaneous tissue. It is the site for performing a cricothyrotomy, an incision through the skin and cricothyroid membrane to relieve difficulty breathing caused by an obstruction in the airway, if you are unable to secure the airway with an advanced airway device. The rest of the neck contains large blood vessels, nerves, and other critical anatomic structures that you must avoid cutting when performing a cricothyrotomy. Cricothyrotomies look easy when performed by skilled clinicians, but this procedure can be traumatic for the patient if you are not absolutely certain of anatomic landmarks, or have poor technique. Trauma or swelling of any of the laryngeal structures can create a life-threatening airway obstruction. In the worst-case scenario, this entire anatomic region may be bypassed by a tracheostomy. By their very nature, traumatic injuries may alter the typical anatomy of the upper airway. Procedures such as a cricothyrotomy can prove highly challenging when the airway is filled with blood or vomit, or when the anatomic landmarks are obscured by swelling or subcutaneous air. The lower airway. Inspired gas is distributed to the millions of alveoli by a network of conducting airways. Gas in these tubes does not come into close contact with capillaries, so it does not participate in ventilation. This wasted ventilation is called anatomic dead space. Typically, anatomic dead space is about 2 milliliters per kilogram of ideal body weight. A 75 kilogram person has about 150 milliliters of anatomic dead space. This dead space remains relatively constant. If a 75 milliliter patient took an average breath, tidal volume, of 700 milliliters, about 550 milliliters would participate in ventilation at the alveolar level. The other 150 milliliters would fill the tubes, and would never be exposed to blood flow. If the same patient were to drop his or her tidal volume to 500 milliliters, only 350 milliliters would participate in ventilation, because 150 milliliters is still filling the anatomic dead space. The trachea is about 10 to 13 centimeters long and extends from the level of the sixth cervical vertebra to its point of bifurcation, carina, at roughly the fifth thoracic vertebra, approximately nipple level. At this point, it forks into the right and left mainstem bronchi. In adults, the right mainstem bronchus typically branches at a less acute angle than the left. Thus, if you advance a tracheal tube too far into an adult, it almost always goes down the right mainstem bronchus. Similarly, aspirated foreign bodies often end up in the right mainstem bronchus. The mainstem bronchi branch into lobar bronchi, segmental bronchi, subsegmental bronchi, and bronchioles. These structures account for approximately 15 branchings of the airway, and are lined with ciliated epithelium. Cilia are little hair-like structures that rhythmically wave in a pattern that helps move particulate matter up and out of the airway. Goblet cells are also found in the lining of these airways. These cells produce a blanket of mucus that covers the entire lining of the conducting airways. The mucus covers the cilia and forms a two-layered blanket that is thick at the surface, gel layer, and thin and watery next to the cilia, sole layer. The gel layer of the mucus blanket is thick and floats over the sole layer. Cilia constantly push the gel layer up and out of the airway in the healthy individual. As the cilia beat, they reach out into the gel layer, pushing it up and toward the glottis. On the return stroke, the cilia collapse into the sole layer, so that they do not pull the gel layer back down. In this manner, the cilia slowly move the entire gel layer up and out of the tracheobronchial tree, where it is either swallowed or expectorated. Smooth muscle surrounds the conducting airways down to the subsegmental level. Bronchoconstriction occurs when the smooth muscle constricts around these larger airways. Below this level, bronchodilator medications have little effect on the airways. Wheezing that is resolved with bronchodilator medication was probably caused by constriction of the smooth muscles. Wheezing that is not resolved with these medications may be caused by a variety of pathologic conditions, including inflammation. The terminal airways and alveoli include branches 16 through 23 of the tracheobronchial tree, the so-called terminal bronchioles. The tracheobronchial tree ends with the alveoli, but the transfer of oxygen and carbon dioxide can nevertheless take place across both the alveoli and the terminal bronchioles. It is often helpful to think of alveoli as little balloons at the end of a straw. Alveoli cluster around the terminal bronchioles, and capillaries cover the alveoli and bronchial tubes from level 16 to level 23. The alveoli and terminal bronchioles actually make up the majority of the lung mass. Gas transfer is most efficient in the alveoli, but a significant amount of gas is also exchanged across the respiratory bronchioles. These terminal bronchioles are very thin and have little structure. This is helpful for gas exchange, but it also means that these bronchioles lack cilia, a mucus blanket, smooth muscle, or rigid structures. Once foreign material gets into the terminal bronchioles and alveoli, parts of the lung collectively known as the lung parenchyma, it may cause significant damage. Emphysema may affect this area of the lung, destroying the few structural components that are present. When that happens, the terminal branches of the tracheobronchial tree become so weak that they collapse during exhalation and trap air in the alveoli. The alveoli are lined with a substance known as surfactant, which reduces surface tension and helps keep the alveoli expanded. If the amount of surfactant is decreased or the alveoli are not inflated, the alveoli collapse, which results in a condition known as atelectasis. If smoking or disease destroys certain types of cells in an alveolus, it cannot repair itself. Conversely, alveoli can repair significant damage if certain cells survive an illness. The pulmonary circulation begins at the right ventricle where the pulmonary artery, the only artery that usually carries deoxygenated blood, branches into increasingly smaller vessels until the pulmonary capillary bed surrounds the alveoli and terminal bronchioles. There is significantly more circulation to the lung bases than there is to the lung apices. Like all the capillaries in the body, the pulmonary capillaries are very narrow, and typically allow only red blood cells to pass through in single file fashion. People whose lung tissue has been destroyed by smoking, emphysema, have fewer and smaller capillaries, which increases the resistance to blood flow across the lungs and strains the right side of the heart. In addition, people with chronic lung disease and chronic hypoxia often make a surplus of red blood cells over time, polycythemia, which makes their blood thick. Pushing this thicker than normal blood through the tiny pulmonary capillaries can also put a significant strain on the right side of the heart. Right heart failure secondary to chronic lung disease is known as cor pulmonale. Airway problems versus breathing problems. From your first cardiopulmonary resuscitation class, the differences between maintaining the airway and breathing for the patient are highlighted. Unfortunately, it is easy to become confused between pathologic conditions that affect one versus the other. Many patients present with an airway that can use a little assistance. No one should be snoring, gurgling, squeaking, or using accessory muscles to inhale. You must remain vigilant that secretions, soft tissue, blood, or vomit do not compromise an airway that you initially thought was open. At the same time, an open airway does not ensure that an adequate volume of gas is moving in and out of the lungs. Proper ventilation is necessary to provide adequate oxygen to the bloodstream, and to remove carbon dioxide. Increasing the amount of available oxygen ensures that even a patient who is not moving adequate volumes of gas, for example, hypoventilating, can still maintain adequate oxygen saturation. Unfortunately, if ventilation remains inadequate, carbon dioxide levels will increase. Hypoventilating patients become hypercapnic, have too much carbon dioxide in their blood, and acidemic. The pH of their arterial blood falls too low. Both conditions can interrupt important body systems and, if uncorrected over a period of time, can result in death. Ventilation revisited. Many airway problems can be bypassed by inserting an advanced airway device, such as a supraglottic airway or a tracheal tube. By contrast, alterations in breathing can be much more complex. They can involve problems with the conducting airways, branches, such as asthma or bronchitis, difficulties at the alveolar level, such as pneumonia or emphysema, problems with the muscles and nerves that make breathing work, as in Guillain-Barré syndrome or spinal cord injury, or problems with the rigid structure of the thorax that allows the pressure changes that make breathing work, such as flail chest. Most people are usually negative pressure breathers, air suckers. The expansion of the chest and downward movement of the diaphragm create negative pressure in the thorax. Air is pulled in through the mouth and the nose, over the turbinates, and around the complex terrain of the epiglottis and glottis. Air typically does not enter the esophagus and stomach because it is preferentially sucked into the trachea. This negative pressure vacuum effect occurs because the thorax is essentially an airtight box with a flexible diaphragm, the major muscle of breathing, at the bottom, and an open tube, the trachea, at the top. During quiet breathing, when the diaphragm flattens, the overall size of the container increases, and air is sucked in through the tube at the top to fill the increasing space inside the thorax. You can increase the amount of air you move each minute, minute ventilation, by taking bigger breaths, hyperpnea, or by breathing more rapidly, tachypnea. To breathe even more deeply, you can use additional muscles to pull the ribs up and out, further increasing both the size of the thoracic cavity as well as increasing the negative pressure environment, and moving larger volumes of air. Clearly, disruptions of the thoracic cage will hinder your ability to move air by this mechanism. Holes in the thorax provide another place for air to be sucked in, resulting in a sucking chest wound. When multiple ribs are broken in more than one place, causing a flail chest, free-floating sections of the thorax get pulled in when you breathe, limiting the amount of air that can be sucked in through the trachea. Infants and small children may exhibit retraction, or indrawing, of the intercostals and ribs when airflow is restricted by disease processes. The normal expansion of the chest without the ability of air to move easily results in greater negative pressure in the thorax. This draws the intercostals inward with each chest expansion. When you ventilate someone with positive pressure, that is, with a pocket mask or bag mask ventilation, Air is forced into the upper airway, and flows into both the trachea and esophagus unless steps are taken to help direct it into the trachea. Indeed, positive pressure ventilation with bag mask ventilation or a pocket mask is physiologically the opposite of normal, negative pressure ventilation. Exhalation is usually a passive process. After the size of the thorax has increased during inhalation, the components of the respiratory system return to their original places, and air is pushed out of the trachea under positive pressure. When a patient has trouble exhaling, for example, in asthma, reactive airway disease, or chronic obstructive pulmonary disease, they may need to use the abdominal muscles to push air out. When this occurs, exhalation is no longer a passive process. Watch your patient work as they breathe. Is the patient having trouble pulling air in or pushing air out? Difficulty in exhalation usually indicates obstructive disease. Difficulty in inhalation may indicate upper airway obstruction. The neurologic control of respiration is complex. At least 4 parts of the brain are responsible for the smooth, rhythmic respirations that we take for granted. One area helps control rate, another depth, another inspiratory pause, and yet another rhythmicity. Patients with traumatic brain injuries may exhibit bizarre respiratory patterns when one or more of these respiratory centers are damaged or deprived of adequate blood flow. Table 29-1 summarizes the various breathing patterns. Most of these respiratory centers are in and around the brainstem. Patients who sustain serious trauma to the upper cerebral hemispheres, such as from a gunshot wound, are often still breathing despite mortal wounds. Apneustic breathing results from damage to the apneustic center in the brain, which regulates inspiratory pause. A patient exhibiting apneustic respirations will have a short, brisk inhalation with a long pause before exhalation. This pattern is indicative of severe pressure within the cranium or direct trauma to the brain. Similarly, BO respirations are seen when the center that controls breathing rhythm is damaged. This respiratory pattern is grossly irregular, sometimes with lengthy apneic periods. Cheyne-Stokes respirations are more of a high brain function. Many deep sleepers or intoxicated people will exhibit this type of respiratory pattern. The depth of breathing, or volume of snoring, gradually increases, then decreases, crescendo, followed by an apneic period. The apneic period is usually brief in the relatively healthy patient. Exaggerated Cheyne-Stokes respirations may be seen in patients who have a severe brain injury, where the crescendo-decrescendo is much more prominent. The apneic period may last 30 to 60 seconds. Stretch receptors in the lungs are responsible for the Herring-Brewer reflex, which limits inspiration, and may cause coughing if you take too deep a breath. You'll become accustomed to ventilating unresponsive patients. When called on to assist a responsive patient's respirations, as may happen when a patient is breathing shallowly, many paramedics give breaths that are too large, causing repeated coughing and discomfort to the patient. Assisting the spontaneously breathing patient with bag mask ventilation can be a complex skill, requiring practice. Respiration revisited. Respiration is the process by which oxygen is taken into the body, distributed to the cells, and used by the cells to make energy. Respiration takes place in each cell. It involves using oxygen and glucose to make energy that allows the cell to do its work. The oxygen must be supplied by the lungs and circulatory systems. The primary byproduct of this process is carbon dioxide. The respiratory system is involved in the delivery of the oxygen to the bloodstream, and the removal of the waste carbon dioxide from the body. If the lungs are not functioning appropriately, both of these vital functions may be impaired. Failure to deliver oxygen efficiently results in cellular hypoxia. Hypoxia kills cells by making it impossible for them to make enough energy to do their work. It also causes acidosis. You can often help the patient with hypoxia by providing additional oxygen. Under normal circumstances, the carbon dioxide created during cellular respiration is returned to the lungs by the circulatory system, where it is exhaled during ventilation. When the lungs are not working adequately, carbon dioxide is not efficiently disposed of and accumulates in the blood. This carbon dioxide combines with water to form bicarbonate ions and hydrogen ions, also known as acid. pH is an expression of how many free hydrogen ions are in a solution. The result is acidosis. By contrast, in hyperventilation, the person breathes faster or deeper than normal and blows off more carbon dioxide than usual, resulting in alkalosis. A. Systems approach to respiratory emergencies. Evaluation of the respiratory organs is clearly an important component of assessing respiratory emergencies. However, the job performed by the respiratory system so dramatically affects other body systems that a thorough respiratory assessment includes much more than listening to the patient's lungs. Neurologic status. The brain is very sensitive to reduced levels of oxygen. For this reason, any alteration in level of consciousness could represent a degree of respiratory compromise. Anxiety can be an early sign of hypoxia, while confusion, lethargy, and coma are typically later signs. A brief seizure often accompanies a hypoxic event or cardiac arrest. Dizziness and tingling extremities could signify hyperventilation. Major neurologic insults may also manifest themselves with some altered respiratory pattern. Brain trauma, or anything else that disturbs the function of the brain, may depress the respiratory control centers in the medulla. For example, the increasing intracranial pressure in closed-head trauma may literally put the squeeze on the medulla to produce a variety of respiratory abnormalities, including apnea. A stroke may have a similar effect by depriving portions of the brain of circulation. Overdose with drugs that depress the central nervous system, such as narcotics or barbiturates, may also severely depress the activity of the respiratory center. Injury high in the spinal cord may paralyze the intercostal muscles, and even the diaphragm. Polio attacks the nerves that supply the respiratory muscles, but certain chronic illnesses, such as myasthenia gravis, weaken the respiratory muscles themselves. The net effect of these conditions is the inability of the respiratory muscles to function normally in response to the respiratory drive. As a consequence, the tidal volume is shallow, and the minute volume is correspondingly decreased. Patients with such conditions often need assisted ventilation to increase the tidal volume and, thus, minute volume. Cardiovascular status. Think of the lungs as lying between the right and left sides of the heart, regarding function. Although an anatomic drawing may not depict the lungs in this way, the description is a very accurate concept when reviewing blood flow through the body. The right side of the heart pumps blood to the lungs, while the left side of the heart receives blood from the lungs, and then pumps it around the body. Any major change in the function of the lungs, right side of the heart, or left side of the heart almost always affects the other components. The body's immediate response to mild hypoxemia is to increase the heart rate, tachycardia, to deliver a higher volume of blood to tissues to compensate for lower blood oxygen levels. Severe hypoxia often causes bradycardia. Any uncorrected hypoxic insult may result in lethal cardiac dysrhythmias, such as ventricular fibrillation or ventricular tachycardia. Changes in fluid balance, right heart pumping pressures, or left heart pumping pressures can cause various forms of heart failure. A thorough evaluation of the cardiovascular system is requisite in the evaluation of the respiratory patient. Muscles and mechanics. Muscles have to work to allow you to breathe under normal circumstances, and they have to work a lot harder when oxygen needs are higher or when there is a problem with the normal mechanics of breathing. This extra work comes at a cost. People who have asthma, for instance, can often compensate for their respiratory distress by devoting lots of energy to their breathing. They can maintain their oxygen and carbon dioxide levels in an acceptable range as long as they continue to apply their muscles to this effort. The tremendous workload causes them to use tremendous amounts of energy, which requires even more oxygen and ventilation. Such patients are typically not in a position to eat and drink normally, so they continue to get more dehydrated, more malnourished, and more tired. At some point they will tire out and be unable to continue doing the necessary work of breathing. They will then look sleepy, the rate and depth of their respirations will slowly drop, and they will decompensate, respiratory failure. Other things may interfere with the mechanics of breathing. Placing a patient in the Trendelenburg position, or even laying the patient flat, especially if the patient is overweight, causes the abdominal organs to push up against the diaphragm. With each breath, the patient must move the abdominal contents out of the way to expand the thorax, and breathe. This explains why most people seek a sitting position when they are short of breath, orthopnea. If the abdomen is distended with air or blood, the situation is compounded. Things that bind the chest or abdomen, such as tight clothing or undergarments, a pneumatic anti-shock garment, or backboard straps, can also make it very difficult to breathe. Diseases that cause muscle weakness, such as botulism, amyotrophic lateral sclerosis, or Guillain-Barré syndrome, can be fatal when they render the patient unable to breathe. Renal status. Fluid balance, acid-base balance, and blood pressure are controlled, in part, by the kidneys. Each of these factors also affects the pulmonary mechanics, and hence the delivery of oxygen to the tissues. Patients with severe renal disease often present with respiratory signs and symptoms, so you should always note signs of severe renal disease when evaluating the conditions of such patients. The conditions of patients who have heart failure secondary to renal disease can be difficult to manage because diuresis may be difficult or impossible for them. Patients who have renal disease may also have acid-base disturbances that cause them to hyperventilate, which is why renal disease is sometimes mistaken for a respiratory disorder. Often, a patient's need for emergency dialysis may influence your transport decisions and options. Assessment of the patient with dyspnea. As always, remember that recognizing and treating life threats is the priority in the initial assessment and throughout pre-hospital care. Initial assessment. Your first glance at a patient may identify a body type associated with the particular pathologic condition. The classic presentation of a patient with emphysema includes a barrel chest, a chest that is rounded and bulging, like the shape of a barrel, from years of having air trapped in the thorax, muscle wasting. The patient has cannibalized his or her own body mass for energy, and pursed lip breathing, a technique often used to improve breathing in patients with obstructive lung disease. Such patients are often tachypneic and do not typically present with profound hypoxia and cyanosis, hence the term pink puffer. Patients who have chronic bronchitis tend to be more sedentary and thus may be obese. These patients are often encountered in a chair or recliner, where they sleep in an upright position. They may be surrounded by a wastebasket overflowing with tissues, a cup into which they spit their copious secretions, a urinal to avoid frequent trips to the bathroom, and an overflowing ashtray. The table next to their chair may have several medications, inhalers, or an aerosol nebulizer. Such a scene can disclose volumes of information about the patient and his or her history long before you ever place a stethoscope on the chest. Severely ill patients with end-stage diseases, cancer, or immune system disorders are often easy to spot, as are the sickly appearance, rigors, and chills of a patient with pneumonia. A spontaneous pneumothorax tends to occur in tall, thin young adults, and women who smoke and take birth control pills are predisposed to pulmonary embolus. Clues to a variety of pathologic conditions may be evident from your very first impression of a patient, but keep in mind that they are only clues. Avoid making a hasty initial diagnosis based on minimal information. The patient's presentation may make you suspicious about a particular condition, but make sure you confirm your suspicions with a thorough assessment. Position and degree of distress. Patients in respiratory distress tend to seek the sitting position. The tripod position involves leaning forward and rotating the scapulae outward by placing the arms on a table or by placing the hands on the knees. This stabilizes the shoulder girdle, improves efficiency of the accessory breathing muscles, and decreases the total work of breathing. Beware of the patient in respiratory distress who is willing to lie flat. This could be a sign of sudden deterioration. Purposeful hyperextension occurs when a patient maximizes airflow through the upper airway. Such patients essentially hold their heads in the head tilt, chin lift or sniffing position. This position may indicate upper airway swelling, but it is also commonly seen in patients who are trying to maximize airflow. Maintaining this position uses up valuable energy. As a patient who is severely ill with respiratory disease begins to feel fatigue, he or she may hold the head up in this position only during inhalation, letting it fall into flexion during exhalation. This head bobbing is a very ominous sign, signaling the potential for imminent decompensation. Head bobbing is frequently pre-terminal behavior. Work of breathing. Patients who are using several muscles to breathe are in danger of tiring out, so it is important to note the use of accessory muscles. Is the patient using the muscles of the abdomen to push air out, as in asthma or chronic obstructive pulmonary disease, or is the patient using muscles in the chest and neck to pull her in? Patients who are using extra muscles to breathe may cause dramatic pressure changes within the thorax and exhibit the following signs and symptoms. Chest wall retractions. These are most common in infants and small children, where the rigid structure of the thorax is still flexible. On inhalation, the child may pull, or retract, the sternum or ribs into the chest, causing a visible deformity with each breath. Soft tissue retractions. In most patients, the bones are rigid and do not move, but the soft tissue is pulled in around the bones. Dramatic retractions can be seen during inhalation in the supraclavicular, intercostal, and subxiphoid areas. Nasal flaring. The nostrils are pulled wide open on inhalation. Tracheal tugging. The thyroid cartilage is pulled upward and the area just above the sternal notch is sucked inward with inhalation. Paradoxical respiratory movement. The epigastrium is pulled in with inhalation while the abdomen pushes out, creating a seesaw appearance as the two move in opposing directions. Pulsus paradoxus. Profound intrathoracic pressure changes cause the peripheral pulses to weaken, or disappear. On inspiration, these pulses are easier to palpate during exhalation. This is rare. Assessing breathing for rate and depth is an obvious component of a respiratory assessment, but one that is often not accurately determined. Respiratory rate may be a commonly estimated vital sign, but respiratory depth is even more commonly misjudged. A patient with an adequate rate but a low volume will still have an extremely low minute volume. Respiratory rate times tidal volume equals minute volume. While assessing the respirations, note their pattern, see Table 26-1, and the inspiratory to expiratory ratio. Is the patient working hard to inhale, to exhale, or both? Does the breath have a peculiar odor, such as the acetone breath odor associated with diabetic ketoacidosis? Are there any audible abnormal respiratory noises? In general, any respiratory noises that you can hear without a stethoscope are abnormal noises. Quiet breathing should also be of interest. The patient with tachypnea who has crystal clear breath sounds may have hyperventilation syndrome but may also be breathing fast because of acidosis. Quiet tachypnea should prompt you to consider shock. Paramedics occasionally mistake tachypnea caused by pain, anxiety, or metabolic disorders as the patient's primary problem, and administer aerosol treatments for diabetic crisis or sepsis. Aerosol bronchodilators do not help those conditions. Neurologic assessment. Assessing the level of consciousness is enormously important in patients with dyspnea. Although you cannot measure the patient's arterial blood gases in the pre-hospital environment, the patient's brain is constantly doing precisely that. Any decline in oxygen dissolved in plasma, or POW, 2, represents hypoxemia, and will manifest initially as restlessness, confusion, and in worst-case scenarios, as combative behavior. An increase in partial pressure of carbon dioxide, PaCO2, by contrast, usually has sedative effects, making the patient sleepy and hard to rouse. Skin color. Assessing skin color is a fast way to begin forming an early impression of the patient's condition. Although it is important to note the generalized cyanosis of oxygen desaturation or the profound pallor of shock, more subtle information can be gained by assessing the patient's mucous membranes. The tissue inside the mouth, under the eyelids, and even under the nail beds is usually the same pink color in all healthy patients. A few notable variations are described below. Cyanosis. Healthy adults have a hemoglobin level of 120 to 140 grams per liter. Healthy persons will begin to exhibit the blue discoloration of cyanosis when about 50 grams per liter is desaturated, does not have oxygen attached. That means their oxygen saturation would be roughly 65%. If a person's hemoglobin level was only 100 grams per liter, 50% of it, 50 of the 100 grams per liter, would have to be desaturated before the patient would look cyanotic. Some patients in cardiac arrest are a deep blue, while others are simply pale. Similarly, patients with high hemoglobin levels, those who have chronic respiratory disease, may develop cyanosis earlier than patients who have normal hemoglobin levels. Of course, there are slight variations in what is considered normal. Also, Some patients who have chronic respiratory conditions who have an artificially low oxygen saturation may also have a low level of chronic cyanosis, which explains the use of the term blue bloater to describe patients who have chronic bronchitis. Chocolate brown skin. High levels of methemoglobin derived from nitrates, and some toxic exposures may turn the mucous membranes brown. This transformation is typically more evident in the patient's venous blood than in the skin and mucous membranes. Pale skin. Pale skin and mucous membranes are caused by a reduction of blood flow to the small vessels near the surface of the skin. The source of this condition could be hypoxia, shock, catecholamine release, such as from epinephrine or norepinephrine, or a cold environment. While you are noting the color of the mucous membranes, also note their moistness. Dehydration can be seen in the mucous membranes of the mouth and eyes. Dry, cracked lips, a dry, furrowed tongue, and dry, sunken eyes point to obvious dehydration. The skin of an older patient may always look dry with poor turgor, so skin assessment may be of less value in some older people. The focused history. Elaboration on the chief complaint. One challenge in assessing respiratory patients is that they may not be able to talk to you because of having difficulty breathing. While it is usually best to ask open-ended questions and allow patients to tell their own stories, dyspneic patients may only be able to speak in short sentences, or may be reduced to nodding in response to a series of yes or no questions. In some cases, the bulk of your history taking may have to be hastily obtained from a family member, or gleaned from the few clues, such as medications, immediately available. You often have to institute basic therapy, such as oxygen or nebulizer therapy, before getting the complete story from patients. Sometimes, you must immediately intubate patients, which will eliminate your ability to get a history from them from that point on. When it is possible to discuss the history of the present illness with patients, several lines of questioning can provide important data. Utilizing the OPQRST mnemonic can help you elaborate on the chief complaint. Reason for calling for help. Have patients explain in their own words what they are feeling. Many patients will identify their problem and tell you the best way to treat it without you having to dig for the information. Patients who have chronic respiratory conditions are often knowledgeable about their disease or disorder, and may have tried several potential treatment options already. If they have been intubated and placed on a ventilator in past episodes, that is important information for you to have. Onset and duration. The speed with which the patient's distress has worsened is an important consideration in determining the underlying cause. Rapid onset dyspnea may be caused by acute bronchospasm, anaphylaxis, pulmonary embolism, or pneumothorax. Left heart failure typically progresses much faster than right heart failure. Right heart failure may slowly worsen over many days, whereas left heart failure resulting from a massive acute myocardial infarction can kill a patient in a matter of minutes. Infectious diseases sometimes present very rapidly, but at other times may occur at the end of a lengthy battle with a low-grade infection. Did this problem arise suddenly, or did it get worse over time? How long has it been this bad? Paroxysmal nocturnal dyspnea, dyspnea that comes on suddenly in the middle of the night, is an ominous sign. It may signal left heart failure, worsening of chronic obstructive pulmonary disease, or both. It occurs because of accumulation of fluid in the alveoli or pooling of secretions in the bronchi during sleep. The position of comfort and difficulty speaking may also help you gauge the degree of distress. A patient who is comfortable while lying flat and speaking in full sentences can be deemed to be in little distress. A patient who is sitting in a Fowler position, 90 degrees, speaking only in 2 or 3 word statements is probably in considerable distress, possibly even life-threatening distress. History of the problem. Asthma attack, heart failure, pneumonia in immunocompromised patients, and even spontaneous pneumothorax are often repeating pathologic conditions. If the patient has some experience with these types of events, they can serve as a baseline to assess the current condition. Ask these questions. Do you feel better or worse than last time? How often does this happen to you? What did the doctor tell you it was? What helped you or what happened last time? Attempts at treatment. When respiratory disorders are chronic or recurring, patients may already have strategies to manage their crises. Determine what the patient may have already tried, and whether it had any effect, positive or negative. By following this simple line of questioning, you can determine which medications the patient is supposed to be taking, which often gives valuable clues to other problems, and whether the patient is taking those medications correctly. Patients also often know exactly what caused their problems. Associated symptoms. Respiratory difficulty must always be evaluated in light of the patient's cardiovascular and renal status. Many acute myocardial infarctions present as heart failure, as do renal crises. Tachypnea can signal anxiety, diabetes, or shock. In addition, most chronically ill patients have a respiratory component to their disease. Many pathologic conditions can masquerade as respiratory distress, especially in patients who have underlying respiratory disease. Do not be too quick to conclude that your patient's only problem is a relatively straightforward respiratory issue. Always dig deeper to determine what else may be triggering or worsening the patient's respiratory distress. The focused physical examination. By the time you have elicited the history of a patient who has respiratory complaints, you should already have some important information about the patient's physical signs. In particular, you should have observed the patient's level of consciousness, position, degree of distress, and so forth. This section presents the components of the physical examination in sequence, noting at each step the points of particular relevance to the dyspneic patient. Neck examination. In the neck, look for jugular venous distension when a patient is in a semi-sitting position. Jugular venous distension is a condition in which the jugular veins are engorged with blood. Cardiac tamponade, pneumothorax, heart failure, and chronic obstructive pulmonary disease can all cause jugular venous distension. It is common all of the time in patients who have an obstructive lung disease such as asthma or chronic obstructive pulmonary disease. Healthy young adults often demonstrate jugular venous distension when they are supine, and it is common to see gross jugular venous distension when people are laughing or singing. When jugular venous distension is present in patients who are sitting upright, it can provide a rough measure of the pressure in the right atrium of the heart. Distended neck veins may indicate cardiac failure as the source of the patient's dyspnea. Jugular venous distension may also indicate high pressure in the thorax, which keeps the blood from draining out of the head and neck. Hepato-jugular reflux occurs when mild pressure on the patient's liver causes the jugular veins to engorge further. This is a specific sign of right heart failure. Jugular venous distension must be interpreted given the patient's position and other vital signs. The trauma patient who demonstrates grossly distended jugular veins despite a blood pressure of 80/40 mm of mercury should cause considerable concern, and could be a sign of tamponade or tension pneumothorax. A healthy 20-year-old who has jugular venous distension when lying flat, but not while sitting, is of little concern. While looking at the neck, note the trachea. Tracheal deviation is a classic, albeit late and uncommon, sign of a tension pneumothorax. Tension pneumothorax is very difficult to see except in extreme cases. On a radiograph, the trachea can be seen deviating because of a tension pneumothorax. The deviation occurs behind the sternum, so it may not be seen or even felt. Consider palpating the trachea at the suprasternal notch. When the trachea does deviate, it often does so at a point behind the sternum, so it may not be palpable or visible. Chest and abdominal examination. Hepato-jugular reflux is specific to right heart failure. When the right ventricle is not pumping effectively, blood backs up, making it difficult for the jugular veins and the large reservoir of blood in the liver to drain into the thorax. As a result, the combination of jugular venous distension and hepatomegaly, distended liver, may present in right heart failure. If you gently press on the liver, the blood you squeeze out will back up behind the failing ventricle, and the jugular veins will engorge further. When a patient in respiratory distress is sitting up in a semi-Fowler, 45 degrees, position, it is easy to check for hepatojugular reflux. Feel the chest for vibrations as the patient breathes. Tactile fremitus, secretions in the large airways are usually easy to feel and to hear. Some experts recommend percussing the chest. With experience, you can tell the difference between a normal chest and a bad pneumothorax but this remains a difficult procedure to perform in the pre-hospital setting because of ambient noise around you and the patient. Examination of the extremities. Does the patient have edema of the ankles or lower back? If so, does it pit and leave a depression when you push your finger into the edema? Is there peripheral cyanosis? Check the pulse. Is the patient profoundly tachycardic from exertion or hypoxia? Is there pulsus paradoxus? Also note the patient's skin temperature. Does the patient have an obvious fever, or is he or she cool and clammy from shock? Is there distal clubbing from chronic hypoxia? Data collection. As appropriate to your patient's care plan, attach any monitors that are immediately available to you. Repeated vital signs, electrocardiogram, and tidal carbon dioxide, and pulse oximetry readings are the data most commonly collected. In some situations, depending on available equipment, you might also record peak expiratory flow, or even transcutaneous carbon monoxide levels. Monitoring devices are discussed later in the chapter. The stethoscope. As far as stethoscopes go, the following guideline applies: the longer the tubing, the more extraneous the noise you will probably hear. Avoid overly long stethoscopes. Higher quality stethoscopes have a tubing within the tubing design that limits external noise interference. Practically speaking, your stethoscope is the single most important investment you will make as a paramedic. Buy the best you can afford and take good care of it. Periodically check to make sure the earpieces are clean and clear of earwax. On a regular basis, wipe down the length of the main tubing with an all-purpose cleaner. This helps slow the breakdown of the tube from the oils it picks up when you place it around your neck. Ensure you disinfect your stethoscope after every patient contact. The diaphragm of the stethoscope is for high-pitched sounds, breath sounds. The bell, if present, is for low-pitched sounds, some heart tones. If you press the bell firmly against the skin, it stretches the skin beneath it and makes it act like a diaphragm. Hence, the bell should be placed lightly against the skin if you hope to hear the lower-pitched sounds. Some newer stethoscopes take advantage of this principle, allowing a single head to help transmit high and low-pitched sounds based on the pressure exerted by the operator. In older-style stethoscopes, the bell rotates, allowing you to better hear the sounds you are trying to assess. Your ear canals tend to point anteriorly in your skull, toward your eyes. You may wish to tilt the earpieces on your scope more forward for a better fit. But be careful. You may hear little or nothing if you accidentally place your scope in your ears backward, causing the earpieces to hit the sides of your ear canal. Auscultation. Whenever possible, auscultate the lungs systematically. Although we tend to compare the left and right sides, the lungs are not symmetrical. The right lung has 3 lobes: right upper lobe, right middle lobe, and right lower lobe. The left lung has only 2 lobes, left upper lobe, and left lower lobe. Understand where you must listen to hear the various lobes. Some of the pathologic conditions you will listen for, such as most pneumonias and heart failure, are gravity dependent, meaning they will tend to be found in the lung bases. In the case of wheezing, it may be diffuse and spread throughout the lung fields. The bases are almost exclusively heard by listening to the patient's back. The upper lobes, which rarely have abnormalities, are heard by listening to the anterior part of the chest. The right middle lobe can best be heard by listening just beneath, or lateral to, the right breast. The best left-right differentiation can be appreciated in the mid-axillary line. This is the best place to listen for tracheal tube placement. If you listen to the anterior part of the chest, you are very close to the noisemaker, the tracheal tube, whether it is in the trachea or the esophagus. Specific breath sounds. The breath sounds you hear are made by turbulent flow in the large airways as they are transmitted through the chest to your stethoscope. Tracheal breath sounds are not commonly auscultated, but note how harsh and tubular they sound. Bronchial breath sounds are also quite loud, but note that exhalation predominates. Moving farther toward the periphery, bronchivesicular sounds are softer and have equal inspiratory and expiratory sides. Finally, the most commonly heard breath sounds are the soft, breezy vesicular sounds heard in the periphery. They have a much more obvious inspiratory component. You'll want to listen to a large number of healthy lungs to become familiar with the 4 different sounds. Pathologic conditions may cause you to hear some normal breath sounds in abnormal places. Sound moves better through fluid than it does through air. Thus, the more air that is present in a patient's chest, as in chronic obstructive pulmonary disease or asthma, the more distant, diminished, or absent the breath sounds will be in the periphery. Conversely, the wetter the patient's lungs are, as in pneumonia, consolidation, when fluid causes the lungs to become firm, or heart failure, the louder the sounds will be in the periphery. If a patient has pneumonia in the right middle lobe, you may hear bronchovesicular, equal inspiration and expiration, or even bronchial, greater expiration than inspiration, sounds in the periphery, instead of the expected vesicular sounds, greater inspiration than expiration. The quality of the breath sounds also depends on the amount of extra tissue you must listen through and the patient's respiratory effort. For this reason, it is often helpful to compare breath sounds on the right versus the left. The breath sounds of a patient who has a one-sided pathologic condition, such as pneumonia, will sound louder over the side with the abnormality than they will over the healthy side. Both breath sounds and vocalizations travel more efficiently through a firm, fluid-filled lung than through a healthy lung, but travel poorly through a hyperinflated lung. If a patient speaks while you are auscultating the chest, you cannot usually understand what he or she is saying through your stethoscope. If you can, it may mean consolidation from pneumonia or atelectasis. You'll likely hear these sounds directly only over the consolidated lobe. Table 29-2 lists tests that indicate consolidation. Adventitious, abnormal, breath sounds are the extra noises that you may hear on top of the breath sounds described previously. Continuous sounds, for example, a wheeze, can be heard across some portion of each breath. Discontinuous sounds are the instantaneous pops, snaps, and clicks that we often identify as crackles. Wheezes are high-pitched, whistling sounds made by air being forced through narrowed airways, which makes them vibrate, much like the reed in a musical instrument. Wheezing may be diffuse, as in asthma and heart failure, or localized, as when a foreign body obstructs a bronchus. Pathologic conditions such as asthma rarely cause one-sided wheezing. Have the patient cough and listen again. If you hear a sound on only one side, it could be caused by the movement of secretions. A wheeze may begin at the start of exhalation, and continue until the end of exhalation. Crackles are any discontinuous noises, such as pops, snaps, and clicks, heard on auscultation of the lungs, and are caused by the popping open of air spaces. They are usually associated with increased fluid in the lungs. These sounds are often referred to as rales or rhonchi. A rhonchus is classically defined as a low-pitched continuous sound, such as a low wheeze or death rattle, but the term is sometimes used to mean a low-pitched crackle, thick secretions in the large airways. The most ominous breath sounds are no breath sounds at all. They mean the patient is not moving enough air to ventilate the lungs. Silence means danger. Sputum. It is probably not productive to discuss specific pathologic conditions suggested by various sputum colors, but it is appropriate to note whether the patient is coughing up colorful sputum. Many smokers or patients who have chronic respiratory diseases cough up sputum every day, especially first thing in the morning, so determine if the color or amount of the sputum has changed. Many patients do not spit their sputum out, whereas others will keep a cup or emesis basin next to their chair to spit in. Blood-tinged sputum may be a warning sign of tuberculosis or pulmonary edema, or it may mean the patient has been coughing forcefully and broken small blood vessels in the airway. Also note if mucus is purulent, pus-like. Ask the patient these questions: have you been coughing up anything colorful? Is that different for you? Monitoring devices. Pulse oximetry. Under normal circumstances, a pulse oximeter is a non-invasive device that tells you what percentage of the patient's hemoglobin has oxygen attached to it. For example, an oxygen saturation of 97% indicates that 97% of the patient's hemoglobin has oxygen attached to it. An oxygen saturation greater than 95% is considered normal. Most healthy people would feel short of breath at a saturation rate of less than 90%. A pulse oximeter must see a pulsatile capillary bed to read properly. If the patient is wearing nail polish, you may need to remove it with an acetone nail polish remover before obtaining a reading, although some research indicates that if you are getting a consistent reading through nail polish, the reading is probably accurate. Poor peripheral perfusion, cold extremities, or patient movement, tremors or shivering, can make the reading inaccurate. Most pulse oximeters also display the patient's heart rate. This reading should match the patient's palpated heart rate. Pulse oximetry does not recognize the difference between an oxygen molecule attached to hemoglobin and a carbon monoxide molecule attached to hemoglobin. From living in an industrialized society, most of us have a 1% to 2% carbon monoxide level all of the time. Smokers may have a 3% to 4% level. Thus, a 97% pulse oximetry reading may actually consist of 95% oxygen and 2% carbon monoxide. Patients who have toxic or even fatal levels of carbon monoxide may show normal or high pulse oximetry values. Pulse carbon monoxide oximeters, which specifically measure carbon monoxide levels, are poised to become important tools, enabling paramedics to readily assess for carbon monoxide poisoning in the pre-hospital setting. The oxyhemoglobin dissociation curve describes the relationship between oxygen saturation and the amount of oxygen dissolved in the plasma, PaO2. It demonstrates that when present at very low levels, oxygen molecules bind easily to the hemoglobin, so that small changes in PaO2 result in relatively large changes in oxygen saturation. As the hemoglobin begins to fill up with oxygen molecules, larger changes in PaO2, shown on the horizontal axis, are required to produce changes in oxygen saturation. Placing a healthy patient on a non-rebreathing mask may increase the saturation level from 96% to 99%, whereas placing a hypoxic patient on a nasal cannula at 2 liters per minute may increase the oxygen saturation from 80% to 92%, a much bigger change. Conversely, the more hypoxic patients become, the faster they will desaturate as they fall off the steep part of the oxyhemoglobin dissociation curve. Other factors, such as acid-base balance, body temperature, and amount of hemoglobin, can also affect the entire system and shift the entire curve to the left or the right. End-tidal carbon dioxide detector. Carbon dioxide is returned to the lungs in the venous blood, where it is exhaled during ventilation. You can measure this exhaled carbon dioxide by various methods. Calorimetric end-tidal carbon dioxide detecting does not measure the exact amount of carbon dioxide exhaled, but it does indicate whether carbon dioxide is present in reasonable amounts in the exhaled breath of the patient. This type of monitoring helps in identifying placement of a tracheal tube. Air exhaled through a tracheal tube that has been properly placed in the trachea of a normally perfused patient should contain 4% to 5% carbon dioxide, a yellow reading on the calorimetric device. If the tube has been mistakenly placed in the esophagus, less than 0.5% carbon dioxide will be present in the exhaled gas, a purple reading. Note that the monitor might be fooled if the patient has carbon dioxide trapped in the stomach from the ingestion of carbonated beverages, so confirm the reading over at least 6 breaths to be certain it is not a false positive. The exact percentage of carbon dioxide contained in the last few milliliters of the patient's exhaled air can be measured by a special sensor. For example, some electronic end-tidal carbon dioxide detectors use a photoelectric sensor that relies on absorption of infrared light by carbon dioxide to provide this measurement. The sensor can evaluate end-tidal carbon dioxide in the spontaneously breathing patient via a specialized nasal cannula-type device, or it can be attached to the end of a tracheal tube. These devices typically display a waveform that can give additional data about the patient's respiratory status. In addition, such monitors serve as alarms that can alert paramedics to changes in respiratory rate or depth. Peak expiratory flow. The peak flow is the maximum flow rate at which the patient can expel air from the lungs. A lower value indicates that the patient's larger airways are narrowed by bronchial constriction or bronchial edema. Many patients who have pulmonary disease check their own peak flow and chart the results. They may present this chart to you on your arrival. Normal peak flow values vary by age, gender, and height, but generally run from about 350 to 700 liters per minute. The current Canadian guidelines for the assessment and treatment of adult asthma from the Canadian Lung Association, the Canadian Thoracic Society, and the Canadian Association of Emergency Physicians define a moderate exacerbation of asthma as less than 300 liters per minute. A peak flow below 200 liters per minute is considered severe and signals significant distress. Some people with chronic asthma have a peak flow that never exceeds 100 liters per minute. Upper airway obstruction. Anatomic obstruction. The most common cause of upper airway obstruction in the unresponsive patient is the tongue. Indeed, this problem results in the death of trauma patients, patients with diabetes, patients who have had a seizure, or intoxicated patients every year. There seems to be an inherent urge on the part of bystanders to place a pillow behind the head of an unresponsive individual, which merely exacerbates this problem. If the patient is snoring, take away the pillow, and reposition the patient's airway. Excess soft tissue in the airway is one cause of obstructive sleep apnea, and some people go so far as to have tissue surgically removed from their pharynx to limit this anatomic obstruction. Fortunately, you can manually displace the soft tissue of the upper airway with a variety of simple maneuvers. Also, whenever you do not have a concern for spinal motion restriction, unresponsive patients may be positioned on their side, the recovery position, to avoid blocking the airway. Many post-seizure, intoxicated, or hypoglycemic patients can be transported safely on their side, which also reduces the risk of aspiration if they vomit. The infected airway. A variety of infections can cause swelling in the upper airway. The most common is probably croup, a distressing viral infection of the upper airway that most commonly occurs in small children. The Poiseuille law tells us that as the diameter of a tube decreases, resistance to flow increases exponentially. This phenomenon explains why children, who have inherently narrow airways, get croup when a viral infection causes minimal swelling in their upper airway, while adults with the same virus do not. In recent decades, many deadly upper airway infections have become very rare as a result of immunization efforts. Unfortunately, the rate of childhood immunizations has begun to decline as the general public becomes complacent about these diseases, so you must remain vigilant for these pathologic conditions. Table 29-4 lists infections that can impair the upper airway. Croup and tonsillitis are common, especially in children, but the other conditions are rare. When these pathologic conditions do occur, they are critical emergencies because the airway could swell shut with little warning, making orotracheal intubation extremely difficult or impossible. Avoid manipulating the airway in these patients unless absolutely necessary. It is usually possible to ventilate such patients with bag mask ventilation by paying careful attention to technique. If intubation is essential because of an inability to effectively ventilate the patient with bag mask ventilation, you may find that the airway is entirely obscured by the swelling, and your attempts at laryngoscopy may merely make the swelling worse. Try to have a partner press on the patient's chest while you look for a stream of bubbles coming from the airway. Use a tracheal tube at least 2 full sizes smaller than what you would typically choose for that patient. If this effort fails after a single attempt, a needle or surgical cricothyrotomy will be necessary. Aspiration. Aspirating stomach contents into the lungs carries a significantly high mortality rate. It is a common but profoundly dangerous complication in patients who have had a cardiac arrest or in unresponsive patients who have had trauma or who overdosed. Follow these guidelines when treating such patients. 1. Aggressively reduce the risk of aspiration by avoiding gastric distension when ventilating, and by decompressing the stomach with a nasogastric tube whenever appropriate. 2. Aggressively monitor the patient's ability to protect his or her own airway, and seek to protect the patient's airway with an advanced airway if this is impossible. 3. Aggressively treat aspiration with suction and airway control if steps 1 and 2 fail. If basic life support maneuvers fail to clear an obstructed airway, use laryngoscopy and McGill forceps and, if necessary, perform a needle or surgical cricothyrotomy. Aspiration could also refer to foreign body airway obstruction. Remember that most adults choke when they are intoxicated or traumatized or have a reduced gag reflex from stroke or aging. Chronic aspiration of food is also a common cause of pneumonitis in older patients. Make sure you do not make the situation worse by allowing these patients to eat when they are having difficulty breathing. Obstructive airway diseases. Obstructive airway diseases are characterized by diffuse obstruction to airflow within the lungs. The most common obstructive airway diseases are emphysema, and chronic bronchitis, chronic diseases, and asthma, an acutely episodic syndrome. These three conditions collectively affect as many as 10% to 20% of adults. Emphysema and chronic bronchitis are collectively classified as chronic obstructive pulmonary disease because the changes in pulmonary structure and function are chronic, progressive, and irreversible. Asthma is considered a separate entity because, at least in its early stages, it is a condition of reversible airway narrowing. Obstructive disease occurs when the positive pressure of exhalation causes the small airways to pinch shut, trapping gas in the alveoli. The harder the patient tries to push air out, the more it gets trapped in the alveoli. Hence, patients with obstructive disease end up with large amounts of gas trapped in their lungs that they cannot effectively expel. Patients with obstructive disease learn that if they push the gas out slowly at a low pressure, they can exhale more than if they try to push it out hard and fast. Patients with obstructive airway disease may demonstrate a variety of physical findings that can alert you to the nature of their disease. Pursed lip breathing. Breathing in this way allows patients to push a breath out slowly under controlled pressure. Increased inspiratory to expiratory ratio. The inspiratory to expiratory ratio is typically 1 to 2 in healthy people breathing quietly. It takes about twice as long to exhale as it does to inhale. Patients who are very sick with obstructive disease may have an inspiratory to expiratory ratio of 1 to 6 or 1 to 8. Abdominal muscle use. Abdominal muscles are used to push air out, exhalation. Patients with obstructive disease must work to push air out with every breath. Patients who have asthma often report abdominal pain after an attack. They do the equivalent of hundreds of sit-ups as they force each exhalation. Jugular venous distension. The trapped air creates a higher pressure in the thorax. Blood draining into the superior vena cava from the head and neck can back up in the jugular veins, causing jugular venous distension. Asthma. The name asthma, from Greek, meaning panting, was first given to this disease by the 2nd century Greek physician Aretius because in the paroxysms, the patients also pant for breath. Asthma is characterized by an inflammation in the bronchial airways due to a variety of stimuli. This inflammation results in widespread, reversible narrowing of the airways, or bronchospasm. Sometimes this condition is called reactive airway disease to indicate that the patient experiences bronchospasm when exposed to certain triggers, such as dust, cold, or smoke. Asthma characteristically occurs in acute attacks of variable duration. Between attacks, the patient may be relatively asymptomatic. According to 2018 statistics reported by Asthma Canada, approximately 3.8 million Canadians have asthma. Asthma is one of the most common diagnoses in emergency departments in Canada, and is the most common chronic disease in the pediatric population. Approximately 250 adults and 20 children, 1 in 100 admissions, will die each year because of asthma in Canada. Women, 9.2%, are more likely than men, 7%, to report that they had asthma. Asthma is the most common chronic disease of childhood, affecting 12.5% of children, and is the leading cause of chronic disease and disability in children. In Ontario alone, it accounts for approximately 17,600 emergency department visits and 2,500 hospital admissions each year. Bronchospasm. Bronchospasm is caused by the constriction of smooth muscle that surrounds the larger bronchi in the lungs. This may occur because of stimulation by an allergen or irritant such as dust, perfume, cat dander, or cold temperatures, or by other stimuli such as exercise or stress. When air is forced through the constricted tubes, it causes them to vibrate, which creates wheezing. Bronchospasm can also reduce the peak expiratory flow caused by a turbulent airflow. The primary treatment of bronchospasm is the administration of bronchodilator medication, beta-2 agonists such as salbutamol. Anticholinergic medications, ipratropium and tiotropium, are less commonly used. For life-threatening asthma, epinephrine is sometimes used to help reverse bronchoconstriction. Other treatments, such as magnesium for severe asthma, are generally reserved for the emergency department setting. Bronchial inflammation. Inflammation of the bronchi is the underlying cause of asthma. Therefore, most asthma patients will need corticosteroids, which are sometimes administered in the pre-hospital environment. Unlike bronchodilators, corticosteroids may take longer before their action is seen. Potentially fatal asthma. Patients who have potentially fatal asthma often have severely compromised ventilation all of the time. Such patients are at serious risk if something triggers acute bronchospasm or if they get an infection. A patient who has asthma is at high risk of respiratory arrest if he or she has a history consistent with any of the factors in Table 29-5. Medication noncompliance also predisposes a patient to asthma. Chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease comprises at least two distinct clinical entities, emphysema and chronic bronchitis. Emphysema. Emphysema is the destruction of the airway distal to the terminal bronchioles and alveoli. Some people have emphysema caused by a congenital enzyme deficiency, alpha-1 antitrypsin deficiency, but the most common cause of emphysema is cigarette smoking. In pure emphysema, the breakdown of the connective tissue structure of the terminal airways results in groups of alveoli merging into large blebs or bullae, which are far less efficient at exchanging oxygen and collapse far more easily, causing obstruction, than does normal lung tissue. Although little can be done in the pre-hospital environment to help this condition, many patients have associated bronchospasm, inflammation, or infections that can be relieved, helping improve the patient's overall situation. Many patients who have emphysema have a barrel chest caused by chronic lung hyperinflation. These patients are often tachypneic as they attempt to maintain a normal carbon dioxide level despite their dysfunctional lungs. They often use extreme amounts of energy attempting to breathe, cannibalizing their own muscle mass in the process. Chronic bronchitis. Chronic bronchitis is officially defined as sputum production most days of the month for 3 or more months out of the year for more than 2 years. The hallmark of this disease is excessive mucus production in the bronchial tree, which is nearly always accompanied by a chronic or recurrent productive cough, a cough that produces phlegm. The typical patient who has chronic bronchitis is almost invariably a heavy cigarette smoker. He or she is usually somewhat obese, congested, and sometimes has a bluish complexion. His or her blood gases tend to be abnormal, with elevated PaCO2 levels, representing hypercapnia, and decreased PaO2 levels, representing hypoxemia. Often, he or she has associated heart disease and right heart failure, cor pulmonale. The pink puffer, emphysema, and blue bloater, chronic bronchitis, represent two extremes of the chronic obstructive pulmonary disease spectrum. In reality, as the disease progresses, most patients with chronic obstructive pulmonary disease fall somewhere between these two clinical extremes, showing signs and symptoms of both disease processes. Restrictive disease. Trauma and diseases of the bones and muscles, severe kyphosis and scoliosis, can significantly impair the ability to move air, causing a group of disorders known as restrictive lung diseases, which comprises pathologies that limit the patient's ability to expand the lungs within the chest cavity. These disorders put patients at risk of infection, and may severely limit their ability to compensate for any respiratory insult. Restrictive lung diseases by themselves do not generate many calls for a paramedic response. They are mentioned for the sake of comparison to obstructive diseases, which paramedics will encounter frequently. Typical presentations of chronic obstructive pulmonary disease. Patients who have chronic obstructive pulmonary disease are often very sick people, with little or no respiratory reserves to help them deal with any additional respiratory insults. You must actively search for what has pushed them from a relatively stable state to the insufficiency that caused them to call 911. The following are some common issues that conspire to cause the patient who has chronic obstructive pulmonary disease to decompensate. Chronic obstructive pulmonary disease with pneumonia. Because they are chronically ill, have poor secretion clearance, and sometimes have excessive mucus production, which acts like a culture medium for nasty bugs, these patients often get infections in their bronchi and lungs. Do they have a fever? Has the color or amount of their sputum production changed? Do they have other signs of infection, such as body aches, general malaise, or pain when breathing? Are auscultated breath sounds, such as localized bronchi, consistent with pneumonia? Chronic obstructive pulmonary disease exacerbations with signs of infection are typically treated with antibiotics. Chronic obstructive pulmonary disease with right heart failure. It is very difficult for the right side of the heart to push the patient's thick blood through lungs destroyed by emphysema, and through capillaries squashed by hyperinflated alveoli. This commonly causes right heart failure secondary to the patient's lung disease, cor pulmonale. If patients take in too much salt or fluid, or if they do not get rid of fluid, because of renal failure or insufficient diuretic use, they may have an episode of heart failure. Do they have peripheral edema? Jugular venous distension with hepatojugular reflux? And inspiratory crackles? It may be difficult to tell the difference between the crackles of heart failure and the crackles that these patients always have secondary to their chronic obstructive pulmonary disease. Do they say they have had a progressive increase in dyspnea over several days? Have they taken in more fluid than usual, or run out of their diuretics? Chronic obstructive pulmonary disease with left heart failure. Patients with chronic obstructive pulmonary disease are at high risk of having a sudden cardiac event. Any sudden left ventricular dysfunction such as an acute myocardial infarction or cardiac rhythm disturbance, dysrhythmia, can cause them to have sudden onset left heart failure. Do not allow your initial impression of chronic obstructive pulmonary disease to prevent you from identifying the patient who is also having an acute myocardial infarction. Acute exacerbation of chronic obstructive pulmonary disease. In the acute exacerbation, no coexisting condition such as heart failure or pneumonia clearly accounts for the patient's sudden decompensation. Instead, the patient's condition suddenly becomes worse, often because of some environmental change such as weather, humidity, or sudden activation of the heating or cooling system. An acute exacerbation can also be prompted by the inhalation of trigger substances. Did your patient decide to go through some old boxes today? Did a neighbor just visit with the cat? Is someone painting in the next room? End-stage chronic obstructive pulmonary disease. Patients with severe chronic obstructive pulmonary disease will eventually reach a point when their lungs simply cannot support oxygenation and ventilation any longer. You may come to know these patients well as their calls to 911 become more frequent. Some will be in hospice care. In the end stages of the disease, it can be difficult to determine whether a patient has an exacerbation that can be resolved or if he or she has reached the end of the disease process. Unfortunately, tracheal intubation may result in a situation where the patient cannot make his or her wishes known. In addition, the more frequently the patient has to be intubated and placed on a ventilator, the more difficult it becomes to wean the patient off the ventilator. Having this knowledge increases the anxiety level of the patient, thus increasing his or her cardiac workload and cardiac oxygen consumption, a potentially lethal combination for the patient with end-stage chronic obstructive pulmonary disease. All EMS systems have their own ways of dealing with do not resuscitate orders. It is important to secure documentation of the patient's wishes as the terminal phase of the disease begins. Follow local protocol or contact direct medical control as needed regarding such issues. Hypoxic drive. Hypoxic drive is a rare phenomenon that affects only a very small percentage of patients who have the most chronic forms of pulmonary disease in the end stage of their disease. As a paramedic, you'll routinely provide pre-hospital care for the sickest of the sick, so you should understand this concept. You'll likely encounter patients whose respiratory drive can be decreased by high levels of oxygen. However, 100% supplemental oxygen is foundational therapy for most patients, so it makes no sense to withhold oxygen from anyone who needs it for fear of decreasing the respiratory drive of those few people who might have this complication. When a patient has chronic hypoventilation, bicarbonate ions are retained to compensate for respiratory acidosis. The patient might then switch to a hypoxic drive, meaning that the primary stimulus to breathe comes from decreased levels of oxygen, not increased levels of carbon dioxide. This places you in the position of having to decide whether the administration of oxygen is appropriate. In making this decision, consider the following points. 1. Only a small subset of patients with chronic obstructive pulmonary disease breathe because of hypoxic drive, but you cannot tell who they are just by looking at them. 2. Such patients do not suddenly become apneic after a whiff of oxygen. High levels of oxygen slowly depress their respiratory drive, and their respiratory rate slowly declines. They become sleepy and, eventually, their respiratory rate falls into the single digits before they become apneic. Although you are likely to be close enough to the patient to recognize this phenomenon, the real concern is the in-hospital patient who receives 100% supplemental oxygen but then is left by himself or herself for a prolonged period. 3. If the patient becomes apneic, provide artificial ventilation, and consider intubation. 4. Although oxygen saturation may be a valuable adjunct to your decision, oxygen saturation numbers are a little different for patients with chronic obstructive pulmonary disease, and tell you nothing about their carbon dioxide levels. Common respiratory presentations. Asthma with fever. When patients with reactive airways begin wheezing, their inhalers usually will help for only a little while before their symptoms return. The typical asthma attack that responds to treatment but occurs again in a few hours is sometimes caused by an underlying infection, such as pneumonia or bronchitis, that continually triggers the asthma-like symptoms. The asthma attack will not go away until the patient receives treatment of the trigger. Does your patient have a fever or chills? Are they coughing up colorful sputum? Failure of a metered dose inhaler. Metered dose inhalers indicate how many actuations, puffs, they are designed to deliver, but most patients do not keep track of their usage very well. Often the medication may be exhausted even though some propellant remains in the canister. The patient may have been sucking nothing but propellant for days, which explains why their wheezing is not getting better. Similar problems can occur when patients use grossly outdated medications or medications that have been overheated, left in a hot car or similar environment. In this case, your bronchodilator may work well, even though theirs has failed. Another problem that can occur is that patients who do not fully understand how to use the device do not inhale at an appropriate point, and then end up spraying the medicine on the inside of their mouths. This is one reason why physicians often prescribe a spacer device to be added to the metered dose inhaler for children, and for adults who have difficulty using the device. Dyspnea triggers. Just because someone knows that their reactive airways are triggered by cats, perfume, cigarette smoke, cold, or pollen does not mean that they can always avoid these triggers. Sometimes a social or family situation is important enough that patients are willing to risk experiencing an episode of dyspnea. Sometimes people who are allergic to cats will hold a cat, and people who are on strict fluid restriction will drink excessively. Seasonal issues. Many ugly things grow in heating ducts and air conditioners during their off-seasons. When the weather suddenly changes, and heating systems or air conditioners begin turning on in houses all over your district, you can expect an increase in calls from chronically ill respiratory patients. Excessive heat, humidity, cold, pollen, dust, and smog can all conspire to push someone over the edge and experience a flare-up of respiratory disease. Non-compliance with therapy. Many patients who have chronic respiratory disease will rebel against their therapy as an attempt to regain some control over their lives. Sometimes, the long-term nature of their therapy is not fully understood, and they attempt to wean themselves off of their medications, oxygen, or respiratory support devices. However, this may cause them to have a crisis. Many patients have been prescribed home oxygen, nebulizer therapy, continuous positive airway pressure, bi-level positive airway pressure, and a variety of medications that they refuse to use or use only sporadically. Some medications, such as oral corticosteroids, can cause dangerous complications if their use is terminated abruptly. Failure of technology or running out of medicine. Advances in technology have allowed patients who have chronic respiratory disease much more freedom to get out of the house and to travel. This creates the risk that you will be called to assist someone whose oxygen tank has run dry, whose portable ventilator has suddenly malfunctioned, or whose medications were left behind. Exertion-related problems. Oxygen demand increases with any kind of exertion. If patients' conditions are stable at rest, compare their condition during typical exertion. Do they get dyspneic when they move from their chair to your stretcher, go to the bathroom, or eat? Note oxygen saturation while at rest, and during any simple exertion. Check babies while they are eating or after they cry. Other causes of respiratory problems. Pulmonary infections. Bacteria, viruses, fungi, mycoplasmas, and many other agents cause infections. The respiratory tract is particularly vulnerable to a variety of airborne agents, as well as those that reside in the nose or throat, and subsequently migrate into the bronchi and lungs. Infections of the upper airway may require aggressive approaches to airway management. Infections in the lower airway are usually treated with supportive pre-hospital care, and by transport to the hospital. In general, infectious diseases cause swelling of the respiratory tissues, an increase in mucus production, and the production of pus. Swelling in the well-perfused respiratory tissues can be dramatic, particularly in the upper airway. This is problematic because the resistance to airflow goes up exponentially when tube diameter is narrowed, the Poiseuille law. Alveoli can also become non-functional if they fill up with pus, as occurs in pneumonia. Like collapsed or fluid-filled alveoli, pus-filled alveoli do not participate in gas exchange. Instead, these alveoli contribute to shunt, in which oxygen does not reach the bloodstream, perhaps resulting in hypoxemia. Problems with ventilation, perfusion, or both can prevent oxygen from reaching the bloodstream. Pneumonia may be caused by any of a variety of bacterial, viral, and fungal agents. Bacterial pneumonia is most frequently caused by Streptococcus pneumoniae bacillus, for which an effective vaccine is now available. This type of pneumonia has caused a 13% increase in Canadian emergency department visits from 2017 to 2018, according to the Canadian Institute for Health Information. Pneumonia is one of the top causes of in-hospital deaths, and over 6,000 Canadians die from pneumonia each year. Older people, patients with chronic illnesses, and smokers are at greater risk of contracting this illness. In fact, anyone who is not moving air well, who has excessive secretions, such as patients with chronic obstructive pulmonary disease or asthma, or who are post-operative, bedridden, or sedentary, or who is immunocompromised, is at risk of developing pneumonia. Patients with acquired immunodeficiency syndrome are particularly susceptible to pneumocystis pneumonia caused by Pneumocystis carinii. It is a primary cause of morbidity and mortality in such patients. All high-risk patients are strongly encouraged to get the pneumonia vaccine annually. The patient with pneumonia usually reports several hours to days of weakness, productive cough, fever, and sometimes chest pain made worse by a cough. The illness may have started abruptly with a shaking chill, rigor, or came on more gradually with progressive weakness. As you obtain your history of recent illness, be particularly tuned in for comments akin to, "I just got over the flu about a week ago." Frequently, pneumonia is a secondary infection that follows a bout of the flu, and is one of the leading causes of death under those circumstances. On physical examination, the patient with pneumonia often appears very ill, has a toxic appearance. He or she may or may not be coughing. Crackles may be heard on auscultation of the chest, and there may also be increased tactile fremitus and sputum production. In advanced cases, areas of diminished or absent breath sounds are noted, due to consolidation. Sputum may be either thick, because of dehydration, or purulent, pus-like. Pneumonia often occurs in the lung bases, typically on only one side. Sometimes patients' oxygen saturation will be significantly lower when they lie on one side versus the other. In pneumonia, this is typically when the good lung is down, although this is not always the case. Patients with pneumonia are often dehydrated, which contributes to VQ mismatch, and intravenous hydration is often required. Supportive pre-hospital care includes oxygenation, secretion management, suctioning, fluids, and transport to an appropriate facility. Bronchodilators will not help the pneumonia, but they may slightly improve the patient's ability to ventilate, especially if they have underlying asthma or chronic obstructive pulmonary disease. Alveolar dysfunction. The alveoli are vulnerable to a number of disorders. They may collapse, atelectasis, from obstruction somewhere in the proximal airways or from external pressures produced, for example, by pneumothorax or hemothorax. They may fill with pus and pneumonia, with blood and pulmonary contusion, or with fluid in near drowning or heart failure. Atelectasis. In healthy lungs, most alveoli do not collapse on exhalation. Instead, the healthy individual employs a variety of methods to keep them open, such as sighing and coughing. However, after operations, when people are sick, or when there is injury or damage to the chest wall, lungs, or surrounding tissues, the alveoli and lung segments may collapse, which is called atelectasis. Deep breathing, sighing, yawning, and coughing are all mechanisms through which our bodies keep alveoli open and avoid atelectasis. Like balloons, alveoli are more difficult to blow open once they have completely collapsed. In the hospital, patients are encouraged to take deep breaths. A device called an incentive spirometer helps patients quantify how deep their breaths are. These devices are often sent home with patients for continued use after they have been discharged from the hospital, that is, rib fracture, chest surgery. Cancer. Lung cancer is one of the most common forms of cancer, especially in cigarette smokers or in people exposed to occupational lung hazards, such as asbestos, coal dust, or secondhand smoke. Lung cancer is the leading cause of death due to cancer in Canada, representing an estimated 26.1% of the cancer deaths in men and 26.2% of the cancer deaths in women. The vast majority of cases are caused by smoking. Lung cancer may present with a variety of symptoms, including hemoptysis and uncontrollable coughing, shortness of breath due to cancerous fluid accumulating around the lung, or pneumonias because tumors compress and block a major airway. Because many patients with lung cancer are smokers, these symptoms may be accompanied by chronic obstructive pulmonary disease and impaired lung function. The lungs are also common sites for the metastasis of cancers from other parts of the body. Other cancers may invade the lymph nodes in the neck, producing tumors that threaten to occlude the upper airway. Patients with various types of cancers may experience pulmonary complications from their chemotherapy or radiation therapy. Lung irradiation, for example, may be associated with some degree of pulmonary edema. Tumors or treatment may also cause a pleural effusion, which can present with rapidly progressing dyspnea. You may be called to assist with end-of-life issues for cancer patients. Patients in hospice care, for example, may present with depressed respirations caused by the large amounts of narcotics administered to them or that they have administered to themselves. In this type of narcotics overdose, remember to titrate naloxone only to improve respirations. Do not completely reverse the patient's primary pain control, as you can abruptly leave them in complete misery. In the past, the respiratory depressant effects of narcotics and anti-anxiety agents may have been overemphasized, but now these agents are gaining increased popularity in the management of chronic pain, chronic cough, and anxiety in end-of-life scenarios. For instance, fentanyl, a strong narcotic, is sometimes dispersed through an aerosol to suppress a chronic cough in patients who have end-stage lung cancer. Toxic inhalations. Many potentially toxic substances can be inhaled into the lungs. The type of damage done depends in large part on the water solubility of the toxic gas. Highly water-soluble gases like ammonia will react with the moist mucous membranes of the upper airway and cause swelling and irritation. If the substance gets in the patient's eyes, they will also burn and feel inflamed and irritated. Less water-soluble gases may get deep into the lower airway, where they may do damage over time. Such toxins have been used in war to disable the enemy, because they do not cause immediate distress but rather cause pulmonary edema up to 24 hours later. Gases such as phosgene and nitrogen dioxide will present in this manner. Some common gases, like chlorine, are moderately water-soluble and present somewhere between the two extremes. Severe exposure may present with upper airway swelling, whereas lower-level exposure may present with the classic delayed onset, lower airway damage. Table 29-7 details the different categories of toxic gases. A patient who has been exposed to such a substance must be removed from contact with the toxic gas immediately and provided with 100% supplemental oxygen or assisted ventilation if breathing is impaired. There is reduced tidal volume. If the upper airway is compromised, aggressive airway management, such as intubation or a cricothyrotomy, may be required. Pulmonary edema. Swelling of the lungs occurs when fluid from the blood plasma migrates into the lung parenchyma, the tissues that make up the walls of the capillaries and alveoli. This pulmonary edema compromises gas exchange long before this fluid spills into the alveoli and becomes noticeable, usually presenting with pink, frothy sputum. One of the most common causes of pulmonary edema is heart failure resulting from a left-side acute myocardial infarction. Inhaled toxins can also damage alveolar tissue and cause fluid to seep into the lungs. Other infection-mediated substances may also damage the pulmonary capillaries and cause the same effect. Sometimes trauma or even altitude changes can lead to acute respiratory distress syndrome or high-altitude pulmonary edema. Early in pulmonary edema, you'll hear crackles in the bases of the lungs at the end of inspiration. This sound is caused by fields of alveoli popping open as the lungs reach maximal inflation. Always listen to the lower lobes of the lungs through the patient's back. As pulmonary edema worsens, you may begin to hear crackles higher in the patient's lung fields, often described as crackles up to the subscapular level or crackles up to the apices. As fluid migrates into the larger airways and mixes with mucus, you'll begin to hear coarse crackles on inspiration and exhalation. You may also feel tactile fremitus. Ultimately, the patient will begin to cough up watery sputum that often has a pink tinge, from red blood cells. As air is forced in and out of the fluid-filled lungs, the fluid may bubble and foam. Coughing up pink and foamy or blood-tinged sputum is a classic danger sign of severe pulmonary edema. Acute respiratory distress syndrome. You'll not see acute respiratory distress syndrome very often in the pre-hospital setting unless you are involved in doing interfacility transfers. However, you can play a vital role in preventing this devastating pathologic condition in many patients. This syndrome is caused by diffuse damage to the alveoli as a result of trauma, shock, aspiration of gastric contents, pulmonary edema, toxicity, or hypoxic events. It seems to be worse when there is some direct damage to the lungs, as in trauma patients who have severe pulmonary contusions. Alveoli become stiff, non-compliant, and difficult to ventilate. Patients may ultimately require mechanical ventilation under very high pressure, which causes even more damage. Studies have shown that the way people are ventilated in the pre-hospital and early hospital setting may affect their likelihood of developing acute respiratory distress syndrome later. You can play an important role in reducing the risk of developing acute respiratory distress syndrome by avoiding high airway pressures and high tidal volumes in patients who have pneumonia, trauma, or hypoxemic respiratory failure. Problems outside the lung parenchyma. Pneumothorax. When a patient has a pneumothorax, air collects between the visceral and the parietal pleura that line the inside of the chest cavity. Some people have blebs in their lung parenchyma that are congenital or that result from chronic obstructive pulmonary disease, and which leave them susceptible to the development of this condition. Blebs are weak spots that can rupture when under stress, causing a spontaneous pneumothorax. The stress that ruptures the bleb may be as simple as coughing, or as severe as aggressive bag mask ventilation. People who have severe asthma are susceptible to blebs, as are tall, thin people, especially those who smoke. Some patients have had multiple simple pneumothoraces in their life, and may actually present with the chief complaint, "I'm having another pneumothorax." They may describe feeling a sharp pain after they cough, followed by increasing dyspnea over the subsequent minutes or hours. Most of these patients will not require acute intervention such as chest needle decompression, but you should at the very least administer high concentrations of oxygen, and monitor their respiratory status closely while en route to the hospital. Pleural effusion. When fluid collects between the visceral and parietal pleura, it is called a pleural effusion. Effusions can be caused by infections, tumors, heart failure, or trauma. Pleural effusions can impair breathing by limiting lung expansion and causing partial or complete lung collapse. Some pleural effusions can contain several liters of fluid. A large effusion will decrease lung capacity and make the patient dyspneic. It may be difficult to hear any breath sounds through the effusion. Because the effusion is filled with fluid, the patient's position will affect his or her ability to breathe. Shifting positions may make patients significantly more dyspneic, and they will usually fight being placed into anything other than Fowler position. Supportive pre-hospital care, including proper positioning and aggressive supplemental oxygen administration, should be used until you can get the patient to an appropriate facility where the effusion can be definitively treated. Disruption of the pulmonary circulation. The pulmonary circulation may be compromised by a blood clot, thromboembolism, a fat embolism from a broken bone, an amniotic fluid embolism from leakage of amniotic fluid from the amniotic sac, or even an air embolism resulting from air entering the circulation from a laceration in the neck or an intravenous administration set that was improperly or not flushed. A large embolism, of whatever type, may lodge in a major branch of the pulmonary artery and act as a plug, and prevent any blood flow through that branch. Adequate gas exchange in the lungs requires functional alveoli to provide oxygen and take up carbon dioxide, as well as intact pulmonary vessels to convey oxygen-poor blood to the alveoli. Normal alveoli will be of little use if the venous blood cannot reach them, as is the situation in pulmonary embolism. Pulmonary embolism is considered one of the most frequently misdiagnosed conditions in emergency medicine. As such, it is often a very confusing presentation, because it is not immediately evident that anything is wrong with the patient's lung. The story of sudden dyspnea, perhaps with a sharp pain in the chest, should make you consider pulmonary embolism. Most pulmonary embolisms come from the large veins in the legs, particularly the greater saphenous veins, where clots can form a deep venous thrombosis, and subsequently break off and migrate through the venous circulation, through the right side of the heart, and into the pulmonary circulation. Patients with thrombophlebitis, inflammation of the veins in the legs, are at high risk of pulmonary embolism. They may exhibit leg swelling or calf tenderness. Many patients with deep venous thrombosis or pulmonary embolism have an identifiable risk factor: recent surgery, immobilization, air travel, or blood clotting disorder, although a large proportion of those with deep venous thrombosis or pulmonary embolism do not have an identifiable risk factor, and are deemed idiopathic. Certain cancers predispose patients to clots, as does pregnancy, and oral contraceptive use. Clots may also form when patients are immobile for long periods of time. Sudden pulmonary embolisms sometimes occur in people after long car trips or lengthy airplane flights. Bedridden patients are often prescribed anticoagulants or wear special compression stockings or other devices to reduce the formation of blood clots in the legs. Treatment for deep venous thrombosis is usually an oral or injectable anticoagulant, although if this is not possible, then an inferior vena cava filter may be inserted. This device, which opens like a mesh umbrella in the main vein that returns blood to the heart, is intended to catch any clots that break loose and travel from the legs. Very large pulmonary embolisms can lodge at the bifurcation of the right and left pulmonary arteries. These are called the saddle embolus, and may be immediately fatal. If there is a very large saddle embolus, and the patient is unstable, fibrinolytic therapy may break up the clot and prevent cardiac arrest. Cardiac arrest caused by a large pulmonary embolism is a very difficult situation that few patients survive. You may note ongoing cyanosis, deep cyanosis of the face, neck, chest, and back, despite good quality cardiopulmonary resuscitation and ventilation with 100% supplemental oxygen in this scenario. Disorders of ventilation. Ventilation is the movement of gas in and out of the lungs. With the use of supplemental oxygen, reasonable and even high oxygen levels are easy to maintain in patients who have healthy lungs, even if ventilation is severely compromised. The best measurement of ventilation, however, is the carbon dioxide level. Under normal circumstances, the volume of ventilation, minute volume, is regulated by the need to maintain the PaCO2 in the range of 35 to 45 millimeters of mercury. In a person at rest, that goal is usually accomplished by breathing a tidal volume of around 500 milliliters at a rate of 12 to 16 breaths per minute, that is, with a minute volume in the range of 6 to 8 liters. During deep sleep, a smaller minute volume may suffice, while the muscular exertion associated with exercise may require a larger minute volume. As long as the PaCO2 remains in the normal range, ventilation is considered normal. The carbon dioxide level is also directly related to pH, acid-base balance. Patients who are hypoventilating usually have respiratory acidosis. As their carbon dioxide level goes up, their pH level goes down. Patients who are hyperventilating are usually in respiratory alkalosis. As their carbon dioxide level goes down, their pH level goes up. Respiratory failure resulting from hypoventilation. Many different problems can cause patients to hypoventilate. Conditions that impair lung function. Conditions that impair the mechanics of breathing. Conditions that impair the neuromuscular apparatus. Conditions that reduce respiratory drive. In these circumstances, you must often provide aggressive treatment to help the patient's respiratory efforts. Conditions that impair lung function. When the patient is breathing but gas exchange is impaired, carbon dioxide levels rise. This can happen in severe cases of atelectasis, pneumonia, pulmonary edema, asthma, or chronic obstructive pulmonary disease. Conditions that impair the mechanics of breathing. A high cervical fracture, flailed chest, diaphragmatic rupture, severe retractions, obesity, pregnancy, an abdomen full of air or blood, abdominal or chest binding, using a pneumatic anti-shock garment or immobilization straps, or anything else that impairs the pressure changes that allowed breathing can result in reduced gas flow. Conditions that impair the neuromuscular apparatus. Patients who have had head trauma, intracranial infections, or brain tumors may have damage to the respiratory centers of the brain, which in turn may compromise ventilation. Serious injury to the spinal cord, above C5, may block the nerve impulses that cause breathing to occur. Guillain-Barré syndrome causes progressive muscle weakness and paralysis. If the paralysis reaches the nerve supplying the diaphragm, the patient will be unable to breathe effectively. Amyotrophic lateral sclerosis also causes progressive muscle weakness. This disease is fatal, with death usually coming from respiratory failure as the muscles of respiration become unable to maintain adequate ventilation. Botulism is caused by the bacterium Clostridium botulinum. Though somewhat uncommon, it is usually the result of food poisoning. Botulism can cause muscle paralysis, and is typically fatal when it reaches the muscles of respiration. Conditions that reduce respiratory drive. Perhaps the most common hypoventilation crisis seen by EMS systems is the acute opiate, heroin, oxycodone, fentanyl, overdose. Intoxication with alcohol, narcotics, and other drugs or toxins can reduce the respiratory drive. Head injury, hypoxic drive, or asphyxia can all present with grossly low respiratory rates and volumes. Of course, the ultimate expression of hypoventilation is respiratory and then cardiac arrest. Hyperventilation. Hyperventilation occurs when people breathe in excess of metabolic need. This typically occurs when they increase the rate or depth of breathing enough to cause a decrease in their carbon dioxide level. Interestingly, a falling carbon dioxide level may make the patient feel short of breath, so he or she tend to become anxious and breathe even more rapidly and deeply. In acute hyperventilation syndrome, patients usually feel as if they cannot breathe at all. The continued fall in their carbon dioxide level leads to a rise in their pH level, respiratory alkalosis, that in turn causes numbness or tingling in the hands and feet and around the mouth. The patient may eventually lose consciousness if the patient is unable to control his or her breathing. The traditional therapy for hyperventilation called for patients to rebreathe their own carbon dioxide by breathing into a paper bag, or by applying a partial rebreather mask at 21% oxygen. This is a very dangerous practice for important reasons. Patients quickly exhaust the oxygen and the gas they are breathing, and rebreathing. Remember, hyperventilation does not mean that the patient has too much oxygen, but rather that he or she is blowing off too much carbon dioxide. Do not cause the patient to become hypoxic while trying to stop a relatively benign hyperventilation episode. Any patient who is acidotic might be hyperventilating in an attempt to drive their pH level down to normal levels. In diabetic ketoacidosis, for example, the patient's body is making too much acid because of inadequate glucose metabolism, so the body attempts to compensate for the acidosis by hyperventilating, co-small respirations. It would be a grave error to force such a patient to breathe into a paper bag. A variety of overdoses, toxic exposures, and metabolic abnormalities can also result in acidosis and compensatory hyperventilation, and none of them have the kind of hyperventilation that should be treated by rebreathing carbon dioxide. You should never come to the conclusion that your patient is just hyperventilating until you have ruled out all other potential causes for his or her presentation, which would be very difficult, if not impossible, to do in the pre-hospital environment. Frequently, hyperventilation will follow some emotional stressor. Speak calmly with the patient, and explain the cause of the physical symptoms. Other techniques include breathing with the patient, having the patient count to 2 between each breath, increasing to higher numbers as he or she is successful, and various distraction techniques, such as asking the patient to recite his or her life stories. Hyperventilation that is not caused by some metabolic crisis is usually self-limiting. Explain to the patient that the physical symptoms will pass with normal breathing patterns. Managing the patient who has dyspnea. You have a relatively short list of tools to treat respiratory compromise. At the most basic level, paramedics provide supportive pre-hospital care, ensure airway adequacy, administer high-concentration supplemental oxygen therapy, and provide monitoring and transport for many patients. In actuality, there is little you can do in the pre-hospital setting to alter their pathologic conditions, such as chronic obstructive pulmonary disease, pneumonia, or pulmonary contusion. The primary exception is the treatment of bronchoconstriction. Many bronchodilators are available to help relax bronchial smooth muscle. This therapy can be extremely helpful if the patient's primary problem is bronchial muscle spasm resulting from anaphylaxis or asthma. Bronchodilator therapy may be somewhat helpful to many other patients as well. At the other end of the spectrum of pre-hospital care are the patients who are in overt respiratory failure. The primary approach to this population is to take over the work of breathing completely by intubating them and manually ventilating them. Ensure an adequate airway. The first part of assessing and managing any respiratory problem is to ensure an open and maintainable airway. Get rid of any food, gum, or like items out of the patient's mouth. Suction if necessary, and keep the airway in the optimal position, which typically is the position that makes the patient most comfortable. Decrease the work of breathing. Remove constricting clothing, such as belts or tight collars. Reduce the patient's breathing workload. Help the patient sit up if they feel that position is more comfortable. Do not make the person walk. Do not let a big abdomen get in the way of the diaphragm. Relieve gastric distension, perhaps with a nasogastric tube. Do not bind the chest or make the patient put pressure on the good lung. Provide supplemental oxygen. It is essential to deliver supplemental oxygen to any patient who needs it. If the patient is breathing adequately, administer 100% oxygen via a non-rebreathing mask. Patients who are not breathing adequately should receive bag mask ventilation and 100% oxygen. Closely reassess the patient's breathing status, and adjust your treatment accordingly. Bronchodilate. Many patients who have respiratory distress can benefit a little from bronchodilation, and some patients can benefit a lot. Today's aerosol bronchodilators rarely hurt patients, so they can be used aggressively in the pre-hospital setting. Patients who do not have bronchoconstriction or bronchospasm will probably benefit little from aerosol bronchodilators, and you may have to drop their delivered oxygen concentration during a typical aerosol treatment. In these circumstances, the non-rebreathing mask may trump the aerosol treatment. Follow your local or regional treatment protocol. Consider fluid balance. Rehydration is supplemental therapy for patients with respiratory problems who are dehydrated, for example, some patients who have pneumonia or asthma. It is common practice to give a fluid bolus to younger patients in these scenarios. Any older patient or patient who has a cardiac dysfunction could be pushed into pulmonary edema by too much fluid. Always assess breath sounds before and after giving a fluid bolus to make certain you have not volume overloaded the patient. Of course, patients who have respiratory problems can become very sick in a hurry, and you will almost always want to have an intravenous line in place, in case of further deterioration. Provide diuresis. Many older patients who have respiratory disease have a component of heart failure, and might benefit from a loop diuretic such as furosemide, Lasix. Of course, not every patient who has crackles has pulmonary edema. Giving diuretics to patients who have pneumonia or asthma may actually worsen their overall condition. As always, Careful assessment and interpretation must lead you to a correct diagnosis. If transport time is short and the patient's condition is not dire, perhaps the emergency department can make a better decision after seeing a radiograph and some lab work. Support or assist ventilation. If the patient becomes fatigued, you may need to support breathing in a more aggressive fashion. Therapy with continuous positive airway pressure or bilevel positive airway pressure is becoming increasingly common and can allow you to avoid intubation in many patients. Some patients may simply require bag mask ventilation for a short period to reoxygenate, improve their hemoglobin saturation, and reduce PaCO2 levels. You must be confident in your bag mask ventilation technique so that you do not make a patient's condition worse. Trying to supplement breathing in a patient who is already breathing on his or her own is one of the most difficult interventions to pull off. Gastric distension and vomiting from over-aggressive ventilation can be disastrous in a patient who is already compromised. As always, do no harm. The same is true when providing sedation to anxious or combative patients. The need to control them must be balanced against the possibility of depressing their respirations further. Agitation from dyspnea needs to be corrected with proper oxygenation and ventilation, not sedation. Take over ventilation. Ultimately, you may need to intubate and ventilate patients who are in respiratory failure. Intubation can be life-saving, and many patients can be extubated within a day or two and go on to have excellent outcomes. However, there are some issues to consider when intubating a patient. You must weigh these issues along with the protocols, medical direction, and any expression of the patient's wishes. Keep these issues in mind. Intubation should be the last option for patients who have severe asthma. These patients are extremely difficult to ventilate and are prone to pneumothoraces. Be proactive, ventilate patients before cardiac arrest occurs. When in doubt, attempt to ventilate. If they fight you, they may not be ready for intubation. If they allow you to bag them, they probably are ready for intubation. Patients who are responsive, yet still in respiratory distress, will often require sedation and neuromuscular blocking medications through rapid sequence intubation to facilitate intubation. Some patients who have diabetes or have overdosed present with an obvious need for intubation. However, if dextrose or naloxone, Narcan, is likely to completely change that picture, it might be better to use bag mask ventilation for a few minutes to monitor the effect of the initial therapy, assuming you can do so without causing gastric distension and vomiting. Remember to ventilate slowly, more than 1 second, and use only enough ventilation to produce visible chest rise. Respiratory pharmacology. Medication delivery. Pharmaceutical therapy for respiratory problems is delivered via a variety of methods, some of which are discussed here. Metered dose inhalers. When properly used, the metered dose inhaler should be at least as effective as an aerosol treatment. This device is small, easy for the patient to carry and use, and convenient. Because it does not require additional equipment, such as a nebulizer or air compressor, it is usually the delivery method of choice for both bronchodilators and corticosteroids in the home setting. Metered dose inhalers do have some drawbacks. First, using such a device requires a cooperative patient who is able and willing to perform the maneuver correctly. Because the entire dose is delivered in 1 or 2 breaths, improper technique may result in little or no medication actually getting into the lungs. Also, patients may not realize when they are using an empty inhaler, that is, some propellant remains but there is no medication. The metered dose inhalers that you carry on the ambulance should ideally be equipped with spacers. A spacer is a device that collects the medication as it is released from the canister, allowing more to be delivered to the lungs, and less to be lost to the environment. Remember, the mist you see coming out of the inhaler is not what reaches the patient's alveoli, rather, the 5-micron particles, which stay suspended in the spacer for several minutes, are pulled deep into the lungs by smooth laminar flow. When a spacer is used, the patient does not have to worry about timing the inhalation to coincide with the discharge of the inhaler. Spacers also reduce deposition of the drug into the mouth and oropharynx, which is a problem with the inexperienced user. Achieving the proper technique when using a metered dose inhaler is not difficult, but it requires constant reinforcement. The steps for administering medication with a metered dose inhaler are demonstrated in Chapter 8. Following are some tips on common errors when using or administering a metered dose inhaler, and how to avoid them. Patients need to deeply inhale as they discharge the inhaler to suck the medication deep into their lungs. Placing the inhaler directly into the patient's mouth, without a spacer, often causes much of the medication to fall on the posterior pharynx, from where it is swallowed and digested, thus negating its intended effect. Some patients mistakenly blow into the spacer. Tell them to think of the spacer as a big straw, and they should try to suck the medication out of the bottom. Many spacers will make a harmonica-like sound if the patient sucks too hard. The best particle deposition comes from smooth, low-pressure, laminar flow. Sucking too hard causes turbulent flow, which makes most of the particles stick to the trachea and large bronchi, where they are not as effective. Patients should try to inhale the medication deeply, and then hold their breath for a few seconds. This is a lot to ask of someone who is dyspneic, and it is not always possible. Sometimes the inhaler causes the patient to cough immediately after inhaling the medication, which also does not result in the best delivery, but may be unavoidable. Let the first puff open up the airways a little, so the second puff gets in deeper a minute or two later. Give the bronchodilator first. Many patients have multiple inhalers. A common package might include a rapid-acting beta-2 agonist, rescue inhaler, a corticosteroid, and a slow-acting bronchodilator. Always use the rescue inhaler first. It will dilate the bronchi so that subsequent medications are more effective. In an emergency situation, the slow-acting bronchodilators will not have any immediate effect, so they would not be given. After using a corticosteroid inhaler, patients are encouraged to rinse out their mouth with water or mouthwash. Residual corticosteroid in the pharynx can predispose the patient to thrush, an annoying fungal infection in the pharynx or mouth. Make sure the inhaler contains medication. Most inhalers list the number of puffs of medication in the canister on the label. Patients should be encouraged to keep track of how many times they have used the inhaler, and to discard it when they reach the recommended number of uses. Just because you can hear fluid in the canister when you shake it does not mean that there is medication left. Keep the spacer and canister holder clean and dry. Nebulizer therapy. Aerosol nebulizers convert liquid medications into an aerosol in the form of a fine mist. Recall that 5-micron or smaller particles ride laminar airflow into the lower respiratory tract. Larger particles rain out in the mouth and pharynx and get swallowed, so they have little ultimate effect. To generate the optimal particle size, most nebulizers need to have gas flow of at least 6 liters per minute. In the home, most people run their aerosol treatments off of a small air compressor. In the ambulance, you typically run this therapy off of either tanked oxygen or off-the-wall unit attached to the main oxygen supply. As a result, you might be giving only 35% to 40% oxygen via an aerosol treatment, but this is still more than the 21% oxygen contained in room air. A nebulizer can be attached to a mouthpiece, pipe, a face mask, a tracheostomy collar, or simply held in front of the patient's face, blow-by technique. The less the patient breathes in the mist, the less medication he or she actually receives. Blow-by and mouthpiece treatments are not very effective if patients keep turning their head or removing the mouthpiece to answer your questions. As such, once the decision is made to deliver a breathing treatment, try to stop the conversation, and let the patient focus on breathing in the medication. Although bronchodilators are the drugs most commonly delivered by aerosolization, corticosteroids, anesthetic agents, antitussives, and mucolytics can all be dispersed through an aerosol. Aerosol lidocaine is an extremely effective method of numbing the upper airway before procedures, and aerosol fentanyl is used to reduce chronic coughing in patients who are terminally ill with lung cancer. The newer aerosol bronchodilators cause far less tachycardia than the older, less beta-2 specific ones. As a result, it has become possible to give repeated treatments to patients with bronchoconstriction. Continuous nebulizers are available that hold up to 10 times the usual medication dosages, and run for 1 hour or more. The steps for administering medications via small volume nebulizer were demonstrated in Chapter 8. Dry powder inhalers. Some respiratory medications are most stable in the form of a very fine powder. Such medications are often placed inside a plastic device that the patient places in his or her mouth, and from which he or she inhales deeply. These devices are reasonably convenient and easy to use, but they are rarely used during emergency care. Several common corticosteroids and slow-acting bronchodilators are routinely packaged in a disc-like device, which holds about 1 month's worth of medication. Each time the device is opened, the small plastic blister that holds a dose is rotated into position. The patient then pushes a small lever to puncture the blister, and sucks the powder out of the device. The device is then closed. The device is used to deliver reasonably expensive medications, so be careful not to open and close it repeatedly. You would be wasting several days' worth of medication as the blisters rotate into, and then past, their turn to be punctured. Other devices require the patient to insert a capsule of powdered medication, which is then pierced when the patient compresses a button or lever on the device. The patient sucks the powder out in a similar fashion to that described previously. Intramuscular injections. Drug administration methods that require the patient to inhale the medication may become unreliable or ineffective when the patient's breathing effort is inadequate. Reduced tidal volume. In some circumstances, such as severe asthma or anaphylaxis, it may be beneficial to give intramuscular epinephrine. This medication is not as beta-2 specific as its aerosol cousins, and has many more systemic effects, but when the patient's airways are severely closed, it is sometimes needed. Direct instillation. While it is possible to administer some resuscitation medications through a tracheal tube, current guidelines discourage this practice. If an intravenous cannot be established, the intraosseous route is preferred for medication administration due to better predictability of delivery and pharmacologic effect. Only under exceptional circumstances, such as cardiac arrest, and where intravenous and intraosseous access are not possible, can the paramedic consider administration of select drugs via the tracheal tube as an option. The dose usually is 2 to 2.5 times the usual dose, because much of the drug sticks to the inside of the tracheal tube or drains onto the carina. Newer devices miss the drug into the tube, allowing this process to occur without interrupting cardiopulmonary resuscitation. Although research has shown that this is clearly an inferior delivery model for medications, it may be the only option during a resuscitation if all else fails. The paramedic should consult local and regional protocols to determine if the tracheal route is an option. Fast-acting bronchodilators. The most commonly used and fastest-acting bronchodilators work by stimulating the beta-2 receptors in the lungs, part of the sympathetic nervous system. These so-called rescue inhalers provide almost instant relief, a property that sometimes leads to their misuse. Present-day bronchodilators are beta-2 specific, meaning that they stimulate only beta-2 receptors without acting on other parts of the body, but many patients still use older, less specific medications. Salbutamol, Ventolin, which is currently the most common beta-2 agonist, is routinely given every 4 hours, but more frequent treatments, and even continuous therapy for hours at a time, are commonly used. Anticholinergics. In general, the sympathetic and parasympathetic nervous systems act as opposites. In terms of heart rate and bronchodilation, it is reasonable to think of them as the gas pedal. Sympathetic stimulation speeds up heart rate, beta-1, and produces bronchodilation, beta-2, and the brake, parasympathetic stimulation slows heart rate and causes bronchoconstriction. Anticholinergic medications block the parasympathetic response, so they are like taking the foot off the brake. Just as it is hard to drive your car if someone has constant pressure on the brake pedal, so you can see how bronchodilation can be enhanced by specifically blocking the bronchoconstriction mechanism. In the past, the strategy was to disperse atropine, the most common parasympathetic blocker, through an aerosol. Today, a medication is specifically designed for aerosol use, ipratropium. It is also available in a metered dose inhaler. The combination of salbutamol, beta-2 agonist, and ipratropium, anticholinergic, is also available as a pre-mixed cocktail, marketed as an aerosol or a metered dose inhaler. Anticholinergics have emerged as a very important component in the management of chronic obstructive pulmonary disease. Tiotropium, a once-a-day anticholinergic for this indication, is taken via a type of dry powder inhaler. Patients taking tiotropium would not typically also use aerosol ipratropium. Long-acting bronchodilators. Various bronchodilators exist that work by mechanisms other than beta-2 stimulation. Although most of these medications do not provide immediate relief of symptoms, if taken daily they can reduce the frequency and severity of asthma attacks. Patients who are used to the immediate change in their symptoms after using beta-2 agonists often report that these agents do not work, and have to be encouraged to take them as prescribed until they note the long-term benefits. Popular long-acting bronchodilators include salmeterol, Ceravent, and cromolyn, Intal, nasal crom. Such agents have dramatically improved the quality of life for many patients who have respiratory illness, and who use the drugs correctly. Leukotriene modifiers. Some patients with asthma release bronchoconstricting chemicals called leukotrienes. Such patients often benefit from a leukotriene blocker such as montelukast, singular, which is usually taken via a dry powder inhaler. Methylxanthines. Methylxanthines, which include aminophylline and theophylline, were once the mainstay of asthma and chronic obstructive pulmonary disease therapy. Their popularity has declined in recent years because their adverse effects, particularly cardiac effects, are significant and their monitoring is more onerous compared to the many new drugs available. Some patients who have long-term chronic obstructive pulmonary disease, however, still take aminophylline or theophylline. These drugs can be administered orally, in tablet form or in sprinkles that are placed in food. They can also be given intravenously. Overdose with these agents may cause cardiac dysrhythmias and hypotension, and the level of the drugs in the bloodstream must be closely monitored. Magnesium. Studies indicate that magnesium plays a role in bronchodilation. In moderate and severe asthma attacks, some physicians give 2 to 4 grams of magnesium sulfate intravenously over 15 to 20 minutes. Consult with direct medical control or follow local protocols regarding this therapy. Corticosteroids. Corticosteroids are used to reduce bronchial swelling, edema. Although these are not the anabolic corticosteroids that may be abused by athletes, the corticosteroids used in respiratory medicine do have a variety of adverse effects. Long-term corticosteroid use can cause Cushing syndrome, which is characterized by the classic moon face and generalized edema. Corticosteroids also make blood glucose go out of control, and can blunt the immune system, allowing any infections to flourish. Patients taking long-term corticosteroids such as prednisone must taper their use gradually. Because of these adverse effects with prolonged use, most patients are prescribed a short course of corticosteroid therapy that lasts 5 to 7 days with no taper. Inhaled corticosteroids. Fortunately, inhaled corticosteroids do not appear to have the same adverse effects as their oral counterparts. For that reason, inhaled corticosteroids are a mainstay of asthma treatment, and are common adjuncts to the treatment of chronic obstructive pulmonary disease. Reviewing the asthma triad, you can see how a slow-acting bronchodilator can reduce bronchial constriction, while an inhaled corticosteroid can reduce bronchial swelling. Intravenous corticosteroids. In an emergency, it is reasonably common to give corticosteroids intravenously. A single bolus of intravenous corticosteroids does not appear to cause any negative long-term consequences, and is reasonably safe. Methylprednisolone and hydrocortisone are both intravenous corticosteroid preparations given as an intravenous bolus, usually for acute asthma exacerbations. Corticosteroid administration in the setting of a chronic obstructive pulmonary disease exacerbation is reserved for patients who do not have an underlying respiratory infection, such as pneumonia. Their onset of action takes hours, so you will not see any results in the pre-hospital environment. As always, consult your local protocols and medical direction before administering these agents. Antitussives. Antitussives are designed to stop a cough. Coughs can be very annoying, particularly if they interrupt the patient's sleep. However, the need for comfort must be weighed against the need to get rid of excess secretions. Overuse of antitussives can sedate the patient, reduce respiratory drive, and cause excessive plugging of secretions. Many over-the-counter cough syrups also contain antihistamines that can cause problems if not used appropriately. Aerosol fentanyl is sometimes used to stop the severe coughing associated with tracheobronchial cancers. Diuretics. Diuretics are used to help reduce blood pressure and to maintain fluid balance in patients who have heart failure. Patients who present with pulmonary edema may benefit from diuretics to remove excess fluid from the circulation, which ultimately keeps it out of the lungs. Loop diuretics, such as furosemide, Lasix, are the most commonly used agents in emergent situations. Thiazide diuretics are also commonly taken orally to treat high blood pressure or heart failure. Many diuretics cause the patient to lose not only fluid, but also potassium. Patients who do not take their potassium supplements may have low potassium levels, and a subsequent predisposition to cardiac dysrhythmias and chronic muscle cramping. Do not give diuretics to patients who have pneumonia or to patients who are already dry. Try to reserve them for those who clearly have pulmonary edema. In fact, some EMS systems reserve furosemide, Lasix, on standing orders for patients with wet lungs and peripheral edema. Patients who have some degree of renal failure may require very large doses of diuretics, or they may be completely unresponsive to diuretics. If your patient requires dialysis for renal failure, trying to induce diuresis is unlikely to be an effective strategy. Vasodilators. Another common treatment of pulmonary edema is nitroglycerin. It is a strong vasodilator that reduces the cardiac preload and may rapidly improve pulmonary edema. Morphine, a strong narcotic, also reduces pain and anxiety, and may also help with vasodilation. It can be very helpful in the scenario of respiratory distress. Too much morphine, however, can decrease respiratory drive and cause blood pressure to drop. Use morphine carefully, titrating it based on blood pressure and respiratory status.